Rishikesh. Every time you just do balancing with only cutting the bones or do both things simultaneously, soft tissue release and that component position changing. Some of your graphs show the quite good number of variation, very much tightness in sometime in medial side, very much laxity on lateral side, severe varus cases. In that case, what do you do?
See, if there is a varus knee,
Yeah.
I always balance the lateral side in extension and flexion.
Okay.
I know the varus deformities, all the deformities, they are contributed by not only the bony but also the soft tissues. So in varus knee, I balance the lateral side, and the medial side, I remove all the osteophytes and release the deep MCL, and that balances the medial side. Superficial MCL release, it's not there now. At most, what we do is a pack resting of the superficial MCL and nothing more than that. In even more severe deformities, my study shows that we are doing one study, and it shows that up to 8 degrees of varus, no release is required. You can come out with CR knee. From 8 degrees to 16 degrees varus, if you remove the deep MCL and PCL, you can balance it. If it is more than 16 degrees, you require pack resting of the superficial MCL in addition to deep MCL release and PCL release. So that is the way to balance the varus knee. Exactly opposite on the valgus knee. Whenever there is a valgus knee, I balance the medial side, and lateral side you need release of the soft tissues. So that is the way to balance the knee with the...
That is after graph representation or before graph representation? When your graph show very much tightness on medial side and lateral side, then how much tightness you will accept before execution of your plan?
That is what I am telling you. With the graph, I balance the opposite side, and the release I do after that, and again check it on the graph.
Okay. Thank you.
Thanks, Rishikesh. I would now like to invite Dr. Adarsh, CT-based robotic system.
A very good morning to everyone. I would like to thank Narendra Vaidya sir for inviting me here, and it's a wonderful initiative to get all these systems onto one platform. I feel like an outsider, not because I'm from Hyderabad, because I'm doing Maco, which is very few. So yeah, today I'll be speaking about the CT-based robotic system. So as we all know, for any robotic or computer-assisted surgical system, it's imperative that we feed the computer some anatomical data from the patient, so that it knows in real time where the anatomical parts are in comparison to the saw. So this is called as mapping of the landmarks, and the mapping is done intraoperatively, which can be corroborated with pre-op imaging, or it can be independent of the imaging, depending on which system we're using. So we need to teach the system multiple things: the anatomical landmarks like the hip center, medial lateral malleoli, and the epicondyles. Then we have to do the bone registration. This information, as I mentioned, can come from image-based or imageless. The image-based can rely either on a CT scan, MRI scan, or an X-ray. Imageless relies only on the intraoperative input. So the Maco, which we do in Sunshine in Hyderabad, is a completely CT image-based robot. So as I said, the classification of the robotic systems, depending on what kind of pre-op imaging is there, is either image-based or imageless. So if these are the 5 major robots right now being used. So you just see the Maco is a CT-based. The ROSA, you can have an option of using imageless or MRI or an X-ray. You can use any of the 3. The Smith & Nephew and the Navio Cori is imageless. The Cubis, the Medial Cubis is CT-based. And now the Depu Velis robot is also imageless. Just a few differences between the two. So as I mentioned earlier, the image-based is CT, MRI or X-ray. And you have a 3D model of the knee available before the hand. Just before you go into the OT, you can just run through everything. But there's no such 3D model available in the imageless. Pre-op planning is possible in image-based, not possible in imageless. The bony point registration is to be done inter-op. In the imageless, you need to completely map everything out. So in the image-based, you're just doing the registration with the points. You don't have to actually paint the whole thing out. And only few points are required in each bone, like 40 points in the femur and 40 points in the tibia. But extensive painting has to be done for the imageless. You have to reach till the back of the condyles as well. And image-based is a little bit more reproducible, but imageless depends on the accuracy and the skill of the surgeon. And it can have a bit of human error. So I'm talking about the Maco today in CT-based. If you see the Maco TCare workflow, the pre-op planning and the patient bone registration are the two important steps that I will be speaking about in this talk. So see this video, I've compiled the videos for TCAR, partial knee and total hip. First a CT scan is taken a day in advance of the surgery. All the segments are taken and they're taken by something known as the Maco product specialist. What they do is they take each and every film and they start segmenting and they create a 3D model of the knee or the hip depending on what surgery you're doing. So this is the first bit of advantage that we get. Then we can start planning preoperatively, whether you want to use a 5 size or a 4 size femur, tibia, same thing with the partial and with the hip as well. It's the first bit of information we get. The hip even tells you if you have any shortening or lengthening compared to the other side, which I'll be speaking tomorrow in the hip talk. After you've done all this, then you go intraoperatively and then you have to start registering points on the bone. If with the TCAR, the femur and the tibia, both the condyles. In the partial, just the medial condyles. And in the femur, in the hip, the femur as well as the acetabulum. You start registering points and making sure that they are matching to the CT scan. After you've done that, you get this verification step where you again reconfirm. Only if your accuracy is less than 0.5 millimeters matching to your CT scan will it allow you to go forward. So that is a fail-safe mechanism to prevent any untoward incidents. Only after you've done this can you start removing your bone either with a saw, with a burr in partial knee or with your reamer in total hip. So what is this bone registration that we keep talking about? It's a process by which the CT-based model is mapped onto the patient's bones. So you get a CT scan, the segmentation is done. Then in the 3D model, the product specialist, he starts to map out the anatomical landmarks like the center of the hip, the center of the knee and the center of the ankle. The same thing is mapped intraoperatively as well. And once the two are overlapped, then you can go ahead with the procedure. So the first is the major patient landmarks, center of hip, center of knee, center of ankle. Then you go to your minor fine registration points. So next, behind the scenes, what does the Maco product specialist do? This is all he does before you even enter the operation theater. He does all this work 1 day prior. I want to show you how accurate this can be. So the first thing he does is gets a CT load. This page shows the CT scan over the 3 regions, the hip, knee and ankle. It also helps to reconfirm the patient's name and the operative site. Next, he has to mark out all the CT landmarks. So you have multiple landmarks in the femur and the tibia, which I'll explain a little bit more. With all these landmarks, we get all these, the robot learns about the patient's mechanical axis, the transepicondylar axis, the femur mediolateral axis, and the femur AP axis, with the help of all these points that the product specialist has entered. So the first thing is he does the hip center. Mind you, every single point that he is marking is taken on all 3 planes, so that there is no chance of any error. All the 3 coronal, sagittal, and the axial planes, and you make sure that you get the dead center in the hip. Then the knee center is taken at the most distal point of the trochlear groove. Medial epicondyle at the sulcus, the lateral epicondyle at the proudest point, and then on the tibia, you get the medial and lateral malleoli, and of course the rotational landmarks. The same way that we see the rotation in the conventional, we actually mark it out over here, the medial third of the tibial tuberosity to the footprint of the PCL. The knee center is also taken. Again, I mentioned all the 3 views to make sure that it is very, very accurate. Now the MPS usually does this beforehand, but if you have any doubts, you can also check it on your own. Then the resection landmarks are also determined, and then you go for your implant planning page. In Maco THR, you have 24 CT landmarks, and this helps to avoid any malposition on the CT table. It's taken care of by these markings. In the acetabulum, you have the 3 main points: center of rotation, posterior acetabulum, and the anterior acetabulum. So the robot knows the orientation of the patient. In the femur, the lesser trochanter is the most important point that we mark, so that it gives us the length calculation as well. Okay. So what are the advantages of this image-based robots? You have the accuracy of the bone registration, you understand the pathology and the location of the osteophytes, bone defects, you can do accurate sizing, now you can actually shape match the femur and the posterior condylar offset. All these things can be done now. If you see a comparison between the CT-based and the imageless, the bony landmarks, the surgeon has to physically locate these in the imageless, but here in the CT scan-based, we are just matching to what is already there. There are a few papers showing that there can be a human error in the imageless navigation and the imageless robotics, but though it is very low, it's much less in the CT-based ones. The bone registration itself, here, as I said, in the CT-based, it's just point registration. In imageless, you have to paint it out just to show you the comparative videos. On the top, you have the Navio, where you're actually painting out the whole femur. And in the bottom, you already have the CT scan. This is the 3D model of the patient. We just have to reconfirm with the 40 points the bony registration. The accuracy of sizing, this is a paper by Sebastian Lustig, which showed much more reproducibility in terms of femoral posterior offset, tibial sizing, and femoral sizing in the Maco. Enhanced planning, as I mentioned, just another 2-3 slides. You can see where the defects are. You can plan whether your offset is matching or not. And you can also move your implants around 6 degrees of freedom even before you enter the procedure. Disadvantages, of course, there's the whole thought about the CT scan radiation, but the papers have found that it's hardly 2.7 MSV, which is even less than a CT chest. And what about the cost? Yes, they do say this is a nice paper which compares patient-specific, navigation, imageless and image-based robotics. What about the time? The time taken in image-based is even less than the time taken for the imageless because of the painting. But the cost definitely is more for image-based compared to imageless, including the CT scan cost as well. So in conclusion, this particular paper shows that the accuracy of these CT-based are very, very close to post-operative CT scans which were taken to just confirm. And this showed that the accuracy is within 2 degrees of variation from the post-op CT scans as well. Thank you.
Any question from the audience?
Dr. Srikanth from SOC Bangalore. Adarsh, good presentation. Just one question to you, not from you, but I listened to your dad, Dr. Guruvareddy sir, talk. He says Maco is good for UKR, but not so good for TKR. What is your thoughts on that?
I don't think he meant that. He said what we think when we were getting introduced to robotics, we were not very convinced about TKRs because we had great results. But when we saw the uni, that's when we decided that this definitely should be it. So he says that if you want to do uni, you should do it with a robot. But with TKRs also, we are finding much better outcomes and faster improvement in pain, faster rehabilitation as well. So we are definitely finding good outcomes with the total knee as well.
Anywhere Maco should improve for TKR? Any limitations that you've seen with Maco and TKR in particular?
Sorry, I didn't get the question.
Any limitations of Maco and TKR
At the
compared
moment,
to UKR?
no. We're not able to, we haven't figured out a way to do revisions yet. But we are using the robot for severe varus, for valgus deformities, FFDs. So we're able to use it for many different procedures as well. So not many limitations at all.
Thank you.
Yeah. Thank you.
Adarsh, the planning is done by someone and the surgery is executed by someone. So how the two brains
So the
match?
planning is not done by the MPS. These are only the default things that he brings to the table. We still have to sit and do the planning beforehand. Now, nowadays we are so used to their what they are doing that we kind of take it for granted and do the planning intraoperatively itself. But earlier we used to sit with them for at least 15 minutes for every case and make sure that everything is matching or not. So they only give you the default landmarks and the planning is done by us.
And how long it takes to mark those 40 points?
It used to take a while when we were getting used to it, but now it takes less than like 1.5 minutes.
So
less than a minute.
mapping with Corey and these points, I think they take the same time, I think.
Probably, right? I guess when you get used to it, they kind of get time neutral.
So let's move on to the next
Thank
talk by Dr. Upasani. It's about imageless handheld robotic system.
Good morning, and thank you, Dr. Vaidya, to give me this chance to speak to this august audience. So we just saw a CT-based robot. Before I start my topic, just some small trivia. The term robot came from the Czech word robota, meaning forced labor or activity. And in 1920, Karel Čapek, a Czech playwright, wrote a science fiction play called Rozum's Universal Robots, where robots were a series of factory-manufactured artificial people that undertook ordinary tasks for their human masters. So it was like for ordinary tasks. So I felt it really funny. And the first robotic surgery was performed in 1988, which was for neurosurgical biopsies. And today in 2022, we have a lot of robotic systems and we're discussing about that. Now, what do we mean by an imageless system? So we saw a CT-based system, and I believe you saw the presentation earlier where somebody else is planning and somebody else is executing. So in imageless system, you don't need to do any pre-op CT or any MRI, but that means that you're doing some intra-op mapping of the patient's bones, also of the alignment, and giving the information during the surgery. So imageless system is totally surgeon dependent. And I believe as a surgeon, you would like to be in control of the whole system, of the whole surgery, and the main person who is doing the surgery, and not a technician telling you what to do. So, surgeon-controlled handheld intelligence for modern robotic approach. It's image-free smart mapping, real-time planning and gap assessment, and optimized alignment and balance. And of course, you can see that's the Cori system from Smith & Nephew. It has got a faster, swifter, and precise checkpoint registration. Also, the camera is very fast, almost 500% faster than the old one. So you hardly take a minute or two to finish off with your registration. So smarter image-free mapping, handheld robotic system allows surgeon to control and map the femur and tibia precisely in real time. So you have to give the information as a surgeon to the robot, whatever you feel is necessary. So it's as per the surgeon's preference. You want the transepicondylar axis, you want the posterior condylar axis, you want the white sides line, whatever preference you have as a surgeon for your rotation, whatever extra you want to give, you can give to the robot and then decide and make a plan as per your preferences. So significance of an image-free robotic system, it's a real-time imaging in the OR. So it eliminates time cost. It also reduces radiation exposure because there's no need of a pre-op CT imaging. Eliminates pre-op logistics of surgeon and staff because you see in a CT or a CT-guided robotic system, you are spending almost more time outside the OT rather than inside the OT. And as a surgeon, I believe we would rather spend more time in the OT rather than spending time outside the OT like a radiologist in the CT room. With the state-of-the-art software, intraoperative 3D model is created based on patient's anatomy. And real-time fast gap assessment with precise implant planning. So these are the advantages of an image-free robotic system. Now, enhanced robotic knee workflow. So this is a portable handheld robotic system which has one of the smallest footprints in orthopedic systems today. It's got improved ergonomics, delivers 2x fast cutting volume, 29% faster resection, 2x longer throw for easier posterior resection, and a pistol grip for a more natural hand position. And that's, I would say, a progression from the old system, which helps. It's very much ergonomic for the surgeon. You can use the burr for a longer time without getting cramps in your hands. So benefits of a handheld robotic system. So you can see that this has got so it has got a 180-degree rotating array, so that increases the visibility of your handheld robotic system. There is a dedicated suction for high visibility, so whenever you're burring, the bone dust doesn't come in way of your visibility. There is an integrated irrigation system, so you can keep the temperature of the bone low and there is no bone necrosis while you're burring the bone. It is much more efficient from what it was earlier. There is an integrated soft tissue balancing software. And you did see Dr. Rishikesh Saraf's videos where he had shown how he's balancing his system. So with this system, I say you can do intelligent alignment. And that is as per what you think is right for the patient and the way your philosophy of aligning the knee is. See, because what is perfect, I don't think we have still reached that thing about what is a perfect total knee replacement. And I believe it varies from a patient to patient. You can't just make a generalization that this is the perfect thing for every knee that you're operating. And this robotic system gives you this modularity of changing the implant size, changing the position of the implant. It also gives you an idea of how much release you want to do. And all this is real time. So it's not done anything pre-op, it's all during the surgery. It makes you think faster, makes you think what you want to do and what you want to achieve. So that is why I said this system gives you an intelligent alignment, a mix of whatever you want, a gap balancing system, or you're a measured resection guy, whatever is your surgeon preference. There is more efficient resection of bones, cuts more in less time. There is a milling technique, and there are different techniques which you can use with this system. All burr requires much fewer instruments. Now, this is the comparison of all the available robots. That's the Maco robotic system where you need a CT guided, you need to make a 3D model. So you make a 3D model, again, during surgery, you need to again point those pointers of the CT. So I think you are wasting quite a bit of time, pre-op, intra-op also. Then cutting is done with the saw. It's a non-mobile huge console. Navio or Cori handheld robotic system, it's a compact design. 10-second calibration, that's it takes during the surgery. It's a fast process. It's completely surgeon controlled. And that is what I feel is very important for us as surgeons. It's up to you what you want to do and how much time, where you want to spend. It's image-free, real-time planning, easily portable from OT to OT, or rather from a facility to another facility also. ROSA, again, CT landmark calibration, or calibrated X-rays for intraoperative planning based on 2D to 3D X-ray planning, CT-based system, non-mobile huge console, and a technician is required. QVIS robotic system, again CT-guided 3D image, pre-op planning, bone motion monitor function detect intra-op patient bone movement, so there is something which detects the movement of the bone, and if there something goes wrong, the whole surgery can go wrong. Saw and selected region automatic cutting, tracker array attached to OT table, movement may cause interference with planning, non-mobile, huge console, and technician required. So I believe of all the systems, the handheld image-free one is a totally surgeon-centric, without a technician system, and I believe it gives you a lot of room for doing a lot of things as per your preference. So it's a portable cart from OR to OR. It's got a transportation case which you can move from one hospital to the other also. Thank you.
Thanks, Tejas. Anyone? Any question for Tejas? Yeah.
Yeah, I just wanted to ask, apart from the errors which involve the saw, that is the skiving errors and the slot of the jig errors, is there any actual advantage or improvement over the older brain lab computer assisted surgery?
I think it is a totally different thing from navigation, because navigation you are putting in the pins on a jig and then cutting with the saw and then again rechecking. Here the execution part is done with your handheld device, which is a burr, and you're burring the bone off. So if it depends on what you want to do, you have an option of all burr, you have an option of doing a part burr, part saw. It depends on which workflow you are comfortable with, but it's much more than navigation. I feel people feel this is still just one step ahead of navigation, but it is totally different, because your execution part, so you've done your planning, your execution part is done with your handheld device, and you can recheck the cut and it will be as accurate. Whatever you had planned, it's going to be the same cut. So with navigation, when you're using a saw, you tend, as we all have seen, if it's a real hard bone, the saw blade tends to skewer, and you tend to cut less bone. But when you're using this burr-based system, the cut will be exactly what you had planned. Okay, and it's again based on colors. You can see how much bone needs to be removed and what you need to achieve white color, which is what you had planned. And once you've done your cuts, if you verify, it is exactly what cut you had planned for.
Does the
so you save time over here.
Does the errors of mapping the medial and lateral epicondyle in navigation still exist here in the
I didn't get your question.
When we used to map the medial and lateral epicondyle in navigation, there will be some error if you take 100 cases. So that error is still here in Cori, or is that circumvented?
So mapping will depend on how you are doing the registration. So if I believe you're used to, if you're doing navigation before you started doing robotic, I don't think there will be an issue with mapping. It's one of the most simplest thing, and it hardly takes a minute or two to finish off with the mapping.
Okay.
Rather, I feel it with imageless, because you don't have to map certain points. It's like a brush, you're just painting the whole of the femur.
Dr. Vaidya want to speak something.
I have one or two comments in addition to what Tejas is saying. Many of the robots are working within the haptic control boundary, which was not there in navigation at all.
Yeah.
Okay, so that error and within the haptic control, and that can be either sound based, or there are various systems with the robots, that's a major advantage, haptic boundaries. Number two, the point which we are discussing right now, that was regarding what?
He's saying error of registering the femoral
See,
contact.
the system has got certain, Corey I have used extensively, it has got certain intelligence. So, it's not an artificial intelligence as yet, they are developing towards that. But, you know, if you try to, you know, register a point, I'll demonstrate that during my surgery, which is far away from the original whatever epicondylar region, and you mark the region, not the point. So, it calculates actually what is the exact point.
Okay.
Okay, so the systems have got certain region and you know, map entire surface. So when you are, for example, doing a unicompartmental, not only the distal part of the femur or the posterior is marked, it is mapped on the surface and the system has got certain intelligence which will calculate those points, which in navigation is not possible, yes. They are only points.
So robotics add more information to the original anatomy by mapping it the whole.
Thank you.
Thanks, Tejas.
Okay, thank you.
Now we'll shift to fully automated robotic system. Dr. Neeraj.
Good morning, everyone. At the outset, I'd like to thank Dr. Narendra Vaidya, Lokmanya Hospitals for having me here. I never knew this was a debate session. I initially thought it was just a plain, simple philosophy session and just talk about your own system and, you know, brief the audience regarding the benefits. So, so robots, there is slight repetition in what Tejas has already mentioned. So this word comes from a Czech word robota, meaning force, labor or activity. And robots are in use in many industries and they are known or used where you need precision, productivity and efficacy. First robo was used for neurosurgical biopsy in 1988 and same robo with some modification was used for TURP, prostate surgery in 1991. Subsequently, many robos came in picture for various general surgical work and subsequently in orthopedic for TJA. Imperial College London developed this Acrobot in early 1990s and Robotic was developed by Think Surgical California. So imageless systems we have, Lee Smith and nephew Corey Nevio and some of them are image based. Cubis from Curexo, Maco and Rosa from Zimmer. But Cubis is only fully automated system in use currently for total knee replacement and they also have now software for partial knee replacement. So Cubis system needs a pre-op CT scan and where pre-op planning is done, it takes around 10 minutes only. And it is not done by technician. I mean, they do those auto segmentation and then you go through the plan, you go through a couple of slides and plan it. And as I said, it just takes 8 to 10 minutes. And the distinct advantages of this CT planning as it is applicable in Maco as well, that you come to know regarding various fine, you know, landmarks and you can identify these landmarks, center of the femoral head, center of the knee, ankle, and so precisely because imageless system you never know what is the size of the head, you don't know the neck shaft angle, you don't know the anteversion, how you locate the femoral head center, that is a big question. I'm not here to debate, all systems they have their positives and negatives and whatever system is good for your working in your hand, some technology is required here, okay, for arthroplasty, that should be the take home message. I mean, it's your call which system you opt for. And once all these landmarks are identified at the end of the planning, you get this picture where you know how much distal medial you are going to resect, distal lateral you are going to resect, posteromedial, posterolateral. This resection is guided by size of the implant because that is going to define your posterior condylar offset. And similarly, you know the posterior slope and resection on the medial and the lateral side of the tibia. And once you have this information, you save it on your laptop that is fed to the robo. And this robo preparation or registration goes on simultaneously when anesthesia work is going on. And this calibration is done for each and every case separately. Once the basic calibration or registration preparation is done, then robo is ready. These points are identified on bone, which takes around 10 minutes, around 8 to 10 minutes for registration. And once all these points are identified and you are happy with the gap check, then you can proceed with the resection. This is how it appears on the screen. And this is distal femoral cut. This is completely automated robotic system, and this is highly precise. So here there are two way, one is CT planning and other is intra-op. So it is completely controlled by surgeon. And once you are okay with gap checks, everything, then only you proceed with the resection. And the resection takes around 10 to 12 minutes. And consistently we are able to complete all the resection before we proceed with the final implantation in around 30 minutes time. So my staff is also happy, sir, isme thoda sa kam, get less fatigue and less tired, because they just stand and watch the system work, and it is absolutely comfortable for everyone, including the surgeon, and that's the end result you get. So couple of patients I'd like to share pre-op and post-op, and another patient with severe deformities also. So in afternoon talk I'm going to share couple of cases more. So friends, our experience, there is definitely learning curve around 8 to 10 cases. It is precise system. Most of the cases we ended with 9 or 11 poly. That's what any arthroplasty surgeon would desire. Less drain, pain, and shorter hospital stay. So do you still doubt active robotics existence? Thank you very much.
Thanks, Dr. Neeraj. Any questions for him?
I don't have a question, but just I have done some 2 cases only as this thing on QVIS, and would like to share to the previous question also somebody asked, and a difference between robotics and the navigation. Now in QVIS also, it leaves a rim of bone once it cuts, and that adds to the safety. So various robotic systems have their own philosophies to protect the soft tissues or vascular structures around. So QVIS also leaves a thin rim around the tibial base plate or the femur, and that protects the ligaments and soft tissues.
Nice information.
Yeah, my question to Dr. Neeraj, if everything is pre-planned, everything is before surgery is planned, everything balancing, gap, alignment, everything, then what surgeon will do? Whether soft tissue release is required per op or not. If suppose it is required, then how much? Then it will change your previous plan or not?
Okay, so what we plan on CT scan, it is for the bone resection. That is not gap check.
Okay.
Gap check is checked intraoperatively, because CT image will provide you regarding the bone component alignment and the resection what is required. But intraoperatively, based on the soft tissue condition which guides the gap check, you modify the plan. But once you learn and after a couple of cases, this varus, so I need to external rotate this much, or resection is required posteromedially this. So you can minimize the intraoperative modification as you use it more and more. So there should not be confusion. The pre-op planning is for bone resection, gap check is checked intraoperatively. And that you can still modify your plan intra-op to minimize soft tissue releases. So all robotic systems essentially guide the correction. We are moving away from what we were taught is total knee replacement is a soft tissue surgery and releases, and you balance the knee with soft tissue releases. We are moving away from that, and the bone resection is taking care of minimizing the soft tissue releases, which really helps in post-operative pain management and reducing the post-operative pain.
How much you leave on soft tissue release? How much tightness you will accept pre-operative? You are planning.
No, it is not planning. So pre-operatively it is bone. So
only
bone
just bone resection.
Yes, and intraoperatively the other part of your question is around 10% cases we need soft tissue releases. Till now we have operated on 450 odd cases. So, and consistently soft tissue releases we require in minimal, less number of patients. That's our observation.
But in that case, your bone cut will be more.
Pardon?
In that case, suppose you release soft tissue less, then your bone cut will be little bit more. So it's not possible.
See, soft tissue releases are done maybe after the resection to balance the knee. Okay?
Okay.
And once we confirm that it is balanced in flexion and extension, then only go for final implantation.
It doesn't mean that we will take more extra cut. Whatever robotic
Yes.
or technology you use, it doesn't mean ki extra cut to balance the soft tissue. The cuts will be in the limited range only. It won't be like 20 mm or 15 mm. It will be still 5, 7 mm. And then you have to decide how much of osteophytes are still there in your x-rays and how much release you need. So it works both hand in hand.
Oh, okay.
And you have the cross check after you cut. After you cut and you put your check, then it shows that you are still tight medially, then you sequentially release the ligaments. Not over release is done.
Yes.
Okay, one question, Neeraj. Standard what knees you shown, the very bad varus with a large posterior-medial osteophyte. We have seen that. Once we remove that posterior-medial osteophyte, suddenly the posterior gaps opens up. So how do you manage that with the bony cuts, intra-op, like how do you assess that? Because we have seen that all the time. If the posterior large osteophyte and it suddenly opens up, so how do you tackle that beforehand and anticipate?
That is one more, advantage of this CT-based system where you come to know regarding these large osteophytes which are not seen on imageless systems. On X-ray, sometimes they are not visible. So if there are large osteophytes, we tend to keep slightly, while doing the gap check, maybe a millimeter or 2 millimeter tight on the medial side.
Okay.
We expect opening of the joint once we remove the osteophytes. So we don't match the gap while doing the before pre-resection planning. So we keep it slightly tight on the medial side, and there are large osteophytes, and invariably it opens out once we remove the osteophytes, and that really helps. So you learn it over the, as you
I do the same thing.
This.
For the same thing, I do 2 millimeter less,
Yes.
2 millimeter cut less. So
Yes.
at least you have 2 millimeter less gap on the medial side, so it opens up
So
there.
it's little tight planning.
Tighter planning, yeah. Okay,
Yes.
thank you.
Sir, one more question, sir. Sir just asked about a large posterior osteophyte. In the case which you showed, the patient had a very large varus. So there would be a lot of posteromedial bone loss. How do you take that into consideration before?
So posteromedial bone loss, if it is there, then on CT image, you come to know you are going to resect, say, 0.3, 0.4 mm on the medial side and 5 or 6 millimeter or 7 millimeter on the lateral side. That image pre-op planning really helps in such cases. And we keep the resection to minimum. Maybe in severe deformities, we have option of going for extension surface where we resect only distal femur and upper tibia and then check the extension gap. And again, we can modify our plan, okay, intraoperatively. And if the defect is too much, we can go for bone grafting and or augments there and extension stem. A couple of cases I will be sharing in the afternoon session with severe deformities.
Sir, any specific changes in planning for cruciate retaining knee replacement while you are using this kind of a robotic?
Honestly, I don't have any experience of CR. I'm a PS guy. So, but in severe deformities, as I think it was discussed earlier, but CR, couple of surgeons are doing or using this system routinely, and they are not
I'm
having
asking about any
issue.
specific changes of planning while you are preparing for the CR.
Sorry, I don't have any experience regarding that.
Excuse me, sir. We are running out of time, so we can ask our question in next session, if you don't mind.
So now
Thank you so
we
much, sir.
move on to the next lecture by Dr. Patel. It's about imageless robotic system with saw blade. Dr. Patel.
Good morning, everyone. I am thankful to Lokmanya Hospital and Dr. Narendra Vidya sir for inviting me for this talk on imageless robotic system with saw blade. In this era of technology, robotic knee replacement is the future. Why robotics? To patient, it gives personalized care with real-time intra-op data, potential for faster recovery. To surgeries, it gives higher accuracy and gives objective and quantifiable data. To hospital, It gives potential to increase the patient flow and a scope to marketing. There are a number of systems which has been discussed previously. There are a number of robotic assisted systems which use different technique and image. Most of them use milling, cutting guide, saw, burring, and image, CT scan based, X-ray based, and image-less options are available. The comparison between image-based and image-less robotic system has been discussed previously. I would discuss the workflow of the image-less case. There is no pre-operative planning is required. The patient, the day patient is posted, the case is registered in the robotic system. In the OR setup, there is an option to position the robot on same side and the opposite side. Even surgeon can stand on the same side and the opposite side. There is the surgeon, as per the preference, can select the protocol of PCA, TEA, AP axis, knee soft tissue assessment, and femoral rotation tool. This all protocol as per surgeon choice can be implemented. Once the OR setup is done, incision and trackers are installed. Once the incision and trackers are installed, femoral landmarking and tibial landmarking are done. This is a short video where landmarking are done. This is surface mapping. There are around 17 registration points, which would take around 30 to 40 in total points, and it takes around 2 to 3 minutes to register the case. Once the surface landmarking is done, the soft tissue assessment of ligament laxity can be done. The screen would, the soft tissue screen would be looking like this, which would show the degree of deformity, how much virus is there, what is the amount of flexion extension, and the different degrees of laxity in different knee flexions. And the final side would be the extension and flexion gap on medial and lateral side. After input of this all data, you will get a planning screen for the imageless case. The planning screen would show resection in extension and flexion. We can, in this planning screen, change the resection by increasing and decreasing the femoral resection, or increasing and decreasing the tibial resection, and changing the posterior slope of the tibia. In flexion, we can upsize or downsize the femur, we can change the stylus height, and we can even change the tibial resection. So this is the planning screen. The planning screen goal is like you balance on one side. It is not necessary to chase the numbers. Once you balance on one side, opposite side you can always do the soft tissue release. After the finalization of the planning screen, the resection screen is available, where you can give the command to robot, where you are having the option to cut femur first or tibia first. This is a small video which shows the resection process. Here in this case, we have gone for the distal femur first. The robotic arm comes at the resection level as per the adjustment done in the planning screen. It is fixed to the bone with the pins. We can use 1 pin or 2 pins or 3 pins. 1 pin is also adequate. As in the conventional case, we can even recheck with the stylus. It is not mandatory. We can look the numbers at the screen also. We cut the bone as in conventional case with the saw. Once the distal femur is cut, we can validate the cuts with the validation tool. After taking the distal cut, we can take the proximal tibia or 4-in-1 cutting block. Both options are available. If you want to go with the checking of the extension gap, we can go with the tibia. In this case, we are going with 4-in-1 cutting block. It is fixed to the bone with the the pins are inserted. After removal of the pin, you have like a conventional cut 4-in-1 block, which is to be placed in the pinholes. In this case, we are using this this cutting block, and the conventional cuts are taken with the saw. Once all cuts are taken of the distal of the femur, we can direct the robot to go for the tibial resection. The jig is fixed with the pins. simultaneously we can check the amount of resection which would be done. Once the tibial resection is done, a validation tool is available to check the amount of resection done. This is the stage where we can check the flexion and extension gap, both. Here we can remove the robotic arm, keeping the pin in situ in this system, where if in case if it is required, we can do the recut also, and we need not go to robot back. After putting the trial implant, the flexion and the flexion and extension gap balancing is checked. Such final evaluation screen is available. The imageless case with saw blade, the procedure particular is centered around the surgeon. The soft tissue and ligament balancings are quantified. The surgeon maintains the control. The saw remains in the surgeon hand. Use of cutting guides and collaborative mode, and it is practically very fast. The image-free options, no CT is required, and so radiation is less. The procedure is simple, and the workflow is same as conventional surgery, and so learning curve is very less. Thank you.
Thanks, Dr. Patel. There is some change in the program. We'll again have Dr. David with us. Any questions for Dr. Patel?
Any advantage over CAS Brain Lab Kick 3 surgical technique of this over Kick 3? Because I did not find any advantage except the...
Dr. Patel,
yeah.
Question for you.
By listening to your talk, I found an advantage over CAS, something like Brain Lab. The only difference was the block was not moving because the block is under the control of robo. That is the only advantage I found. Is there any other advantage compared to Brain Lab Kick 3 surgical technique?
To the comparison to the Brain Lab, for one thing is the soft tissue assessment is easily available in this case, and second thing is no zig placement is required. Here the robotic arm would place the zig to the bone. We can fix the zig. The advantage again going back is the pins, that the pins are of the conventional zig also, zig only. In case if we want to revisit the cuts, we can just go back, put the pins back and do the recut with conventional jig also.
Okay. What do you find the soft tissue balance easy more than Brain Lab the system?
The soft tissue data is available in all different flexion and extension. That is available in Brain Lab also, but it is available, and the positioning of jig is done through the robotic arm.
Yeah,
the main advantage is that.
Yeah, that's what.
You need to have a learning curve to have a triangulation in matching the zig to the plane, and that may take some time. Here it would not take that time, and the precision would be perfect.
Yeah, just for the sake of that benefit, the cost versus benefit, did you find any balance over the cost and benefit? See, just for the sake of one benefit over the Brain Lab system.
Right.
Well, I'm happy to be back, and we'll talk about implant design and how this relates to robotic surgery. I've really enjoyed the discussion at this point and how all of us have approached these same problems of registration, planning, and bone preparation with different technologies. So my disclosures haven't changed, but I would also disclose that I'm 54 years old and I have an arthritic knee and I still have my ACL. So I got involved in designing the Journey implant in 2004, and I wanted to make an implant that I wanted to have in my own body. So we'll talk about the Journey 2 implant and how Corey is used to put these implants in place. I surf, all my patients surf, and surfing is a big test for a total knee. You have to bend the knee to 145 degrees or 150 degrees to pop up on the surfboard. The knee must be perfectly stable in mid-flexion. 30 to 90 degrees is where we are most of the time, and you want to retain proprioception for difficult maneuvers like riding a barrel. You can't do this with traditional implants. It's just not possible. We talked about how this flat joint line really is not anatomic. The normal joint line is oblique, and that is necessary for normal ligament tension. The IB2 design and every total knee design on the market keeps your femur posterior on the tibia. And this is intentional to enable deep flexion, but it puts your quadriceps at a disadvantage, so you never get great quad control. And then if you have a CR knee, that you have this paradoxical motion where the femur slides anterior as you go in and out of flexion, and that doesn't feel very good when you're doing high-level activities. Or if you have a PS-type knee, the femur is locked in this posterior position, so you never get great quad function, again, necessary for sports. So if we use nature as an inspiration, and the dolphin's fin was an inspiration for the surfboard fins on the thrusters, we did the same for the total knee. And in the early 2000s, we got a lot more information available to us by collating CT scans, MRIs. We could do virtual MTS testing. We can incorporate ligament function. And the goal is to make an anatomic knee implant that restores pre-arthritic joint shape and alignment with the goal of preserving all of the ligaments in the knee. And it's a family of implants. So the first implant design was a bicruciate substituting total knee. Then we added a CR type, and then the XR is the bicruciate sparing design, and we also included unis and PFJs in the whole family. So any implant you use, you should understand the design philosophy. And basically with the Journey 2 knee, you want to make balanced flexion and extension gaps that are 19 millimeters. And these cuts on the distal femur and proximal tibia are going to be perpendicular to the mechanical axis, and then we externally rotate our cuts so we get parallel boxes in flexion and extension. So you have these rectangular gaps, and this is pretty typical of how we do our total knees. What's unique about the implant is that it's thinner medially and thicker laterally. And this helps restore the oblique joint line. And the femur, again, is thicker medially and thinner laterally. So this helps your ligament tension tremendously. And this is what we are trying to do with kinematic alignment, where we're adding valgus to the femur and adding varus to the tibia. But this ends up internally rotating your femoral component and does weird things to your patellofemoral tracking. So I think it's hard to achieve this goal routinely and get good function. So the femur matches the anatomic contours. It's a different radius of curvature medially than laterally, just like a normal knee. The tibia component is concave medially and convex laterally like a normal knee. And this helps normalize ligament tension and also helps drive posterolateral rotation, normal kinematics as you go into flexion. So this is a complex graph, but worth digging into. The blue line is the MCL tension. So it's tighter in extension than in flexion. The orange is the Journey 2 MCL tension. So it parallels the joint line, and the MCL gets looser as you go into flexion. With the traditional implant that you have this flat joint line, the MCL just gets tighter and tighter as you go into flexion. So if you want your knee to bend 135, 145, you have to put it in a little bit loose. This becomes a big problem on the lateral side. The LCL strain, again, tighter in extension, looser in flexion. Journey 2 matches native. But with a standard knee implant, you're very loose the whole way through. And if you put it in extra loose so your MCL is not too tight, then the knee feels very sloppy. And this is a major reason for revision of mid-flexion instability, and why 30% of patients don't like their total knee. So the Journey 2 knee gives you this oblique joint line, so it reproduces that oblique anatomy, and also keeps your femur anterior where it's supposed to be over the tibia, and that helps your quadricep function and patella tracking. So if you look at normal knee kinematics, it's pivoting and has this posterolateral rotation as you go into flexion. The Journey 2 knee does the same thing, and the rotation also occurs at the correct timing. And this knee gets deeper flexion more easily. When I changed to this implant, my physical therapist I work with closely asked me what I was doing differently. And he said, your patients are moving easier, they're moving faster. In my post-op protocols, I don't do any formal PT for the first 2 weeks. I just want the knee to settle down. The patients get their motion much easier. My instance of manipulations is hard to remember the last time I did one. This is a mature implant. The Journey 2 has been around since 2011. There's over 200,000 implantations, has a 5A ODEP rating. We have some studies out there that show you that compared to the Legion, which is a more traditionally designed implant, this was Hospital for Special Surgery in New York, 23-degree range of motion improvement at 1 year and improved knee society scores, so the knees function better with the Journey 2 knee, and it's very durable. So this is a study looking at registry data. So 5-year revision rate was less than PS implants, and if you look at these very active young patients, revision rate 3.1% versus 7% in the registry, so very durable, and less than 1% required revision at 6 years. So if you put the knee implant incorrectly and don't have an infection, it should be very, very durable. So this is a typical patient. He's 72 years old. He has a mild varus deformity. My patients definitely present earlier than what you're used to seeing. He has a slight flexion contracture. I set up the room, as I showed you before, with the Cori device across the table from me. My assistant is positioned just cephalad to me through the whole procedure. I do not apply a tourniquet. I do all my cases through a subvascular approach. My patients are primarily outpatient surgeries. When I make my approach, I don't do a big ligament release. I just do enough to get the work done, but I do carefully remove all the medial osteophytes in this varus knee. Helps with two things. Helps the robot get a better estimate of the size, medial lateral, and also helps detension the MCL. The system of Cori allows you multiple surgical preferences. I collect joint laxity because I use that to help me with my gap balancing. Femoral rotational access we'll talk more about. You can set your tibia resection depth or anterior or posterior reference. So the computer will automatically put the implant at 3 degrees external relative to the PCA unless you have a large deformity, in which case it'll trigger you to manually define the PCA. And you can use Whiteside's line or you can use the epicondylar axis. As mentioned before, you can have lots of options here. We want to get the mechanical axis, so we start by defining the center of ankle by touching the medial and lateral malleoli. We identify the center of the ACL footprint, center of the femur at the trochlea, and this is how we collect those data points. We rotate the hip to get the hip center. So total time for data collection and registration is very short. And now we have the mechanical axis of the femur and the tibia. We know what the patient's starting with, and then we can dial it in to exactly what we want postoperatively. You define the initial range of motion, and this is how long it takes to register the range of motion. You want to know where you're starting and what you have to correct. The digital mapping we talked about before, it's very quick, very precise, takes about 40 seconds. I also add special points. I like to make some marks on the anterior cortex to make sure I know where that is and avoid notching. I draw in where I think Whiteside's line is. I manually define the AP axis of my femoral component to be perpendicular to the posterior condylar axis. I agree with the earlier speaker that it's challenging to identify the epicondylar axis. So I start at 0 and then I manually externally rotate the component until I reach the number that I'm looking for. Tibia registration, again, very quick. Around the outside of the rim and then coloring the surface to refine the model. So the initial implant position by the computer is perpendicular to the mechanical axis of the femur and the tibia. And then the surgeon will modify the plan. And I'll run through this plan slowly and in detail, but it takes me a minute to plan a knee. And my registrars take longer and I can always correct their plan. The idea of an anatomic implant is that it functions like a pre-contoured plate. If I get this plate correctly positioned on the lateral cortex, then the rest of the fracture will line up. If I get my less affected side perfectly balanced, then I know that my joint surface is corrected on the more affected side, and I can adjust anything residual with soft tissue balancing. And ideally, we want to minimize our soft tissue balancing, but in severe deformities, it's unavoidable. So we have an algorithm where we stepwise add correction, adding varus, for example, to the femur as the deformity gets more severe. We're cautious about adding varus to the tibia because you already have 3 degrees of varus built into the tibial polyethylene. So this is our basic algorithm, and we're staying very well within our safe zone of plus or minus 3 degrees. And since we have sub-millimeter accuracy with our milling tools, we're not having the errors that you can have with a saw blade. If you dial in 3 degrees, that's what you're going to get. So initial implant placement is here. So the first step is verifying that I like the size, and I'm going to pick the biggest size I can without medial and lateral overhang. And then I'll set my distal femoral cut angle. So this patient had a 9-degree varus knee, and based on our plan, we're going to goal of adding 2 degrees of varus to the femoral component. So we do that by clicking this button here. But it looks like we're going to add too much material back laterally, so we need to move our femoral cut more proximally. And that matches the lateral joint line. So we've adjusted our extension gap shape. Now we adjust our extension gap size by moving the femur proximal or distal as needed. And then we go to the top right-hand screen and we see that the femoral component is positioned 90 degrees to the PCA. So I'm going to add 3 degrees as a starting point and see where we end up. In this case, we have a 3 millimeter difference in our posterior femoral cuts, and that's appropriate for 3-degree rotation. And with different implant designs, you may not externally rotate as much, and I'll show this to you later. But you have this notch warning, and you can see that our femoral component is really too posterior, so we're overstuffing our flexion gap and not restoring posterior femoral condylar offset in the sagittal plane. So we just have to move the femur anteriorly. So now we match the posterior femoral offset, and we can verify our component position on this 3D model. So you can toggle back and forth. Now we go to the tibia. The tibia is almost always one size smaller than the femur for this system. We center the tibia on the position on the tibia bone model, but it looks like we're going to lower the joint line. We need to move the tibia approximately so it matches the less affected joint line. So now we've done that, so we've matched the joint line, and we can set the posterior slope. For this implant, it's indicated to be at 3 degrees. Now we can collect our gap information. So I just basically put a Z-Retractor in the knee and range the knee with a strong valgus stress, and I range the knee with a strong varus stress, changing the position of the Z-Retractor. And this is how long it takes to gather that information. Again, registration doesn't take hardly any time. And now we have this gap information, and the purple is lateral, the orange is medial, and it looks like I'm loose laterally in extension and loose laterally in flexion. So the easiest solution for this is to cut a little less tibia. So now our gaps are more closely balanced, but I'm a little bit looser in extension than I am in flexion. So one option is to cut a little less distal femur, and that's one option, or you can move the femur anteriorly to loosen up the flexion gap or even downsize the femur. So I move the femur anteriorly here, and now my gaps are within 0.5 millimeter of each other. And I have chosen a 9 millimeter poly, but in the back of my mind, I'm thinking I might need a 10 millimeter poly at the end of this case. But I'm still tight medially. What does that mean? Well, it guides our soft tissue releases for later if we need to do them. You always get soft tissues loosening up as you're making your bone cuts. So I think it's a mistake to do soft tissue releases early in the case. So again, tighten extension, MCL pie crusting, using the Cori machine for guidance of exactly how much to release. Tight medially in flexion, posterior medial capsule. Tight laterally in extension, very common for valgus knee, IT band, pie crusting. If you have to start releasing posterolateral structures, like the LCL, in a bad valgus deformity, then I start thinking about a constrained component or a hinge. So the negative and positive numbers are the result of the computer placing components perpendicular to the mechanical axis in an uncorrected position. So the gap is positive and this overlap is negative. And when you put the trials in, this is what the computer sees. And this is the output from this case. This is where those numbers came from, what it looked like to the computer. Before correction, after correction. Bone removal, again, is if you're using cutting blocks and a saw, you're taking a step backwards in your precision of bone preparation. So the milling is absolutely the best way to go. It's very efficient, 6 minutes to prepare the bone for a total knee. I don't think you can beat that with any device. Going from top to bottom. And the excursion of this milling tool is 12 millimeters, so you can remove the bone in a single pass. The tibia, we just go from the top down, front to back. The bone is removed quickly and easily, and you know when you're done with this bone preparation that you have an accurate cut. We put in our trials and we assess range of motion, and we also assess ligament balance. This graph shows me that I'm a little bit looser in the lateral side in extension and in flexion, but I'm a little tighter medially. So I can pie crust my MCL and I can add a little thicker polyethylene. And again, as you're doing this release, I want to have numbers, information. I can see what's happening to my curve as I'm doing these releases, if I need to do them. In this case, all I did was I added a thicker poly, and then I had sub-millimeter gaps through the full range of motion, got my 2 degrees of varus correction. And we have all this information, and we reviewed this with the fellows as well, so they make sure they understand why they planned the case this way, what they got, and it all should make sense. This is the final outcome. I always get long leg films to check my work. This patient had an excellent result. Now, this is coming to India. This is one of my favorite operations, and this is going to be my knee when it's my turn, is a bicruciate sparing total knee. So this is a relatively unconstrained polyethylene on the tibia side, and it's built like a medial uni and a lateral uni connected by a metal bridge, a very durable implant. And it's the ligaments that drive this posterolateral rotation as you go into flexion. And you need a robot to do this operation because you want to mimic the prearthritic joint shape and alignment and maintain the joint line precisely. And this is the kind of patient that we deal with in the US. You look at his knee and you say, where's the arthritis? This guy's complaining bitterly. He's like, my knee swells up all the time. I'm miserable. I've injected it. I've done an arthroscopy. And he has exposed bone. So I have to hit it out of the park. I have to do an excellent job for this patient so he can surf better after the surgery than he did before. And this is his plan. And you can see here that we're really looking at the three-dimensional model of the knee. We're matching the lateral bone shape, and we're adding material back medially where there's wear. And this is why digital mapping is so critical, because I want to match the cartilage surface. That's the real joint line. I'm not externally rotating as aggressively. I just want to match his posterior condylar axis, match his joint line precisely, and I even have to match the rotation of his tibia so that we are internally rotating this component, relatively speaking, to maintain the ACL. And you can see here, like we talked about earlier, this knee is opening up laterally as you go into deep flexion like a normal knee. So this is why you want to have all this information available when you're planning. This is what the implant looks like in real life. You have the bone island preserved for the ACL insertion. You have plenty of room to clean out the back of the knee. And this is the x-rays. It's a very bone conserving operation. This is him going home the same day. So with the kinematic implant design and computer-aided design, planning, and CNC machining of the bone, we can really get excellent patient outcomes. This is our patient back surfing, so he's happy, I'm happy, and I think that the combination of the implants that you have really should help drive your decision for the robot. You want to make sure that the implants that you're using are the most advanced, durable, and kinematic implants available. Thank you very much, and again, thank you for allowing me to participate in this very dynamic session.
Thank you, Dr. David. Any questions from the audience?
Thanks, Dr. David, for the fantastic presentation. The traditional teaching in orthoplasty is that we need to rotate the femoral component by around 3 degrees externally. Any indications where you have to internally rotate the femoral component?
So for the BCS design, no. And the reason that is because the polyethylene shape is concave medially and convex laterally. And you need to add external rotation to the femoral component to make sure you're very tight in flexion laterally, that you're matching less than 1 millimeter gaps, because it's that intimate contact with the bones that drives that rotation between the metal of the femur and the plastic polyethylene. If you put the knee in without sufficient external rotation for a bicruciate substituting knee, then you're looser in flexion than you want to be, and then the rotation will not occur at the right time, and you'll have disordered motion. And those patients have chronic inflammation and even have shown early tibial loosening. So you must really actively externally rotate that femoral component on the bicruciate substituting knee. For the bicruciate retaining knee, I never internally rotate the component, but I often will put it in at 0 degrees of rotation because I want to perfectly match the posterior condylar axis. And it's the motion of the knee that's driven by the ligaments now rather than the implant. So when I do a bicruciate retaining knee, the XR, I'm going for 2 millimeters of laxity on the medial side in extension and inflection, on the lateral side 2 to 3 millimeters in extension, and 4 opening up to 7 millimeters laterally in flexion. So you're going to have a much less externally rotated femoral component.
That's an excellent one. What is how much extra-articular deformity we can correct in this design?
So that's an excellent question because it will present a limitation to some degree in your practice. So with a kinematic implant, we designed it such that the maximum varus deformity would be 15 degrees, and valgus deformities more than 10 degrees are difficult to manage with the kinematic implant. With the XR implant, major restriction is a sagittal deformity. You cannot have more than 5 degree flexion contracture, and we limit to 10 degrees varus and 5 degrees valgus for the bicruciate retaining implant.
So the other question is, we more rely on MCL is the hinge ligament. And is that pie crusting of this MCL? Instead of that, why can't we go ahead with the bone cuts rather than going with the MCL pie crusting?
Well, the MCL is tight in extension, and our algorithm allows you to move the femur into varus, so it limits the amount of MCL release you need to do. So we are detensioning the MCL by removing osteophytes is our first choice. Second choice is adding varus to the femoral component. The third choice is doing any kind of MCL release. So I agree with you. You want to minimize ligament release, but there are limits to how much you can adjust your component position and not go out of bounds of plus or minus 3 degrees for durability.
Thank you, sir.
Sir, in kinematically aligned knee, while we are creating a slope oblique joint line, but still we are creating a rectangular space. How does it differ in ligament tensioning with mechanical alignment, sir?
Well, the idea of kinematic alignment is exactly as you suggested. You're restoring this oblique joint line in flexion and extension. So you have these implants that are symmetric, and you're rotating them into such a position so that the ligament tension is preserved. So I think kinematic alignment is a little bit of a misnomer. It really is more of a ligament tensioning alignment, because you cannot take a standard design knee and have it reproduce normal kinematics. You're improving the tension on the ligaments, but you're not. Normal kinematics to me is that posterolateral rotation of the femur as it goes into flexion, and no implants out there except the Journey 2 drive rotation. Even if you put in a rotating platform knee in a kinematic alignment, you're not going to get that knee to rotate, because the polyethylene is symmetric and it's not concave on one side and convex on the other side. So I think that kinematic alignment is a great way to put in a standard implant, because you're going to get better motion and better function, but you'll never get proper femoral rotation with that design.
Thank you, Dr. David. And now we move on. I invite the backbone of this conference, Dr. Vaidya.
Actually, I think Dr. Suryanarayan is and Ashok Kumar is ready with the case. Okay. So I think we'll go for the live case first. Okay. My talk can wait.
Okay.
Yes.
So we'd like to invite the moderator for live surgery, Dr. Rakesh Rajput and Dr. Rajkumar here.
Yeah. Good afternoon, Dr. Rakesh. Can you hear me? Can you hear me, Dr. Rakesh?
Check. Dr. Suri?
Yeah, can you
Just
hear
a
me?
minute, they're just getting the chairpersons in.
Certainly.
Just a second.
Surya and Ashok, we can hear you now.
Yeah. Thank you very much. At the outset, let me thank Dr. Narendra Vaidya and the Lokmanya Hospital and the team and Smith Nephew. This is a great opportunity. After a long time, I'm doing this. I think indeed a wonderful facility, Lokmanya, at this hospital. Dr. Narendra, compliments to you. Let me introduce my colleagues. Dr. Ashok Kumar is to my left. In fact, he is much better trained with the technology-assisted surgeries. Other colleague, Dr. Kalevanan, is on just in front of me. He is probably more getting into focus on these issues with the hip surgeries at this time. So just for the sake of saving some time, we have just made the little incision. I'll just go through the incision here. Big forceps, yeah. So it's a standard small medial approach. Can I have a look at the X-rays, please, now? Somebody can focus on the X-rays? So this is predominantly a medial compartment disease. If you see the standing X-ray, there's a complete collapse bone on bone on the medial side. With some stress X-rays, it is opening up a bit more laterally on this side. So I think this is pretty much suited, though the lateral condyle looks a little jarred a little bit. And there is a little concern for me over the lateral osteophyte over the patella, which is sort of beaking over the lateral condyle. If it is significant, probably one may address to it. But clinically, I'm told he has no symptoms from the patellofemoral. There's no point touching it. But if need be, one can always access it either during the inside out Or if you don't want to touch the exposure or extend the exposure, go laterally and then do a small parapatellar small release from the outside in, and then exercise the osteophyte and the lateral marginal fascectomy like we do in the total knee replacement. So all in all, I think it is pretty much appears the ideal situation for the unicondylar. But personally, I always tell the patients also, never say never. Sometimes if we are in for surprises, if that happens, there is an extension, or you can extend the indications for the uni in a fixed bearing, unlike being as rigid in the mobile systems which we use. We have graduated from fixed to the mobile and back to the fixed with the robot assist at this time. And all our unis today are robot-assisted unicondylar replacements. So we have made a small medial parapatellar incision here, thick forceps. You can force another one. So if you see the patella on the lateral side, I think the cartilage appears pretty much good. Somebody can mark it out here? Focus inside. No, they can't see. Yeah, on the this is the medial ridge. Can you make out a bit on the lateral side?
Yes, sir.
So this is the lateral cartilage appears fine. A lot of parapatellar osteophytes, not so much as I see on the X-ray on the medial. I have extended a little bit just for the sake of the demo, just about a centimeter more on the quadriceps tendon. Otherwise, you can stop short here itself. That's enough, more than enough. The medial osteophytes you can see on this side. Just a little digression from this is of late we have been doing a few of them. If you look at this, the quadriceps tendon, this is the VMO. You could probably go subvastus. I think functionally they are much better. You can mobilize the fascia here and then go subvastus, because that's all the exposure you need when you do with a robot. However, 2 points of caution. I think women lend themselves better because of the elasticity of the tissues, unlike the muscular men. And the second point is, if you have a low riding vastus medialis obliquus, I mean the VMO fibers end pretty much low on the patella. From the old quad sparing approach we experience, we know they work better. So if you have a high riding quads VMO, then I think you are in a much better ground to have a decent exposure. Just a point to consider probably in terms of minimizing the approach. I'll just flex it now. Leiden.
So this system, does it allow you to convert it into a total knee?
Yes, of course.
So that's a big advantage.
And if in case I find a big thing or the ACL is totally is gone and you are uncomfortable to do it, I think you can just convert a little bit extension above, below, proceed with the same procedure. The pins have been now fixed. Usually the point is about 4 to 5 finger breadths beyond the tibial margin. Similarly, 4 finger breadths away, and ensure the distances, and that your trackers, as you see on the tracker ball here, trackers are moving well within the field. So that, and that too, when you have got to mark the center of the femur, when you rotate, I think you must ensure that they are on the field and you don't disappear. If that is these things, if you adjust, then the whole process tends to become pretty much smooth. And maybe sometimes it may still be an issue, and you got to. This is the meniscus forceps, which I just kept it out here. You probably dissect the anterior part of the meniscus as much as the situation permits, and anything more posterior we can probably access it at the later part of the surgery. Diathermy. Diathermy.
So I think if there's any question from the audience,
please keep shooting along.
So these surgeons are very happy to answer as they go on operating.
So it is very important that before we worry about the other point I want to show was how much it is opening here. So like I said, the lateral side is bad, is quite fine. Can somebody go? And then when you open, it is opening about 3 to 4, and that's about all you want. Don't give an over pressure, because that is not our intention. Because like the basic fundamental premise in the uni is not to overcorrect, but just to keep it a little under. And so this is comfortably releasing well. And that is one point you must again check on this.
Sir, one quick question away from this topic. You said you were doing mobile and then now switched over to fixed. Any single 1 or 2 valid points to say that the reason for switching over to a fixed
No,
bearing?
the switching back to the fixed bearing, because I started in 1999, 2000, that was with the fixed bearing. The big difference, Rajkumar,
Yes.
is that your leeway to extend the indications a bit is a shade better with the fixed than with the mobiles.
Okay.
So, I mean, if there is ACL is a little borderline, especially in the elderly patients, as you extend the ages, I think you are on much better ground with the fixed than with the mobile. Otherwise, I think elegance and the outcomes are fantastic both in the mobile and the uni. No regrets otherwise with the mobile. And once you got the robot-assisted technology, all the little mistakes you used to make with the fixed bearing earlier on sort of got eliminated nearly completely.
Okay.
So
One
just a
other
raise
small-
of hands in audience. How many of you do uni compartmental? Just raise of hands. So we have fair amount. And how many do robotic UKRs? Right. So we've got about just 1/4 of them. So I think this surgery should help you to convert from standard UKR to a robotic UKR.
Just trying to take off all the osteophytes, nibbler. The tibial side, of course, don't do any dissection. Just got a periarticular enough to remove all the osteophytes.
Suri, you have a very learned audience here. There are plenty of people who do UKRs.
That's excellent. I think it is an underutilized procedure in this part of the world.
Sir, may I ask a question?
Yes, please.
Yeah. So how much varus you accept going ahead with the uni or H2O? If the metaphyseal varus has any limitations with uni?
Go osteotomy, sorry.
Suri, question from the audience.
Yeah.
So how much varus in a knee would you accept going for a UKR?
See, the no limit about 8 to 10 degrees is quite fine actually, because so long as they are correctable. Fixed varus is a bad indication, complete fixed varus, because they are not. You sometimes find that you have to retain it in the extreme varus position. A correctability designates purely a cartilage damage and a cartilage collapse. So these are the ideally suited situations.
No,
so
his
number is, in terms of the number, probably I would say about 7 to 8 degrees varus.
So his question also asking for H2O versus a uni, like how much of varus you decide to go for a H2O or a uni. That's what.
No, that is not the degree of varus that is a prime determinant, Nibbler.
I think it's about 10 degree of varus and about 10 degree maximum FFT. If that was another
More
question.
than, see, high degree of varus again is not a very easy thing to tackle if you are doing an osteotomy.
No, my question is pertaining to metaphyseal varus, meaning tibial bone varus angle.
That doesn't matter in the uni.
Okay.
So I think that even becomes more of an indication for you for doing UKRs.
Yeah, osteotomy, small.
Thank you.
Excuse me, sir.
Yeah.
Dr. Satish here.
Yeah.
You are releasing medially already. So will it affect your stressed range of movement assessment or registration?
No, I am removing just the deep tibial with the osteophytic margin. Below that I have not touched anything.
Okay, sir. So
This
it won't affect your stress ROM.
No. In fact, I think this is finally what it, rather than marking out here and then trying to map it, do what you want to do in terms of removing the osteophytes, which are the impediments. Then now we know finally where we are with regard to what correction you have. See that.
Thank you.
And I'm not forcing anything, if you see. It's very important not to give this, wherever it goes. And finally, when you do it again, it needs to be somewhere within the same ballpark.
And also in fixed bearing about the hyperextension, how much is it accepted or how much of hyperextension you
If
would
the
go?
ligaments are competent, if the cruciates are okay, I think it's fine. A few degrees of hyperextension, if it remains, doesn't matter at all.
Okay.
And if it is bothering you, probably just work on the slope, you may probably go a little less. But otherwise, don't tamper with any of the things. I think it's again important to realize uni is predominantly only a resurfacing procedure. So we have fixed the arrays. Can we go on to the screen also? The PIP? Yeah, so now I'll just give the markings. Checkpoints we are checking on the femur, the tibia, yeah, yeah. Yeah. So these are usual standard landmarks that have been given. Usually, sometimes you find that you may need to release the lateral support to get the thing.
Okay.
Otherwise, if it is working, give it a try or two. Can you switch on? No, the error margin is much more. We'll need to go back and redo the whole thing.
So sorry, how much error would you accept?
Less than 1.
Less than 1.
See, if there is a little movement, it just goes.
The positioning matters
Yeah.
a lot.
I think if we can, want to try this?
I think two things go wrong in here. One is the lateral post hinges, and the second, sometimes the table is not fixed.
No. Can you just loosen the side support? Yeah. So it's again error margin of 1 exactly, probably is acceptable. Yeah. One minute. Yeah, go ahead. No. Loose பண்ணியா சார்?
Is it the side post which is...
Looks like... No, it's okay. No. Side post will loosen it. Don't listen. I'm in the habit of doing both the sides from the right side alone, same side. Yeah, 0.9, it's acceptable. This is a problem. If you are not able to externally rotate,
Okay.
you may make that mistake and you may find that trouble. Just registering the range of motion. Yeah. Extend.
So any flexion restriction decides your indication for uni here, and you.
Till 120, if it is there, it's fine.
Okay.
I mean, at this time, I'm not very adventurous with regard to the indications.
Sorry, sir, one question. You can keep on operating.
Yeah.
So at this moment, when you expose,
yeah,
what makes you convert into a total? That's a question which is very commonly asked
correct.
by
people.
There will be 2-3 things. Once again, I'll just take this marking.
Yes, yes.
We are just giving the valgus stress now with just this spoon retractor.
Maybe we can see that a bit better?
Yeah.
Can you have full screen on that?
Can you find the full screen now? Yeah. So this is a spoon like one. You keep with the same pressure along the ranges of motion. Yeah.
I think what we have here is what we call a Z-Retractor. You can use that, or you can use a manual valgus stress also.
The other one which I'm just in construction is, I was thinking of this old spoon which we used to use with Oxford, 1 and 2 millimeters. If you just are able to get it inserted inside, then you do not give the pressure or anything and let it be there. What I'm sort of working on is getting a small spoon here and get 2 K-wires to fix it inside. So I think the pressure will certainly remain uniform, whereas when you put the spoons, I think it tends to be up and down a little bit. So then we get the standard landmarks. Keep more along the center of the femoral condyle. So this is the tide mark which you are taking on.
So maybe Suri, you can tell us what does this tide mark represent?
Tide mark basically represents the end point of the femorotibial articulation. If you see extended, and down there, this is a zoom inside. Zoom inside.
Just above the notch.
Yeah. See here. Can you see the tibiofemoral articulation?
Yes, yes. Yes.
So do you just use the wear pattern as your tide mark, or do you actually extend and bring the tibia and see the tibial
No,
margins?
usually a wear pattern more or less depicts, unless they probably had a severe flexion, deformity and all, in which case you won't be doing it. Then center of the knee, just extend it, go above the PCL attachment, that's what I take, about 4 millimeters above, on. This is a distal most point, again towards the center, on. This is the posteromedial corner. Yeah. We can now mark a small homon. So we'll just map the femur. No, give me the other one. Okay, that's fine. No, that's okay. That's okay. Langebeck. Just going a little shade slower to be clear. Okay, can you start?
This is in the distal portion or posterior also?
No, this is for right now. What the more exposed areas I'm finishing up.
Okay, sir.
Then we will go up to the posterior side. A little valgus stress helps to do the posterior side.
Okay.
And on the tibial side, like I will show you, if it is very tight or you find it difficult, do it in extension, the posterior half. That makes life a little shade easier.
I think a big advantage of this system is, compared to probably some other systems, is when you mark, the posterior part is very difficult, both on the femur and on the tibial side. You can use various things, or sometimes you can come back and again mark it later.
The posterior still we need to do.
Okay.
That's the mark which you have to take. Valgus stress. Yeah, on.
Any specific advantage over the CT based one in this aspect, sir?
I think it is image free, probably makes life so much easier, and then you are not committed to anything.
Okay.
So that will sort of give us approximately a decent size,
Okay.
because you have got the full grab of the anterior and the posterior point. So now you get a whole profile of the femoral condyle on the medial side.
And the image is also getting created now.
Yeah.
That's a good one.
Yeah. Okay, continue. So we go to the tibia. Take the tibial spine.
Okay.
Keep it somewhere in the center of the interspinous area on. The lowermost point of the tibia on. The posterior most point. Yeah. Anterior most on. Medial center on. Then the tibial axis which we give on. Start.
Can we see the perioperative image in full screen?
Perioperative full screen?
Yeah. No, just to see. Yes. Very.
This is again the reason and the advantage that if you take up all the osteophytes, exactly when you map it, that gives the near size, you know.
Okay. So that's why before doing this, you removed the osteophytes.
You must remove all the impediments.
So should we go to the sides also, or only
Yes,
in the
that will make it more precise.
Okay.
Of course, you have the option, you can downsize if you want. See, when you go in, if you see the full screen, it becomes, sometimes it's a little tight.
Maybe
So-
we need to flex more.
Yeah, you can extend. So instead, stop it. Yeah, extend the leg. Get it in extension. Takes only a few minutes. Then it becomes valgus stress. Yeah. On. Only make sure your point probe tip is on the bone.
Yeah, so the posterior one is very difficult.
As a routine, totally how long it takes for this registration?
2 minutes.
2 minutes. It's quite
Okay. On. Okay, so posterior. On. Yeah. So that is your virtual thing. Yeah, now in the other screen.
Yeah.
So we can ask them,
Yeah.
full screen, yeah.
Yeah. So it is showing a size 3 on the femur.
Okay.
You can adjust it down to the femur. The yellow line depicts the bone margin.
Okay.
Take it to the posterior condyle, the virtual condyle. You can oppose it. You are not going to make any changes on the femur. The posterior condyle, if you can see, is just again
So how much
centered.
flexion was it showing?
Which one?
The
45
femoral
degree
component?
flexion. femoral 45 degree is by
So
default.
that's the default flexion.
Yeah,
showing.
default flexion component. And then you see the marking of the femur. Just move it as well. The profile of the femur, how it's sitting on the femur. I think size 3 pono. If you put the size 3, see if it is a little bigger. You'll have to take it more proximal, bit medial. So center the condyle. It's okay. 3 appears good. If you see here, the femur is positioned along the 3 center, the center of the femur, the tight mark center, and that's why I said the points which we give, the mega points, if they are aligned in one line, becomes easier.
So the boundary helps you to
Correct.
centralize the
Correct.
component.
The tibial side. Yeah. Yeah, we are now aligning it to the anterior cortex there.
With the femur size selected 3, will that affect your tibial side selection? Like
it goes up and down at
Okay.
least a size more. So now you got the virtual margins of the bone like the ones which you have mapped, and then you can probably play a little bit on the rotation. In fact, if you keep it a little more externally rotated, it takes you away from the attachment of the PCL. That's how we used to work on it earlier on. But I think neutral rotation is pretty much fine. There is no. So this is the tibial sort of positioning I've done. It's a 8 millimeter thickness, size 2 of the tibia. We just now check on the gap and see the gaps. We are now nothing much to do. It's a 5 millimeter resection depth on the tibial condyle, a little bit slope of 5 degrees, which is looking at the lateral X-ray on this case, seems a little degree or 2 more. But if it is well balanced, I'm not going to touch it.
Suri, that's a very quick, very good balance straight away.
Yes. So we have got it and see how it's tracking. This is a preoperative there. 7 degrees to a post-op varus of 3 degrees. We have not got to 0.
Okay.
It goes in. I think it looks pretty much balanced.
so you don't aim for 0. That is the point here.
Yeah. And this is basically the tibiofemoral contact points which is there. See the tibia articulating. This is the problem. If you don't have the ACL and there is a lot of rotation, it tends to shift more towards the medial side.
Okay.
And then your contact is more eccentric. We prefer to keep it as close to the tibial spine as much as possible.
But if we here you get a 0 degrees, whereas how do you titrate it here?
Again, by adjusting the component position, probably you would resect a bit more, millimeter or so.
Okay.
And if it doesn't feel like, no, it's not too bad, it's okay, but keep it at at least about 1 to 2 degrees of varus. So the tracking also looks all right. The stability looks okay. The rotation is fine. I think that's about all. I think we can accept these marks and then proceed with the burring.
Right.
Is it okay, Rakesh?
Yeah, good,
Yes.
good, Suri.
Yeah. So we got checkpoints on. One second. On. Yeah. Come, start. Homan? I know that as I look at it sometimes, these procedures are also 2 components. One is the planning and the second is the bioskills, how well you can use these hardware. Because that is the one that saves time and does time. In that regard, I think your colleagues are often better and you need to learn because the hands move far better.
Can we see the other screen, full screen, please? Yes.
And you know the color coding here. Foot pad.
I think what you're seeing now is what we call as a refining procedure, which you are giving again a feedback to computer where you want to cut.
till you get to the white. Initially, probably the sclerotic bone will give you an idea like it's very, and it may be a little forceful, but be careful. Under the sclerosis, often it's a soft bone.
But you also have the option of using a saw blade.
No, this is a burring system. In the tibia, also I think you could do, but I think in the uni especially, since the activity is much less, it is probably used better to all bur it. Keep it that the bud perpendicular to the bone.
Okay.
That is the most efficient cut that happens. Yeah. Like Ashok says, it's an end-on, we need to have it all the time. You can see the entire spectrum of the colors.
Yes, sir.
The pink, the blue, the green, and then the white.
And when it
This
crosses...
is merging towards the posterior cut.
Okay.
You are seeing the anterior upper peg hole. You have now the lower peg hole here.
And if it crosses the white border, it stops by itself?
Yeah. The thing, the cutting edge sort of goes back.
Goes back.
Occasionally you can get this light pink color, which means you've gone about 5 mm more.
Okay.
But that's acceptable.
Flex it. Push it. Flex the thing.
The cement integration seems to be better in this burring
Yes,
system.
yes, because it is not a totally flat, smooth like a cut.
How long it takes for a femoral side in a routine?
Yeah, it takes 3 to 4 minutes.
3 to 4.
Depends. Sometimes you are able to do it faster.
Can I ask you a question?
Is the speed is fixed or it is adjustable?
Which one? The burst speed? Yeah, we keep it as a fixed rotations.
Yeah. Sir, there is a question from the audience.
Yeah.
So we have fed the computer, fed the registration of worn out medial femoral condyle.
Pardon me? I didn't get you.
Sorry, I'll translate the question to you. Let me hear it first.
During registration process,
yeah,
we have fed the robo the worn out medial femoral condyle. Am I right? Few millimeters are worn out.
Correct.
And when we were trying to overlap our implant during our planning process, we have brought it up to the level of worn out femoral condyle only. We have not distalized it.
No. We have not worked on the depth. We have only worked on the margins of the virtual bone.
So in terms of placing it proximally or distally, can we play around?
We can play around by increasing the depth of the cut.
That white margin which you think is the assumed bone where you were actually meant to be.
Okay.
So you don't want to be beyond that because that will then be tight on one particular aspect of the mapping.
So you now change it into a speed control mode.
Okay.
Just to create the peg holes. Yeah. Come. That needs a little change of the tip along the sleeve of the support cover is taken out. There are 3 ways I think we should show. It is like again a gaming device, and you have got the homing device of 2 circles.
Okay.
If you see on the lower left side, align both the green and the blue towards the hole and then go down, and the depth of it is determined again at the center where you find the pink color goes off. I think we should change this image.
Image, full, yeah.
For the full, 1 second, sure. Change the full screen image. Bring the, see now you got to zoom in both the circles. And if you see the lower white thing, see it takes off the pink, then you know you're deep enough.
Okay. And the depth is also fixed.
More or less, yeah. If it is little less, it's okay, maybe you can always prepare it. But you have got, most important is if you are far out, veering out of the center, then you will find that it doesn't work.
So you make peg holes before you do the posterior bit?
Because you are changing the burr. So when you are doing the part of a thing without the cover, but the posterior side, if you go along with the sleeve cover in the speed mode, it doesn't go in because the tibia. Show the tip, no, show the tip. If you see the tip of the burr, can you just change the image for a second? Yeah, see this is open tip.
Yeah.
Whereas the other one, can you have the cover sleeve? This is covered and protected otherwise. I'm not putting, I can't put it now, but this is covered it.
Right.
So if it is covered, then to negotiate between the tibiofemoral posterior space becomes a tough call.
Okay.
Hey, adjust Pandapa. Image, please adjust. Yeah. Now see, you can go in, again the same, you can just sort of slide it inwards. Posterior is fine. So the posterior side is well taken off. Just refine the medial also. Yeah, or you may take out a little bit of this blue and the greens. In fact, if you try to match this picture with the image on the screen, what to visually see, you can make out where there are undulations and where probably there is a spike of bone. They typically match completely well. I think this part of the surgery is pretty, more or less mechanical. Nibbler, please. Some overhanging bone I'm just taking out. You can now go on to the tibial side. Want me to do? Or home on? You can do the tunneling usually. What you do is basically keep in the lower left picture, stay within around till the top of the green, and then keep going like a tibial tunnel. The upper part will come out. You will see that pink doesn't go, but you are cutting underneath in some places where there is thick bone.
Okay. Is the burr size is fixed or it can be interchanged?
Fixed size.
Fixed size. Will a bigger burr help in doing it?
I think we are fighting for space. I think it's not really necessary because the whole worry would be that if you have a bigger cutting point, you may veer into the unwanted areas.
Okay.
That's, I mean, my take on this. Clean and sure. See how it's going, burring into the bone. The posterior meniscus, just a point, sometimes can give you a false sense and then you keep digging into it. You are going below and sometimes that can be an impediment. Maybe a good point at this time to just to open up and see if the meniscus is coming in the way.
And then remove it out.
Yeah, exactly. We are more or less done with the medial side. When the sclerotic bone at the medial bone-to-bone area And second point you have to be very careful is removing the medial wall, the lateral wall I mean, because that will decide, that will help control how much of the depth you are going, the sizing wise, ML sizing wise. Sometimes it may go a bit into the ACL, about 20% of the ACL, if it comes away, it is not a problem. Sometimes you may need to do this because otherwise you'll be placing tibia too medially with a smaller size.
I think Surya, I remember Chris Dodd once saying that if you've not taken few fibers of ACL, you've not gone enough laterally.
Probably, yes, as I could put it, that is putting it the other way. What I mean to say, don't shy to not to touch any fiber and then undersize the tibial component. And then even if you just cut a tunnel and not take it out, while inserting and clearing, or it may be some sort of impingement that may be happening. So best is to sacrifice. So this is the medial wall you're seeing on this side on the image screen. I'll just zoom in after the picture. Take this out so that I think you have less. Of course, you can polish this off with a file or a bone file, but if you can take it out with the bud, that will be the ideal thing to do.
So this is where the big advantage with the robot when compared to the
Big
manual.
thing, absolutely. And second is, if you failed to mention this, that if you look at the X-ray, if you see the tibial epiphyseal slope at the top, it is not a 90, it's about a 87, 85 situation. Absolutely ideally suited for this thing, uni. File please. So a little bit of smoothening you can do with the file, especially the medial, postomedial area.
Maybe we can have a look at the file also, Suri, because
Can
a
you just
wonderful
open the
file
film?
this system has.
Can somebody change the image? Yeah, close, zoom in. This is basically the file on the inferior surface. You have the ratchets, the movement, and also the side wall has ratchets here.
Okay.
So
Very
this
good.
side wall, it helps you on the medial wall or the lateral wall, and the lower one shows both on the tibia and the posterior femur.
So if you've got like 1 mm unevenness, this file does a wonderful job for you.
Yeah. Gospey's forceps. I just want to now look at the look at now the practical points, the posterior meniscus. No, forceps, please. And a cocker or some holder. You can see this part of the posterior meniscus. So I'm just going to exercise this with a diathermy.
Sir, there is a request from the organizing team that once we are with the trials is inside.
Yeah, we'll do that.
So
Fine.
Suri, one small question.
Yeah.
So the depth of the cut was around 5 mm.
Yeah.
So the deep MCL on the inner side is also attached around 4 mm. So how do we prevent damage to the deep MCL?
Deep MCL. Because I'm not doing anything on the side. Can you just angle back? It is just as it is. Deep MCL, basically when it comes, a few fibers may get, but usually it doesn't get. See, it's only the bone edge. There's no dissection of sorts done. And the 5 millimeters is from the highest point. It may not be 5 millimeters from the medial ridge. You get what I mean, Rajput?
Yes.
5 millimeters is with the highest point of this, but then here on the medial side, it will not be a 5 millimeter thickness. Like you see, you can't make the tunnel on the medial most areas, trial, femur.
I think that's one difference between TKR and UKR, where TKR you always take out the deep MCL. Here you always want to keep the deep MCL.
Malik, thank you. This is the 8 mm spacer.
Okay.
Okay. Now we'll extend. So now we have got a 4-degree varus post-operative. 144th flexion. Varus of 4 degrees. And then clinically, if you look at it again, some amount of varus movement is there. And now look at the stability across the range. Slight laxity in the terminal extension, millimeter or two, and that's what you want. Is it clear?
Yes. Clear.
So the varus is now 4 degrees.
4 degrees.
Sorry, you aim for 3.
Yeah, it's 4.
Okay. So will you try
No.
to change it, or?
I will not do anything to this. I will not do anything. Yeah. I mean, this is again in non-weight bearing situation. The moment they load it, they are going to have a little thrust on the medial side. So don't fall for total numbers. What is important is the stability of the whole thing. The cursor moving below along the neutral line.
Okay.
Huh?
Sorry, we'll have to sign off.
Sure.
You are happy with the trialing now?
This
So
is
you'll
trialing,
be-
now we are just going to cement it.
So just one thing, Suri, do you have any good tip about cementation, preventing it going from behind on the tibial side?
Yeah. First, I think most important, clear up the whole thing, number one. Put the cement predominantly on the anterior half of the joint, and there is a little shade on the posterior side. Trial tibia, since you are short of time. So this is the tibial zoom in. Yeah. And then only anterior half. The posterior side, usually you can just glide it in and then use something like a curved this thing to take out the cement from the back. That's about it.
Right. So you're going for size 2 on the tibia?
That is the plan. We just have to put it on the tibial side and then check. Remove a femur.
Okay.
Spoon. You can
Sir-
check on, I can tell you. No, tibial size.
Due to want of time here.
Yeah, I can. And that's why we exposed it also beforehand. Just since you asked,
Oh, sir.
it is size 2 is the ideal.
Okay.
The 3 is, somebody can close it in. Zoom the image. If you see, look at it down,
Yes, we can see that.
the 2 is the right size here. Huh?
Oh, okay.
Okay. So I think the plan is on the same one. Thank you anyway. Thanks much.
Thank you, sir.
The subsequent steps is going to be just preparation, cementation, and taking out the medial marginal osteophytes on the patella.
Patella.
Yeah.
Okay. Thank you, sir.
Thank you, Suri, Ashok, and Clivenan. I think big round of applause for a wonderfully executed surgery. Thank you so much, sir.
No.
Narendra Vaidya. So can we have welcome and opening remarks by Dr. Narendra Vaidya?
I think we are through the halfway of the first day. So opening remark actually are not a valid name of the session. So I'm not actually going to present anything. Actually, I was to show some slides. But thanks to all our faculties since morning, we have seen most of the robotic technologies around. Some points which I found very interesting, which I should mention when we talk of robotic system. And we have seen the technology evolve from handheld navigations to navigation. One case Dr. Mahajan demonstrated very nicely in the morning. Still, the satisfaction rate was not improved with the conventional. We had spectrum of implants, various implants and everything, but still that 20% unsatisfied patients were bothering us. And so what we should do, I think the way forward is to give a patient specific mechanics, not mechanical alignment. You can't put everybody at a zero, complete straight mechanical axis. And so there is a role of something what is called as kinematically aligned knees. And that differs patient to patient. And I think technology, all the technologies, I think I have been exposed to almost all the robotic technologies. We have ROSA also, we have Navio, some cases on QVs. I have seen and attended some Macos also. So all the technologies have a possibility of achieving this kinematically alignment. So afternoon session, we have a very interesting session where we will be demonstrating very complex cases, and we have very, very elite panel of senior consultants who will be, going through that case and what will be their alignment philosophy, which can be mechanical, which can be extreme kinematic. I have done some very extreme kinematic alignments also, and to my surprise, these people are doing really well, and most of the adjustments on the femur. So we will be discussing those things also. Haptic boundaries we discussed, I think that is also going to be the next phase. And thanks to COVID, only one thing happened, that we had a lot of interaction between the surgeons who are developing these technologies. And during that, we developed certain protocols which will be circulated very shortly, how a mechanical or a kinematic or a completely extreme kinematic alignment can be adopted. So I think what is important and what is going to be the future, there is going to be augmented reality, virtual reality, everything will come. And we are also trying to develop something like artificial intelligence, where so many of us are now having so much data available. Otherwise, earlier conventional TCAR only, we used to say adequate release has there is no backing to that by any data. What is adequate, what is varus? So ultimately, what was our alignment? That was not known. Now, every step, the computer gives you so much data, and if we compile that data across the country or across a certain group of surgeons, then that can be a very good teaching tool for the new surgeons. And that can be a very objective tool also. Or somebody doing a distant surgery. I think with today's technology emerging, doing a distant surgery or monitoring at least distantly can be really a possibility. So I think way forward is going to be really interesting. One cannot say no to technology now, and can say that, I was doing this now since '93. I have been doing arthroplasty and seen evolve and did so much work. But I think this phase is really interesting, where technology is telling us with kinematic alignment, actually virtually this soft tissue handling. Otherwise, we used to say that the MCL is the mother of the knee. Now why, unnecessarily release this thing, MCL or any other ligaments, if you can kinematically adjust the femur by just bone remodeling. So this is going to be an interesting pathway. We have to have a long-term data, definitely. I think we should, we have formed this SRA, the Society for Robotic Arthroplasty, where we should compile the data going forward, so we know all the 5-year plans and everything, 5 years and long-term results. So to conclude, I think I think that why only replace when you actually can restore the joint. So restoring the joint is going to be the main thing. So I think we will not only replace the cartilage which is degenerated, but we should be restoring the mechanics of the joint, and that should be the aim. So getting a zero alignment is not the aim with robotics. Bone cuts is not the aim, but avoiding soft tissue, indiscriminate or uncontrolled soft tissue releases is going to be the way forward. I thank you all for attending this conference, and I invite Dr. Karne here, who is president of Maharashtra Orthopaedic Association as well as POA, Pune Orthopaedic Association. He has been a great support to this conference, and I would like to felicitate him. So we are running a bit short of time, so I request that lunch time can be crunched, so we have 2 or 3 operative cases on various systems later on, and so I request the moderators and the speakers to be on time. Thank you.
Sir, I would like to invite Dr. Rajkumar sir on the stage and Dr. Rajput. and for the trophy.
We move on to the next session where we'll have a detailed discussion on the handheld imageless robotic systems, CORI and its predecessor Nevio. I would like to invite Dr. Rakesh Patil, Dr. Shubhang Agarwal and Dr. Anubhav Jain to chair the session. I would like to invite Dr. Ashish Chaudhary to give his talk on my OR setup. Thank you.
A very good afternoon to everyone. At the outset, I would like to thank Dr. Narendra Vaidya and all the industry leaders in arthroplasty who have organized such a nice conference. I missed the chance in last two occasions, could not be a part of this August gathering, but this time I made sure that I should attend and learn from the people who have been practicing robotic procedures for such a long time. So, just few points because the presentation is not long enough, but I just wanted to share, in 2 minutes my experience in last few years. So, once we start in a conventional way, and once you get exposed to technology, whether it is navigation or robotics, you always are wary to adapt the technology, whether it's going to be a good amount of learning curve, and are we going to compromise the results in first few cases. So the journey started with the imageless robotics from Smith & Nephew. But I was hearing various pluses and minuses of various systems available in the market. And it takes us back to a few years when we were just discussing about the implants from various companies, and everybody who was maybe a Stryker, Zimmer or Smith & Nephew, somebody who was patronizing or was comfortable with one implant, they were having all the positives about that. So I feel at the end of the day, if a particular system, whether it is CT based, X-ray, MRI or imageless system, if you are comfortable and you are able to produce good results, I think that's the way forward. Every system would have some ups and downs, but if it is working fine in your hands and you are gradually improving your algorithms and able to manage your revision cases and difficult cases, I think that's the way forward. And there is no system which is superior than the other. It's only a matter of getting comfortable with kind of system and able to identify limitations and trying not to do those cases with those systems in hand which may not be able to produce good results. So if we talk about our setup, there are a few things which we had to actually modify, the location and type of anesthesia machine, OT table placements, tourniquet use, site support was one important factor which we saw in the last live surgery as well. And the CORI system, which has recently been launched over Nevio, we found some advantages of that. Although it's just a new entry, we have done only few handful of cases, and the nursing trolleys and the implants. So this is a typical setup we have for any joint replacement through robot. You can see the placement for the robot. This is for the left side procedure. From another angle, you can see the placement of the robotic channel. So we usually prefer regional anesthesia. A typical thin bore needle is used for preventing the post-spinal headache, and ADC catheter is a norm for all the procedures we are doing at our center. These are typical patient positions, so we don't use any side supports for robotic procedure. For the other side, if you are doing a conventional, we use the side supports for the hip. This is just before the procedure starting, and you can see the camera and the CORI placement. And one good advantage we found with this system was we are able to get the iPad in the sterile zone very close to us. And in the previous system, we were finding it difficult to have the entire machine close to the sterile field, and that was blocking the communication with the camera. A typical nursing trolley placement, a typical placement for all the components of the CORI. And usually I prefer to stand at the end of the patient's leg, and the assistant is standing on the side of the operating leg, and the robot is lying on the opposite side. A typical incision, medial parapetal incision. And one important point which we learned the hard way, we had one pathological fracture, iatrogenic fracture because of the pin placement. So usually we try and not invade the second cortex. And one simple tool we adopt is like this is the tibial placement. If you see at the end, we go very slow, and the moment we start seeing the reverse turning of the jig of the drill, we stop at that, and just that ensures that it doesn't penetrate the second cortex. So then the routine checkpoints collecting bony landmarks remains standard, but yes, the tracker are much more easier, and we are able to place it very close to the joint because of the design modification. Hip center rotation calculation, knee flexion, and the surface mapping as was shown in Nevio. It is faster in CORI, and the slippage on the surface while we are collecting the points is much easier. It's again for the tibia. And the implant planning as standard. Femoral resection, the burring is pretty fast. The peg placements, the tibial resection, the tunneling technique we adopt in CORI as well. Here we have a different burr size option of 5 and 6 mm. So that's something which is upgrade from the Nevio. And then the implant trialing and post-op assessment. Final implant placement as standard. And this is the end result of the procedure. And mobilization, we have a protocol of early rehab from the anesthesia point of view, and patient usually starts to mobilize in first few hours of the surgery. Thank you so much.
Okay, thank you, Ashish. One question regarding your OR setup. How much time you will take before actual surgical incision for preparation of the patient's setup? How much time it will take?
Well, over the last 2 years, the entire team knows, the placement of each and every component. So they ask for the type of surgery being done, which side. They place the side supports and the OT table and the nursing trolleys, even the CORI or the Nevio component in the same way. So it hardly takes 10 minutes preparation by the team which is already trained. It's the same OT. We don't mobilize although CORI is portable, but we have tried not to move from one OT. So this robotic OT is the same, and the placement of it is pretty standard.
So over the period of experience, your team is getting geared up, and team is knowing all the setup. So time is getting less for preparation. Now second question regarding your OR setup is the position of the leg. Do you see now in live surgery we have seen the problem with the rotation of the hip.
Yes.
See 3 to 4 times he has to repeat the center of the hip to calculate, because error is more than 1. Error is showing more than 1. So your leg position, whether you keep it little bit lax or you are keeping a leg or thigh in slightly external rotation, or you are keeping it in neutral position?
Yeah, so I also used to have the same problem initially, but I realized over many cases that first of all the side support has to go, and then the main challenge is that if you start in some amount of flexion, you have to have somewhere in the center you have to start the rotation, because otherwise the tracker communication with the camera gets obstructed somewhere and the error chances. And the speed of rotation, I think what we were seeing in the live surgery, if it is slightly faster, the chance of error is always less than 1. So in last maybe 20-30 cases, we could do that in the first go.
So it is little bit like learning curve for first few cases, and then you can adjust accordingly.
Exactly.
Your staff is getting acclimatized to all these things.
Yeah.
Okay, thank you, Ashish.
One question, please. It's regarding your iatrogenic fracture. Was it during the surgery or was it in the follow-up?
Yeah,
and
so,
how did you treat that? And was it in the femur or in the tibia?
Yeah, so there were two cases. The first case was in the femur, and during the procedure only, while I was holding the guide, somebody else was drilling, I could realize immediately that it was off-centered. The pin had went, and both the pins were not properly aligned. So that, and it penetrated the second cortex. The other case was in the upper tibia, wherein we realized that we had gone a little far off, but we monitored that patient right from day one because we knew that this patient is going to have some stress fractures, and we were managed. She was having significant pain, but we followed with serial X-rays. The actual stress fracture did not develop. The first case, he had a fracture after 2.5 months, and it was a complete distal femur fracture, and we had to nail it after that.
So how did you treat that? Did you plate or nail that fracture?
Nailing. We did a nailing.
That was anti-grade nailing or retrograde?
It was an anti-grade nail. We had enough space available to do a rigid fixation.
One quick one. We've all had side support issues. So we've also given up using, for single knees, we use a leg holder with a sandbag under the hip. So that makes life easy.
Yes, of course.
Also, are you changing the position of the camera in between surgeries when you switch from left to the right side?
Yeah, it goes to the opposite side.
So like since you said you're standing at the foot end, can you continue with the same position?
Yeah, I'm able to manage that. Yeah.
From one side itself?
Yes.
Perfect.
Okay, thank you, Ashish. I think I'll invite the second.
Dr. Ashish, one second. I would like to invite Dr. Mithali Vaidya to felicitate Dr. Ashish Chaudhary.
I will invite next speaker, Dr. Anup Gadekar from Lokmanya Hospital. Handheld robotics in cases with implants in situ. It's a very interesting topic where the actual use of navigation or robotics come into the picture.
Good afternoon all. Actually my talk falls under the complex cases in arthroplasty, which is the retained hardware, and it's all must agree that this is a challenging case scenario for any arthroplasty surgeon. Now, 12% of patients undergoing total knee arthroplasty suffer from secondary osteoarthritis, and presence of hardware in knees undergoing TK cause technical difficulty and increase the risk of post-operative complications. The overall success rate following total knee arthroplasty in post-traumatic arthritis has been reported only 71%, and if there are hardware in situ, then there are a high rate of complications. Now, Javed Parviz overall evaluated the outcome of the patients with hardware in situ and compared the rate of complications with the patients without any hardware. And they found out that patients with partial or total retained hardware have a significantly higher incidence of mechanical failure. But the rate of other complications, though it is high, but not statistically significant. Now, what are the problems we encounter with the retained hardware? So generally the femoral medullary canal is obstructed by the retained implants, and there is a canal sclerosis and obliteration from the callus. Also sometimes there are extra-articular deformity from the previous fractures. Now there is a term coined called as a conversion TKR, in which the procedure of periarticular hardware removal is required prior to TKR. And in literature, the conversion TKR is associated with a higher operative time, blood loss, readmission rate, and post-operative complications compared to the primary TKA. There's another paper by Parviz et al. Where he has mentioned the same problems with the hardware removal. Now, other challenges encountered with the conversion TKR are the difficulties with the exposure requiring tibial tubercle osteotomy, sometimes intraoperative disruption of medial collateral ligament and patellar tendons, increased use of stems and augments, and postoperative complications include increased postoperative stiffness and wound complications. Now, there are two ways in which we can do the conversion TKR, either simultaneously with the arthroplasty or it's a stage procedure. Both are having their own set of complications or challenges. If you do the simultaneous arthroplasty and removal of hardware, it may require either 2 incisions or the use of skin flap for adequate exposure, both increasing the risk of soft tissue necrosis and septic contamination. In addition, the screw holes left after hardware removal are potential stress risers which may limit the post-operative weight bearing or require additional support such as stems or struts allograft. If we do a stage approach, then the multiple surgical procedures prior to a knee replacement have been linked to an increased risk of arthrofibrosis and infection. So what are the options available with us if we decide to go with the hardware retentions? The first option is the extramedullary jigs. These are proposed as an alternative on the tibial side. However, femoral extramedullary instrumentation requires a radiographic identification of the center of femoral head with freehand pinning of the cutting block, affecting the accuracy of implant placement. Another option we got is the navigation, and there are multiple papers and case reports available which state that the computer navigation allows the surgeon to obtain good reproducible results similar to routine TKR with a one-stage TKR without hardware removal in post-traumatic knee arthritis. Another case report which states that the computer-assisted navigation system is an beneficial alternative to a standard TKR. This is the paper published by Lin et al. Which state that the results of the study suggest that navigation can help achieve accurate alignment and proper prosthesis positioning for patients with retained femoral implants where the intramedullary rod guidance is impractical. Another option available is patient-specific blocks, and Vaishya et al. Published a paper in Indian Journal of Orthopaedics with a good functional and radiological outcome with the patient-specific block. The literature on the use of robotic technology in such cases is scarce. There is a latest case report published in 2022, January, which state that in a well-planned and selected cases, robot-assisted TKA can be a useful treatment for knee osteoarthritis in patients with retained hardware. What are the challenges we can face with the robotics? The first one is everyone is discussing is the pin placement. So we do a detailed analysis of the preoperative X-ray of the patient, and we preoperatively decide where we are going to put our pins, and we do some fine adjustment intraoperatively. Now I'm going to show some of the cases which we operated with the Navio system and Cori system in past few years. This is a lady with a mid-shaft femur fracture operated in 2018 with a LCP plate. As you can see, there is a varus deformity at the fracture site, and if we try to remove the implant, there is very high chances that refracture can occur at the previous fracture site. And if we see the screw positions, they are very low. So we went ahead with the CR knee using imageless handheld robotic technique. This is another case where the femur interlock nail was present since 2008, and again we see the tip of the nail is very low. So putting a PS knee was not out of question. So we went ahead with the CR knee, and this is the post-op X-ray. Now another case where the hardware was on the tibial side, and it was there since 10 years, and we can see the lateral compartment is fairly in good condition. So we went ahead with the medial compartmental uni in this case, and we could get away with a good X-ray. Another case where the V-nail was implanted in 1986, and it was an Herculean task to take out such nails which were implanted and there for many years. So when we opened the joint, the lateral compartment cartilage was fairly in good condition. So again, we planned a unicompartmental in this case, and this is the post-op X-ray. Thank you.
Any questions from audience?
Very nice cases, sir. What about the first case, the varus in the femur?
Yeah.
You maintained that varus after total knee, or you made some correction in
See,
that
there
also?
are papers available which state that you can correct the extra-articular deformity by the intra-articular corrections, and the guidelines are set in those cases. You have to draw the axis on the from the femoral head, and you have to see whether it passes through the joint line or the knee. And if it passes, you have to draw a perpendicular line to that axis, and you have to see whether the cut jeopardize your collaterals. If it is the cut is above the collateral attachment, then you have to do the extra-articular correction. But if you can get away with the collateral attachment, then there is no need to correct extra-articularly.
So what you did actually? But it would have been better if we can see the X-ray or
Yeah,
stenogram.
unfortunately, I don't have a long leg X-ray right now.
Thank you.
I think for such extra-articular deformities or peri-articular implants, the best thing is to have a scanogram, first thing. Second thing, you should have all your trauma set to be ready. By any chance, if you stuck up during intraoperative thing, so all these trauma instrument or implant removal set has to be ready. And third thing, in such difficult scenarios, this robotics is actually beneficial. It's a very, very, very handy thing, robotics or navigation, where you can come out easily. If you see these cases, the peri-articular implants, where you can put a uni in a very peaceful manner with implants in situ, or you can keep that implant. So there is no need for any stress risers, no need for stuck up during implant removal, no need for surgical lengthy timings. So these technologies are definitely helping us. I think thank you Anup for a wonderful presentation.
I would again invite Dr. Mitali ma'am to felicitate Dr. Anup Gadekar.
Our next speaker is Dr. Rohit Luthra, who is going to talk on burying options, my method of choice.
Good afternoon, everyone. And on the outset, I'd like to thank Team Lokmanya and Dr. Narendra Vaidya for inviting me and letting me be a part of this event for last 3 years. And I'm lucky to be associated with him. So I started my journey of robotics 4 years back in 2018, following the footsteps of Dr. Vaidya. So we started using Navio handheld robotics for doing robotic knee surgeries in June 2018. And so what are the burying options? So my talk is a very short talk, so I'll just go in a little detail of what are the various options we have for burying. So first options, we have a burr cut guide, which was the primitive option of doing a robotic surgery. Then there's an all burr technique, which I think a few surgeons are still doing and they love doing it. And lastly, it is a femoral distal burr technique, which is my preferred choice. So why I will talk about that. So primitively, robotics had burr cut guide. So what we used to do is we used to make two burr holes with the robo. And through this, we used to attach a jig and then connect it for a distal cut. So this is how we used to take a distal cut, like a navigation distal cut. So instead of using a free hand, you use a burr hole with the robotics and then make holes in the distal femur and align the jig and take the cut of the distal femur with the help of a saw. The other technique is a burr all femur, which I have tried but did not like it much. It is a little more time consuming, plus it gives you a fatigue to your hand. So here what we do is we drill the whole bone cut with the help of the burr, and sometimes it's very difficult to reach the posterior aspect of the femur, so you have to actually drop your hand down and do it. It takes time initially, but in the hands of experts, so I know of a few surgeons who are doing it very well, and so they do it and they are very happy. Coming to my method of choice, which is a distal burr technique, here what we do is we burr the distal femur with the help of a robotic device, and then we align and we make two pilot holes, and we align the jig for taking the rest of the distal femur cuts. So we use a 5 millimeter cylindrical burr to drill the distal femur, and we cut the distal femur with the help of the burr, which is a cylindrical burr. I use it on a burr mode, and we make 2 pilot holes. On this pilot holes, we then align our APCC block and take the further cuts of the distal femur. So this is a flow chart. How do we go for it? So first step is to drill burr the whole distal femur. We've seen various demonstrations how we do it, and then we make 2 pilot holes and then align the jig to it. The tibia, we do it routinely like a normal navigation tibia, or we can make a burr cut guide to the tibia and cut the tibia with the saw. So this is what distal burr technique is. So a small video demonstration, I'll just show you how we do it. So we've already burred one of the condyles. Now we're doing the second condyle, and it's pretty fast. So the advantage of doing a distal burr is it's pretty fast, and it gives me an accurate cut. It does not, I have no fear that my cut will be wrong or deviated. Even if it's a hard bone, it will be very perfect because it's using the robotic assistance. So for hard bone or for a soft bone, the cut would be accurate, and it will only remove the part which is we want to remove. And then we change to a speed control, with which we make 2 pilot holes to align the femoral cutting jig. And we use a targeting device also, which is, so the robotic has a targeting device option. So we put that targeting device, and we can align our burr guide to make perpendicular holes to align the femoral jig. And then routinely we take our APCC cut with the help of the block of the APCC block of the company. So this is what a distal burr technique is. So there are various papers which demonstrate why robotics is very important in avoiding errors. Most of the errors are which we encountered in doing navigation knee or a normal knee is through the saw, because once the saw crosses a certain amount of distance, there is a chance that the saw will scuffle off, and you'll have errors while doing cuts. So this is a cadaveric study which was published in the journal, and which showed that when we use robotics, the errors was very less. It was less than 0.1 and 0.5 degrees, and in flexion also it was very less. And there's one more paper which demonstrates that cutting errors while you're preparing femoral components in total knee arthroplasty, so which states that around 1 to 2 millimeters of error can happen when the saw blade is cutting a posterior part of the condyle. And this can be avoided by using a distal burr technique. So why distal burr? Because it's a hybrid method. It uses handheld robotic tool to prepare the distal femur and 2 pilot holes. It accurately positions my femoral cut guide so that my rotation also is perfect, and it speeds up my surgery, so it reduces my operating time. Thank you.
Thank you, Rohit.
I invite Dr. Mithali Vaidya to felicitate Dr. Rohit Luthra.
Any questions regarding burring options? I think there are 1 or 2 few points I want to add here, Rohit. I think with introduction of CORI, the new system from Smith and Nephew, this is imageless handheld robotics. Nevio was a prior one, so that time you have a 5 mm burr, which takes little bit time consuming procedure for total burring. But with introduction of that 6 mm burring from CORI, I think it takes hardly 1 minute more time for total burr. So the burring is faster in CORI system. That is one thing. So choice is yours. See, if you are comfortable with distal cut, no problem. But burring usually don't take too much time with this new 6 mm burr. Thank you, Rohit.
Yeah,
I think
just
question.
a good presentation, Dr. Rohit. Just a question. You mentioned 3 techniques. What is your study on the 3 techniques, and what are the limitations? You know, do you have your own literature on it? And I think the problem with using less of robotics is that, you know, there is a criticism that it's a navigation, it's not robotics. So the more we use less of robot, we'll be criticized for that. So what's your take on that?
So it's a very good point you made. The thing is, when you use so this hybrid technique which I'm talking about, which is a distal burr with 2 pilot holes. So what it does, it combines the best of both worlds. So you using robotics to take a distal femoral cut, so that you're not worried about your saw scuffling off from the jig. So your distal femoral cut is the most important cut, and it is very well aligned. Your varus valgus, your sagittal plane is perfect. And when you make 2 pilot holes, your jig also, your external rotation of the femoral component also is very well aligned with this system. So you're not bothered about, you see, when you do an all burr technique, the last option, you'll take more time, and secondly, it gives you fatigue. And see, that also is a very good option in terms of the result. But when I combine this hybrid technique, so the results are much better in my hand because I'm very well used to it and it's very fast. So I don't waste much time. So the most important cut is the distal femoral cut is taken with the robo, while the other cuts are taken with the saw. So that's how it works.
You looked at the timing. What's the time difference between the 2? How much time you saved?
Yeah, so when I did a full burr, I think I took around 12 to 13 minutes for a full distal femoral burr. And here I can, so burring distal femur, when I do it only distal femur, it's 1.5 minutes. And with the APCC block, all the cuts are done within the next 2 minutes. So it's hardly 3.5 to 4 minutes, we finish off the whole distal femur.
Thank you.
Another point I would like to make that for the distal femur, I agree that we do only distal burr rather than doing an all burr because it definitely saves time. But for the proximal tibia, I would suggest that we do a burr technique rather than the 2 peg holes. It gives us very good cementing for the proximal tibia.
Right.
That is a very additional advantage of the burr. It helps in better cement penetration.
Right. So again, I use a little more hybrid in that also. So what I do is I align my jig for the cut with the burr, and before I take the saw cut, I make a few cuts with the burr so that my saw is not going to scuffle off of the tibia. So then I do with the saw later on. The posterior part I do finish off with the saw.
One quick one. So if you are worried about time on the tibial side while doing an all burr, so what you can do is you can, once you know where your jig is going to be, you can actually take a tentative cut and remove that bulk of bone in the center with a saw, and then you can finish off with the burr.
Right. Perfect. Thank you.
One last question. Just a minute. Last question.
One question.
The burr was supposed to also give protection for the neurovascular structures, but the saw wouldn't. So how, do you differ in that opinion?
So here I'm taking the saw cut only for the APCC block. I agree that burr is going to protect the soft tissues, but even without robotics, when we do a normal TKR or navigated, we usually take care of our soft tissues. We make sure that there's no neurovascular injury. So the main idea of robotics is not to protect the soft tissues, but to give you a better result in terms of alignment and balance. So which is what is solving this problem. Okay. So I don't think it should be a problem. So
thanks.
If you're able to protect your soft tissues, then only you should do a knee replacement surgery. Otherwise not.
Absolutely, absolutely.
Okay, thank you, Rohit. I think Dr. Parmar is here in the hall. I will invite Dr. Parmar, tips and tricks of registration planning.
First of all, many thanks to Dr. Narendra Vaidya for giving me opportunity. My previous colleague has discussed regarding Ashish and Anup and everything, they discussed regarding OR room and everything. My certain points, tips, how make robotic surgery a little bit easier, less time consuming and less complication rate. First of all, we start from the pin positioning. Many surgeons prefer the pin position inside the incision, someone prefer outside the incision side. I usually prefer inside incision to protect the soft tissue. And I usually prefer pin position, metaphyseal, diaphyseal junction and little bit oblique. That is the first point. And usually unicortical, so avoid any pin related complications. Second is tracker area position. Tracker area is always should be kept like that in flexion and extension in both view. They should not overlap. So there is no any, again, rearrangement and everything. So always check both in flexion and full extension. Third one is a hip center calculation. Since morning we are discussing many times, there is a collecting hip center is very difficult. So I usually do one thing, lateral rest, I usually using lateral rest, but keep little bit loose. And I do usually in 30 degree of hip flexion and little bit abduction. So it will be very easier. Sometimes it is very difficult in that position also. So you can take also in external rotation and knee in full extension also. You can collect hip center. That will be easier. Now little importance of neutral position and collection of pre of flexion range. This graph will give some clue. If your graph is not complete in flexion range of movement, there is little bit few blanks. So there will be the FFD. So while balancing your knee in graft, you should more focus on femur side. That clue will be get here. Prop tip position. Nevio usually gives some size little bit higher size. Suppose your femur is 6, 5 or 4, then Nevio usually suggests one more size higher. So avoid little bit less or come near to proper size of femur. Your tip should be touch the bone, not the whole prop while mapping and everything. Special point verification to avoid the notch and properly judge the epicondylar axis. One more on the anterior cortex of the femur and both on epicondylar axis. That is with pink mark. Gap assessment. Gap assessment, sometimes it is very difficult to gap the full range of movement. In that case, you can arrange gap in 0, 30, 60, 90 degree. And if you are comfortable in varus valgus stress view, then you can do in full range of motion also. Implant planning. This is the important step here in implant planning. Nevio usually give one size higher in graph. So usually do one thing before planning implant, just reduce your femur size 1 down. And second thing, first of all, make your both the graph, medial and lateral, parallel, whether it tightness or loose, then it will make your job little bit easier. That by moving little bit your femur and tibia. I accept up to 2 degree of femur varus, sometime 1 degree varus on femur component and 1 degree in tibia. First slide show that there is a medial tightness and lateral laxity. Done the femur component 2 degree varus. Now see, there is both the graph is parallel in second slide. So it is very easy to manage. Now you just move the femur little bit up or tibia little down. Then it is possible. I usually extension balancing first, then flexion balancing. That you can manage with little bit external rotation of your component. I usually accept up to 4 to 6 degree of external rotation of femur and making graph parallel. After that, there is a tightness in both femur and flexion and extension. Then you just move little bit tibia down, and the tightness is only extension, then move little femur up and then balance it. Now come the most important point, soft tissue release, to be or not to be. That is the always question with robot. Many surgeons prefer that you should release soft tissue and preserve the bone. But ideally you should mix the both, release and cut. Gap assessment graph will always give clue whether soft tissue should be released or not to release. Look at the first slide. The first slide is look little bit benign graph. Tightness is both in flexion and extension. There is no looseness. Such type of graph you can manage such knee usually without many soft tissue release. Ideally you can also call the zero soft tissue release. And second one, that is not possible without soft tissue release, that graph. You should balance both soft tissue release and both bone cut and component position variation. Yeah. See, first graph, yes, where there is a soft tissue release is there. Second, there is no soft tissue release is there. Few cases, Anup has already discussed that case with implant, that femur nail, the graph look little bit benign. A tightness is both medial side and lateral side. And I just move the rotate component in a flexion and make the graph parallel. And now it is balanced. Now it is planned for execution. After surgery, gap assessment is throughout the range of motion, less than 1 mm movement, both sides. This is the final X-ray. Case 2, 67-year male, around 25 degree of valgus knee. Here only bone management is not possible. Soft tissue release and bone component rotation and alignment will help little bit more. Gap assessment. You're done those. I accept internal rotation 7 degree femur and balancing and final assessment. And the final picture. Thank you.
Thank you. It was very nicely explained. Can you elaborate a little bit more about how to gain the center of hip rotation more accurately and in a more faster manner? Because it's kind of a tricky, we think.
In few early cases, it is little bit difficult, but you just kept your lateral side support with a little bit loose and take in little 13 degree of abduction and 16 degree, 40 to 50 degree of flexion of hip. You just rotate your hip, then it will be easier.
Thank you.
I invite Dr. Mithali Vaidya to felicitate Dr. Narendra Parmar.
Our next speaker is Dr. Mukesh Ladda from Nagpur. He will speak on accuracy of femoral component external rotation with all burr knee arthroplasty.
Good afternoon, everyone. Thanks to Lokmanya Hospital and Dr. Vaidya. So my talk is on accuracy of femoral component external rotation with all burr robotic. We all know the success of TK depends on proper limb alignment, accurate component placement, and precise ligament balancing. We have published an article recently in 2021 which states that the overall limb alignment with the help of all burr can be within 1.2 degree. Whatever philosophy you believe, kinematic, restricted kinematic, functional, or mechanical, you can get everything with robotics within a range of 1.2 degree, and the component malposition is also less than 1 degree in both coronal and sagittal plane. But we all know that femoral rotation also plays a very important role for normal patella tracking as well as for flexion gap balance. Hence, to have proper knee kinematics, the femoral rotation plays very pivotal role. So when you get a rectangular gap, you are happy because your patient will be happy, but how much external rotation we want is still a big question. Lot of techniques have been described in literature where we use in conventional method like spacer block, tension jigs, lamina spreader, anatomical landmarks, white side line, posterior condylar, transepicondylar, navigation, patient specific. This itself speaks we are not yet reached what is best to get external rotation of the femur. In this recent article in Journal of Arthroplasty says that if you follow 3 degree of external rotation, you are tend to be around 50% error with surgical epicondylar axis. So 3 degree should not be the norm. This is what the paper says in 2021. Way back in 2007 also, it was saying that with conventional, you have internal rotation of around 3.3 degree to 5 degree external rotation. Navigation also have that deviation from 4.7 degree internal rotation to 2.2 degree. Navigation has helped to improve that rotation, but the mean deviation was also too much. We all know that mal-rotation of femoral component will have patella subluxations, patella wear, instability, dissatisfied patient, and that unexplained post-op pain. So with all this in my mind, the aim of our study was to assess the precision of femoral component external rotation with all burr TK. It is a prospective study of 30 patients where we have included primary and secondary osteoarthritis of the knee. Exclusion were revision and partial knee replacement. All procedures were done with Navio all-burr robotic TK performed by single surgeon. Post-operative CT scans were done in all 30 patients to assess the external rotation as per our intraoperative planning. Philips 128 slice detector metal subtraction reduction was done within 6 weeks of the surgery, and all the CT measurements were done by 2 radiologists who were unaware of the intraoperative findings. So this is what I keep it 0 degree to my posterior condylar axis because I don't want it 3 degree for all my patients. So once you have done your surface mapping and the stress x-rays, you get this kind of map where you see their flexion medially is tight and laterally is lax with 0 degree of rotation. So how you plan your rotation, it depends on your soft tissue balance, and the rotation should be within limits. It can't be 10 degree or 15 degree. So here I know that I'm little tight in flexion, so I'll plan accordingly and converted my external rotation to 4 degree where I have balanced my lateral gap both in extension and flexion. But I'm still tight in medially both sides because I know when I'm going to remove that much of bone, up to 2 millimeter, the ligaments and soft tissue get released. But if you have significant osteophytes posterior medially on femur and tibia, this tightness may be up to 4 to 5 millimeters because we know that much of the ligament will and soft tissue will get released. And then you perform with all burr robotic TK, and you can easily take out the posterior as well as all aspect of the bone with all burr within a minute or 2. And then you see how the ligament got balanced very well right from 0 to 90 degree, and this tightness has also become lax to say 0.5 millimeter without much releases of the soft tissue done. So out of 30 patients, 13% had 1 degree external rotation, 2 degree was there in 23%, only 37% of patients had 3 degree external rotation, 4 degree was there in 17%, and 5 degree external rotation was there in 10% of patients. So now, was it replicated in post-operative? So all patients underwent CT scan. The most axial cut was taken, and the line passing through the most distal part of the metal called as femoral prosthesis posterior condylar axis was marked, and then the radiological transepicondylar axis was marked, which is from lateral epicondyle to the medial sulcus, and the distance between the two was calculated as the external rotation of the femur. So there was a very strong correlation between the planned and the external rotation and what we achieved on the CT scan. The minimum was 1, maximum was 5, and what we achieved was 1.25 and 5.5. So there was a very strong positive correlation. Other important finding of our paper was none of the femoral component was in internal rotation. Again, the same slide, I want to emphasize that 3 degree was only required in 37% of patients, and the mean deviation was 0.24, minus 242 plus minus 28. And once you achieve that, you have quite a stable knee, both in flexion and extension, and a good patella tracking throughout the range of motion. And when you have that kind of balanced knee with whatever philosophy of alignment you believe, patients tend to recover very fast when they are in your hospital itself doing all activities within a couple of days. And when they go home, they have quite a comfortable walk and no instability complaints even before suture removal. Same another case, a 82-year-old gentleman with severe varus, unable to walk without support, and this Navio robotic all-burr made him get rid of that walker and quite stable within 3 weeks of the surgery. The limitation of our study was it's a small group of patients and we have not done any functional outcome. But the conclusion was that all-burr robotic provides accurate femoral component external rotation and plan with deviation to around 0.3 degree from whatever you plan. So alignment philosophy you can plan with less deviation, component placement also with less deviation. Hence, all-burr robotic will help you to get that precise component placement in all 3 axes as well as a correct alignment as per your philosophy. Thank you.
Good afternoon. I'm Dr. Mukesh Mohan. Just wanted to have one question. Among these 30 patients where you have done this all-bore external rotation resection, in how many of these patients do you get the perfect piano cut?
Perfect?
The piano sign.
Piano sign will depend on if I am having 1 degree, it may not be the piano sign. If it's 5 degree, I'll get that piano sign.
Right.
Or 3 degree plus. So it's not about piano sign or anything. I think what we have learned from conventional, this piano sign, it's a soft tissue balance, no bony surgery. You have to mix everything to get correct out of it. So it basically depends how you can play within comfortable range of bone cuts and then how you do sequential release to get that perfect rotation as well as alignment and balancing.
So you accept whatever the amount of the sign, you are not aiming plan for the...
No, I am not aiming about for that piano sign, I am aiming at the rectangular good flexion gap.
Right, thank you.
What is the point that has been taken on medial epicondyle? Is it the anatomical or surgical medial epicondyle?
Surgical point on post-op, it's the sulcus in the medial epicondyle. Just below the medial epicondyle, there is a sulcus which is taken as the surgical epicondylar axis.
And this has been taken in the preoperative CT scan also the same thing?
No, this Nevio doesn't take preoperative CT scan.
Okay.
So if you see that first slide where it was 0 degree marked, you can see that it still doesn't go through the medial epicondyle, it's just inferior where the sulcus is.
And what is the guarantee that did you register properly the same sulcus intraoperatively? What is that guarantee?
It's what the augmented reality robotic is helping me to get that. That's the guarantee.
You can err on that side or this side, and that area of visualization will you see in the monitor? That sulcus area?
This one. It's not exactly at the medial epicondyle, sorry. See here. This is lateral epicondyle and this is medial epicondyle, it's below.
Okay. Thank you.
Excuse me? Amongst your studies, how many cases were valgus knees? Any experience?
No, these all were varus knees.
All were varus knees. So it would be interesting to see the amount of external rotation or internal rotation we get in valgus knees.
We can do that also.
Sir, as you rotate the femoral component externally as much for the gap, but did you not find that the femoral tip is going out of the bone?
The out of the bone femur will go if you shift it more mediolaterally.
I'm asking the tip on the upper surface.
Flange. You are asking about the flange.
Flange.
In upper surface also, you may say you are asking me that the lateral anterior flange will go outside the lateral cortex.
Yeah, that's it.
It doesn't depend on rotation. It will depend on mediolateral placement of the component. More external rotation will cause anterolateral notching, but not the shift.
Okay, thanks.
Thank you, Mukesh. It's a very nice presentation.
Thank you.
I invite Dr. Mithali Vaidya to felicitate Dr. Mukesh Latta. I invite the chairperson and the co-chairpersons, Dr. Rakesh Patil, Dr. Shubhang Agarwal and Dr. Anubhav Jain to be felicitated by Dr. Mithali Vaidya.
After lunch, I think it's a very interesting case by Dr. Vaidya. Live surgery will be there in half an hour. So be here after lunch in around 30 minutes. We'll have a very interesting case. Be present at 2 o'clock.
Dr. Rakesh Patil. Dr. Shubhang Agarwal. Dr. Anubhav Jain. a visual delight or a nightmare? We'll witness the master stroke as Dr. Narendra Vaidya performs surgery on the sheer gore of an X-ray. I request everyone to be kindly present after the lunch on time to demystify the complexities of this X-ray. We start the live feed of the surgery at 2 o'clock. Thank you.
ஒன் சைடாக தானே இருக்குது லைட்டு.
Bhavana, check.
We'll start the live feed of the surgery in 5 minutes.
Dr. Vaidya? Baba, can you open up Dr. Vaidya's mic?
Yes, sir. Sir, your mic on, sir.
Dr. Vaidya?
Yeah.
Anand here?
Yes, Anand, yes.
Sir, we want another 5 minutes to get the audience inside. Sir, please hold on.
Yeah, sure.
Thank you.
We'll start with the live feed of the surgery. Vaidya sir would like to discuss the X-ray and the operative plan. I would like to invite Dr. Satish Kade and Dr. Avtar Singh to chair the session. Thank you.
Good afternoon, friends. And now we are going to witness live surgery by Dr. Vaidya. And he is the man who actually started robotics in India. So this live surgery is about robotic surgery with kinematically designed implants. So over to Dr. Vaidya.
Yes, good afternoon everybody. I think you must have had some lunch and we are all set now.
But we are feeling sleepy now, so you have to make us.
I hope that they don't doze away. Anyway, so the case is quite interesting case, and so I think that might keep them awake. So Avtar sir, I am going to demonstrate every step because that is where the people are interested, how the pin placement and everything. And I have not started the case incise because I wanted to demonstrate every step. So it may take 5-7 minutes more.
Sure.
So about the case, now case is a young rheumatoid patient, relatively young patient, where we are going to use a PS implant, and you can see on the X-ray. Just are you able to see the X-ray? Yes.
Yes, now we can see.
Yeah. So there is a severe valgus, almost 35 degrees of valgus with subluxation, and we have a big tibial defect with the hypoplastic lateral condyle of the femur. And the most terror part of it is that the patella is completely subluxated laterally.
Yes.
So it is going to be quite a soft tissue, balancing challenge also in this case. And so now I have my colleagues all ready, so I will start the case now.
Sure.
And you can see big bone defects also, anterior osteophytes also. Yes. Just move this light, that glare will go away.
And you are going to take medial parapatellar or lateral parapatellar?
Yeah, I always go medial parapatellar, lateral parapatellar. To take this patella on the medial side, which is already subluxated on lateral, is going to pose a challenge. And so I will take a routine medial parapatellar. But at the same time, what I do is that something which is called as a proximal and distal alignment procedure, if required, I will advance the vastus medialis on the patella.
Right.
So I can, get it right. The tracking should be this thing, because I think there are two challenges here. Number one is correcting the valgus, and number two is getting this patella to track properly, because it is there, and it is hypoplastic also. You can see now this is the patella here, and the femoral condyles are here, and here we have this notch. So it is now completely here, and that medial retinaculum, you can see it's completely attenuated. So I can take this opportunity to advance the vastus medialis obliquus on the patella. So I'm opening up on lateral side. I have a plan to do a lateral retinacular release also, and I'll be doing it from outside in technique. So that is
you
why
will
I'm
do the release beforehand or you will do it afterwards?
I'll do afterwards, because then I will have some sort of choice how much to release. So I'll just expose the joint and then do the routine things. Knife.
Sir, Satish
Even
here.
the tibia is also slightly externally rotated. So I'll.
Sir,
Yes.
what precaution have you taken while positioning the limb, especially in this case?
Sorry?
What precautions you have taken regarding position of limb?
Position of limb.
Yeah.
Position I have kept usual. Actually, there is a restriction of flexion also. So actually, we have a lateral post here and a stopper for the leg. Nothing very different than the usual case. You have to ensure that when I mark the center of the hip joint, that limb is able to rotate. So
yes, that is
my
very crucial
exposure
step.
is almost done now, and you can see the patella is really terrible. It's all destroyed here. And are you able to see, or there is a glare?
Yes, yes. You
I
can
think
just,
there is a glare. Just move this.
focus it
this
a little
light.
bit more.
Move this light. Better?
Yeah, it's better now. It's good.
So I will take out now all the patellar fat pad and everything. Now the most important challenge in such cases is to, the laxity of the MCL. Contractures of lateral collateral can be tackled by releases or epicondylar osteotomy and many things.
Right.
But the medial collateral ligament is always very much attenuated, and that's why.
So do you do any medial release as well, a little bit? Or you don't release the medial collateral?
I will just take a little bit, about 1 centimeter. It is not a release per se, but enough to take out the bone. So there are a lot of loose bodies also inside the joint, so I will excise them all. Nibbler.
And can you describe the distal femur, especially the,
I
the
will,
lateral
I will,
condyle?
I will show that. Just I'll expose it, and then it is all destroyed. Normal anatomy is completely destroyed. If we don't have an intercondylar notch here, you can see that it is all closed with the osteophytes. So I will have to release all these osteophytes also. There are lot of hypertrophied anterior part of the femur also. You can see, you can take the camera on the top so they can see this. You can see there are huge anterior osteophytes as well. Suction. Suck the perfumes.
Babu, can we have a top view, please? Babu, back left.
So now what I will do is that first step, I will take a osteotome and do a subperiosteal release of the anterior structures so that my knee becomes a bit loose because they are quite tight. So I am just releasing it subperiosteally.
And Dr. Vaidya, do you always use tourniquet or you are using it just
Yes,
for...
I always use a tourniquet.
Okay.
I take a parapatellar approach in thin patients, and straightforward I do subvastus. For my unis, I do a midvastus approach.
Right.
So now we are done with the primary this thing. I won't release more than that. Then I keep this osteotome below the MCL, to protect it, and I'll convert this inhuman patella into a human looking like patella. I'll try to make it a bit even because there is just a cup which is because of the chronic pressure there. We will see if we have to release it, we have to replace it later on because the shape is really bad, but the thing is that it is slightly thin. So I'll take out the osteotomes and osteophytes.
And would you like to replace this or you just remove the extra bone? Or patelloplasty, what do you call it?
Yeah, I'm just doing some patelloplasty and taking out, Nibbler, the osteophytes. So I have my regular team. I have Dr. Rakesh Patil assisting me. Dr. Anup Pachange is there. My anesthetist Bapu and Praveen are there.
Great.
And Hari, who always is there for, for my cases.
All the
And
best to all of
Ashwini.
you.
Yeah, we require it. Yeah, so the important thing here I would like to say that just like in a varus knee, there are always osteophytes on the
medial side,
lateral side also,
Here on
and
the-
there is always a overhang. So like we take out the osteophytes on the medial side, we have to take out that also. So I'll start from the medial side. So this is very important to remove entire osteophytes because that will decompress my ligaments, and we can get the graph, more realistic graph and mapping.
Hello, Narendra.
Yes.
Sunil here. Is it compulsory to remove medial osteophytes in valgus cases?
I always remove, yes.
Because MCL would be more lax then.
Yeah, it will be, but that osteophyte, keeping that osteophyte will not help us. That will continue to pain and poke on the medial this thing. So I will have the natural, ligament completely decompressed.
Okay.
Anybody from the audience is most welcome if they want to ask about any step in the surgery.
So I'm reviewing the intercondylar notch osteophytes. It's really completely plastered. Now I'll go on the lateral side and remove whatever is possible at this stage and remove the lateral osteophytes, the anterior osteophytes also. Now being a lateral defect, now I would like to just explain how I manage these valgus cases. The valgus can be correctable in flexion or extension. Number 2 category is that it can get partially correctable or completely correctable in flexion. So in that situation, your releases have to depend on that. Nibbler. So if the ligament is getting corrected, if there is a deformity is getting corrected, that means you don't require that much of a lateral release because the length of the ligament is then maintained. But in cases where it is not getting corrected, like this case, you will require some releases. So I am going to do a PS knee here. So taking out the posterior cruciate. Right. So now I am ready for my pin placement. Goodly. Nibbler.
Dr. Vaidya, if it's getting corrected in extension, then what is your choice for releases? And if it's not getting corrected in extension, then?
See, if it is getting corrected in extension, that means your distal femur is good. And the posterior femoral condyle is a problem if the deformity is in the flexion.
Yes.
So we can actually adjust all the components accordingly, pins.
Right.
If it is getting corrected in flexion, and the deformity persists in extension, that means the distal femoral defect on the lateral side.
Yeah.
And if it is there in both, that means there are 2 possibilities now. Either number 1 possibility is that there is a tibial defect, like in this case, or there is a hypoplastic distal femur as well as posterior femur.
Right.
So this case is a combination of both.
Sir?
Yes.
What are common tips for placement of pins? What you will advise to
See,
young
there are a
generation?
couple of methods. Now, most important thing is that the pins have to be unicortical. You should not pierce the other cortex.
Other cortex, yeah.
Because that makes you a problem. The femoral pins I place about 3 to 4 finger breadths above the superior pole of patella.
Correct.
And the lower tibial pins, I place it.
You always take it perpendicular on anterior aspect of the femur?
I have tried with the oblique pins like this, 30 degrees oblique.
Medial.
But it sometimes doesn't get visualized when you are taking center of the hip. So I have preferred to always take antero-posterior.
Correct.
And in this particular patient, do you anticipate the use of stem extender on tibial side?
Yes. I have kept a stem also as well as a semi-constrained liner also.
So that means you have to distalize your pin insertion in the tibia.
I will remove it if when I take a trial and if I don't get a balance and I put a constrained liner or something.
Right.
I will remove these pins and till that time the trials will be done. काय चाललंय रे ते हे लावून द्या. So you have to make sure that the arrays are facing the camera. So I have my Cori system ready here.
Right.
You can see that this is like a, just show the setup from a long angle.
Excuse me. Sir, what is your ultimate goal? How much varus or valgus you want at the end?
Yes, sir. Anup. Pins. One more thing I have started is to put these pins here. They act as a self-retractor, you know, for the medial structures, and my assistant on the medial side can move away so I can see the camera can see my arrays.
Dr. Vaidya, there is one question from Dr. Prakash from Amritsar.
Yes.
He wants to know your ultimate goal of alignment in this patient. How much valgus you want to retain or you want to achieve varus?
No, I'd say my ultimate this thing, I will try to do kinematic alignment, and my aim will be to go into 1 to 2 degrees of valgus,
Right.
maximum, but varus I will not keep. The system is getting disconnected again. Just see what is happening.
So I think it's clear.
Nice. Saga bande. They perth restart. Dr. Avatar Singh sir, there
Yes.
is some connection problem, so I'll pause for a minute here.
Okay.
Because they have to again restart the system. Once they attach the camera of the outgoing camera, it is getting shut off. So
Not an issue.
just give me a minute.
So in the meantime, we can gather questions from the audience and I can keep on asking him from time to time. So anybody having any query, just can write it and give it to us. So you have used these pins as soft tissue retractors?
Yes, these small pins I keep it there, so you don't require anybody, you know, on the front side.
That's a smart idea.
Yeah. So I put it even for the uni also.
Right.
And I think the first demonstration, which was excellent by Dr. Suri and Ashok,
Yes.
they were standing on always the right side. I was to always stand on the leg to be operated. So in medial also, uni, you can just do, you know, put these pins and one retractor behind the PCL. So, you know, it gives you a great exposure.
Yes. And standing on the right side of the patient, I think it's a great idea actually. The first time I'm seeing this, standing on the medial side and doing a uni. Normally we stand on the lateral side and do it.
Yeah, I stand on the same side of the leg to be operated.
Yeah.
काय चाललंय रे?
Yes. That's a good idea actually.
Let's hope it, 3 times they have said hazala, so I don't know. Okay.
Yes. There's one question, Dr. Narendra.
Yeah.
That do these pins, they affect your gap balancing or the stress range of motion?
These pins?
Yes.
The retractor pins, no. They will not hinder in my
So I think they are flexible K-wires, I think.
Yeah. Yeah, this is our pins for the jig, conventional TKR pins, whatever we do.
Right.
These are the pins for that, unthreaded. So I want the screen to be, you know, projected there. Can you connect it? Otherwise, focus it on the that camera. So I want the picture bigger on this now, more than this. Show the system in the bigger box and show the operative. Yes, correct. So this is the first screen what we get here in Cori system. So now you can do a mechanical alignment or you can do a kinematic alignment. If you want to do a mechanical alignment, you can choose this skip. But here I plan to have a, you know, kinematic alignment. So I'll do collect. So I do this stress range of movement. Then you can customize your plan. You can use PCA, you can do epicondylar axis or whatever manually defined. So here it will double confirm after we do the mapping. Then the initial resection depth I have kept as a default and I will be doing an anterior referencing. So the next step is to ensure that all the components are visible. After that I start registering. I don't put this screw. There is a small laser mark here which is taken here. So I avoid to put that one more pin which some surgeons put there. Standard registration here. It is very difficult to identify the center of the tibia. So I have done that. It hardly takes any time. So Rakesh. So my test collection is done, and then this is the neutral position, non-stressed. range of motion. And I am done. Now I will start mapping. So you can see that it's a really very fast system. And the camera
Can you
is...
zoom out the operative field?
Babu, can you give us a wider view?
Yep, that's better.
No, konja perspune.
So I am doing the mapping and the femur is being mapped, you can see. Now here there was one question earlier, somebody asked whether you can identify the epicondylar axis, again. So now there are some pink sort of lines which I will show. If you want to have special points, like Dr. Rowinsky also showed, the notch point he does, then you can do it. So I have now painted all the femur. And actually there is very little scope for error here, as you have to just, it's like a child's play, to just move it on the bone.
Sir, how
Yes.
much stress you give during laxity collection? Any tips regarding that?
About?
Laxity collection, stress.
That I will come to that point, Satish, because I am still mapping. I have to go for stress ROM later on.
Yes,
So we are yet to do this. Now you can, have epicondylar axis or whatever as correction. I'll take as a PCA right now. But most important thing I'll mention here is that these all things become very, have a limited importance, because ultimately I will aim for balancing and not look for a particular point. And then there was a lot of debate that this is just, navigation. So it's not like that. I will be, manipulating it and watching it throughout the range of movement. And that will ensure that my points, and the computer is collecting a lot of data. So you can see there are thousands of points which are collected, not only like navigation. So mapping is much more accurate than just points which are corrected. And now this case, for example, a CT based this thing, it will be really tough for any technician to determine what this thing they are going to do. So which sections and which is the bone. So the surgeon has to really spend a lot of time in doing this. So now this is the standard screen which comes first. You can see that, this is a sticky image where you can see the femoral component, how is it sitting. It will give you the size. And the second is a line diagram. You can see that these are line diagrams, and then where you can see the yellow is the bone and the gray or silver is the implant. So here you can see it is removing very little of the lateral condyle as expected, that it is hypoplastic. Posterior side, it's quite okay, 10 millimeters. So I will accept this at this moment. I can move the implant anyway, wherever possible at the balancing stage. After this, now there is a stress collection. Now Satish, you are asking me how much correction, how much
Yes,
force
sir.
you give. So I went one step. Yes.
Do you use any spoon or that Z-Retractor kind of instrument to collect this?
Sorry?
Do you use any instrumentation like a spoon or a Z-Retractor, what they have in the instrumentation?
Actually, I use Z-Retractor for only unis, not for my... And force is a physiological force. I will not apply a brutal force here. That's the only key. You can see the extension. It is getting, very tight. The violet lines, they are my lateral compartment. And up to 30 degree, it's in extension, it is very tight. Whereas in flexion, lateral seems to be loose. So this is the graph, and I am giving the valgus stress, and to my good, surprise, I am not getting very great laxity on the medial at this stage, at least. So I hope that the ligament holds on there. So now we have to balance it. So we have to now, we get this kind of pictures here. So you can now start playing with this, and I will just...
So can you enlarge the screen now?
Yes.
The planning stage.
And if you can spend
Remove
little more
the-
time on
correct.
balancing, because normally we get lots of varus and flexion deformities.
Correct.
These deformities are rare, and we find it little more difficult to balance.
Yes, so now the thing is that in varus, I have done extreme kinematic alignments with combined varus of 6 degrees, 7 degrees also, that is 4 degrees on femur and 2-3 degrees on tibia. But on valgus, I generally don't do more than 2 degrees of valgus on the femoral side and a degree of valgus in tibia. After that, if it is still, you can see that both the bars on the left side, they're below the line. So that means it is tight in the extension there. So I will just increase my superior cut. It's now red sign which is coming is notching. So I will keep it presently like this, because you can then release and get it right. And you can just have a more rotation so that my lateral side, which is very lax in flexion, is very peculiar sort of a joint here. And I will increase my flexion or take it anteriorly a bit to avoid notching, because it is giving me a sign of notching here. So I took it a bit of anteriorly. Now, only thing I will try is to increase the size and see if my flexion laxity is getting corrected. So yes, it is getting corrected. So I may go for a size 6 instead of size 5, but I have to see that it doesn't get an overhang. So I'll prefer size 5 here. And we had 17 degrees of valgus and 3 degrees kinematic I am accepting right now. And then start with, you have burring options like many speakers have told. I will take a distal burr here, and for...
So you have explained the balancing in flexion, balance the flexion gap. Can you explain a little more about the extension gap?
Extension gap is very simple actually. Extension gap, you have to just move the femur distally or proximally. So you get all 4 values around 9 to 10 millimeters. 1 millimeters can be adjusted later on.
Right.
So I will take an initial tibial cut on this twin peg jig and then burr the whatever extra bone is there.
Sir?
Yes.
How many cases you took to shift on this anatomical, shift from mechanical to kinematic alignment?
Now I am doing almost all my cases as kinematic or restricted kinematic or a complete kinematic alignment only. So,
So how was the learning curve for you?
Learning curve, you have to, start with smaller deformities. You can see very less bone is being removed on the lateral side.
Yes, hardly any bone to be removed.
Hardly any bone there. So we have to do these 2 lug holes which are there and put that jig, and then you can see this removes bone like, very easily. Corey has got a very, you can see this very large burr coming out and in. So you can see it is removes at 1 stroke.
Yes, much faster than the earlier
Very
one.
fast, yes. So this is a virtual image which is red is around 3 millimeters or more, blue is 2 millimeter, green is 1 millimeter, and white is where we intend to go. Sometimes people get a bit concerned when that red shadow comes, but red doesn't mean that it is removed the bone.
Yeah, it really doesn't matter.
Yeah, it doesn't remove it. It tells you that you are in the danger zone. So it doesn't cut the bone. And the reaction time of this camera of the Corey is almost 5 times faster.
Right.
So there is hardly any time that you see, the bone being actually damaged, an unintended bone. Again, there is a provision for a lug hole here, which I'll do. And you can see the cut. Can you zoom in here and show? This is almost like a saw with this.
Yeah.
So then I will check my cut with this. You can see that it's absolutely
it's perfectly
perfect
fine.
now.
Yeah.
So after that, now I'll put my 4-in-1.
Sir, do you find any difference using burr and systems using saw?
So say again.
Do you find any difference in systems between using burr and saw?
Yes, I have using Rosa also in some cases and this. But if you see the accuracy, this burring scores over the saw, because saw can sometimes get skived up, or it can get dipped up in the it can get dip involving for that digital involving.
It can get deflect.
Yes, it can get, no, in osteoporotic bone, it can just go this thing. So you can again correct the rotations and everything here. I am applying this.
And you are going in with size 5. Or
Size
6?
5, yes.
Size 5. And at this stage, do you check it manually whether you are notching it or not?
Nowadays I don't.
Okay.
I believe the system. Earlier I used to, when I started new. Arjunik there.
And if you are notching and still you have to use a smaller size, then what remedy do you have? Suppose your tibial size is not compatible with your size 6 and you have to downsize to size 5.
So I couldn't hear. Can you please repeat?
If your tibial size is suppose not compatible with your given femur size.
Okay, I have to reduce the size.
Yes. And then how do you avoid notching in that scenario?
I have to then cut the distal femur also more, because if I undersize in anterior referencing, my posterior flexion gap will increase.
Right.
So I have to increase my extension gap. So a couple of millimeters distal cut of femur, I will go back in the system and take out 2-3 millimeters of bone. Generally the sizes for this Smith & Nephew implant, there is a difference of about 2 to 3 millimeters between two sizes. So just couple of millimeters of bone removal solves this issue.
Right. Or another remedy can be that you can give some flexion to your femur.
Yes.
That can avoid notching.
You can tighten that also. You can go for a total burr with this, which is very easy.
Yes.
One, word of caution, that since this is a rheumatoid patient, I have seen sometimes that the burr, which is very aggressive in Cori, removes a chunk of bone from the condyle.
Right.
Okay, so you have to be very, very careful when you are actually removing the bone with a burr.
On the face of it, the bone looks pretty sclerotic.
Yeah, this seems to be quite okay. Subluxation. So I have done my femur, and I will go for my tibia now. Sarak.
So you do all burr or you...
No, what I will do is that I will take a tentative cut here, and then, I get over this sclerosed portion and then refine with my burr.
I think that's a better idea than...
Because, burring this sclerotic portion takes a lot of time. And if you have to do multiple cases, then it...
tires your hands also.
Yes. So there are some more osteophytes on the lateral side, which I am taking off now, which will decompress my lateral ligaments. Burr.
Do you need to protect the medial ligament also?
Yeah, I'll put a retractor while I'm taking a cut. Right now, I'm just doing this burr.
Okay.
Because if I put a retractor medial right now, the burr may be, it not be visible, the trackers.
Right.
So I am doing this lug holes, which will take my tentative cut.
So if you can take a freehand cut with a saw and then do the burr.
I'm a bit scared that I will cut more bone, sometimes.
Okay.
So it is better that I,
That can cut short your time, actually.
Yes. That's a... Hey, you are coming in between my camera. Tibia thoda zara ibu. So, there. So this is a twin pegs thing. I don't use it for a final alignment, but you can still check it and ensure that you are not cutting more bone, because that is one thing which is very important.
So just to take off the sclerotic part.
Yeah. So you can see that orange line is what is there. So I will, cut above the intended. Please, can you go back a bit? I am losing my signals. Yes. So keep some, safety margin here is my, suggestion. Medial retractor, Arjunik. broad. So my aim is to just remove the sclerotic bone here. It is not a final cut.
Yeah. That will make your life easier actually with the burr.
पिन पुलर चेक करा दे सोड थोड़ा anterior push कर okay so let's see what cut we have done. Can you go back please? Yes, so we have some safety margin here. So now what you do is that you say refine and start burring, so I get a final position.
So you have very little to burn now.
Yes, now I will, very limited this thing, and so whatever bone is now cut with the saw will be removed. We are refining this cut now.
Right.
And then we can start
The refining
cutting.
is like re-registering it actually.
Yes, you can say that. It is just, हे मध्ये signal कोणास तरी अडतोय. Yeah, burr all, yeah. You have to remember one or two tips here, that a bird does not see the femur when you are doing tibia.
Right.
So you should be very careful at the posterior side, though it will get retracted, but sometimes, if the femur is not retracted completely, so I always look at the screen and do it. So my associate who is there with me always keeps a watch that I am not coming. And the posterior portion, this rim, I keep it and then remove it with either nibbler or the saw.
Does this system have irrigation as well, along with the burr?
Yeah, the irrigation is on.
Okay. So it wasn't there in Navio.
That Navio, there used to be that tube, and there was irrigation, but no suction was there. Here the suction is also attached, and so you don't get that sort of bone dust which is there. So I'll wait here and see how my cut is going and check with this thing, and that posterior portion, as I told you, I will just remove it with. So you can see now I am perfectly all right within a millimeter, sub-millimeter. So I accept this alignment, and now I'll, using my saw, I'll just remove the posterior portion of it. That's it. Okay. There, pin. काय झालं हो हो अंत नको Gen 2 I am taking a Genesis 2 tibia so that if required and I have to put a stem, then I have a provision at least, at this moment. Extractor.
So now you're going to use PS poly?
Yes,
and
yes.
Okay, Genesis tibia.
I think I am going to be a bit tight on extension. So let's see. I'll release from posterior side.
Right.
Wait. And if it is still tight in extension, then I may have to take a couple of millimeters of femur more.
Right. And what do you feel about the flexion gap at this point?
Flexion gap is quite okay. You can see this.
Yeah, it looks fine.
Yeah, it looks okay. My extension gap is this thing. So
Sir, till now you have not released any structures on lateral medial.
No, I am going to take a bit of more femur.
Okay, so no soft tissue right now, till now, no soft tissue releases.
No soft tissue release I have done.
So you are feeling that
I am increasing my distal femur here by 2 millimeters, and so it will now, I will refine this because I have already removed some bone with the earlier this thing.
Dr. Vaidya?
Yeah.
Dr. Mukesh here. In planning, the flexion gap looks to be very lax.
Sorry?
In your planning stage,
Yes.
the flexion gap looks to be very lax compared to extension.
Yes, that's why I am taking a bit of more bone distal femur, you know.
So you are laxing more the extension,
yeah.
but are you planning anything to tighten the flexion gap?
See, I don't have augments or anything right now. And if you have to tighten the flexion gap, then I have to go for one size more. And then I will land up in multiple problems. Like Avtar sir was saying, my size tibia is 3 and my femur 6. They are not compatible. And then it's a problem. So it is better to take out 2 millimeters of femur distally.
Okay.
So the gaps become equal.
Dr. Vaidya, does the Cori help in tibial rotation? Does it look at the Cargill line? Or does it help with the base
Tibial
plate?
rotation, no.
Thank you.
They have still not come up with this, and you have to still go by the conventional landmarks of medial 1/3 of the tibial tuberosity and all those things.
Thank you.
So I will do the chamfers also with this now. So I don't have to put this thing, the jig, 4-in-1 jig again.
So this is all burr now.
Yeah, this is now all burr. So I am refining it with the all burr now. So I don't have to put that 4-in-1, take the holes again and do everything. So this is very easy now. Some green portion, some surgeons I have seen that they keep it like this. The anterior portion we have already done. So it is just refining. You can see that that will not get altered. So I don't need to go anywhere in the anterior side. And posterior also only some chamfer bone has to be removed here.
So in this system, in any stage of surgery, you can modify your sizes.
Yeah,
and
you can just go back and alter your plan. Very flexible system.
Was it there in Navio too? This
Yes,
one?
yes. See, basically, I think fundamental difference in the Cori and the Navio is in the hardware and the camera system, the cutting tools.
Okay, sir.
The beauty of this system from Smith and Nephew is that at any point of surgery you can go back and replan everything.
Yeah, and you are in charge of the case. Oh, yeah. नंतर आपण ते osteotomy ठेवले मी ते, if required. See, one, I think, message, we had very interesting discussions whole day. I think one has to remember the fundamentals of the conventional TKR. But there are certain things like, for example, the piano sign on the anterior side, the rotation has to be 3 degrees or 2 degrees. That concept is completely replaced by the kinematic graph, which is going to give us the balancing, which at the end of the day is the most important thing. That the knee is evenly balanced in an entire range of movement. Suction करायचं का तुला?
They all are smart now. Nobody's do suction.
No, we are missing Satish here, who always puts the suction and creates holes, you know. Akra.
So flexion gap doesn't look loose actually.
No,
It's
it is quite
reasonable.
okay.
Yeah, it's okay.
Yeah, I'll just see this. There is some FFD here, and I will check kinematically. You can see here, I'll just,
Tanmay. Mike.
So can we see it on the screen now?
yes, screen please.
What's the residual extension?
Yeah, can I ask one question?
Flexion,
There is
sorry.
about 10 degrees of FFD.
Yeah, Narendra.
So, yes.
This is a rheumatoid case. Can we keep 5 to 10 degrees of FFD?
Yes, I will keep about 5 to 10. I will not make it very lax. Absolutely right. So you can see that the graph is also within 2 millimeters of the intended thing. So I think, okay for the bone resection. I may do a little this thing. Now I have to go on the lateral side and remove some bone, which is I am palpating here a huge bone, loose piece, which we have to exercise, and that will balance it even more. Pin cut.
Sir, can you elaborate this graph or line? What is above the line, below the line, colors?
See, above the line is laxity, and this is the stress range of movement. So you can see that it is not opening up more than 2 millimeters on stress.
Yes, sir.
So if it goes beyond 2 millimeters, then you have to put thicker poly?
Thicker poly, yes, thicker poly, and increase the constraint if required.
Right.
So now what I am going to do is I'll see what is happening with my patella, and I don't expect it to track normally because it is too much shortened. I will have to probably now remove my pins and do these alignment things. So navio portion is, Cori portion is, I'm okay.
What's the residual valgus now?
Residual, I will just show the final report on this. So residual valgus is 3 degrees, 7 degrees on flexion.
That's
Sorry?
inflection, I think. What's the residual in extension, residual valgus?
Yeah, I have not changed the size of the poly in here. So that's why. So it is 5 degrees.
Yeah.
Yeah.
So
5 degrees of combined valgus is there, and we had. So I'll do some releases now. I will have to take out the pins. Anybody wants to see anything on the Cori, because now it's a completely soft tissue realignment procedure. What I have to do now.
So you can demonstrate the soft tissue release now.
Yeah,
we don't need to look
but
at
I
the
will have
Cori.
to. Yeah, I will have to take out this because the patellar
That's
tendon,
fine. That's fine.
It won't have to.
So can we see the final screen?
Final screen to hota na Satish. Now I have to again go back and do it, but I have taken it out now. That range of movement, whatever you saw on this thing, you asked me, na, or to explain that graph. That was the final screen. If I have to show you again the final screen, I have to start right from putting the pins.
Okay, sir.
So that's not.
Thank you.
Yeah, so now here I will do some inside just synovial release, and you can see the patella hardly is coming medially.
In such
Coccus.
patients, do you plan to give some external rotation to the femur in planning?
Some sort of?
External rotation to femur.
I didn't get it.
I mean, when patella is subluxating or subluxated,
Yeah.
do you need to give external rotation?
External rotation we gave, sir. This case we had a 5 degrees of external rotation.
Okay.
Yeah, we had to externally rotate it.
Right.
So now I am going to do a lateral release. It is going to be a long lateral release, and here I will try to preserve the synovium.
Right.
थोड़ा ओढून धर राकेश. Feel सांग. येतोय. So I'll just see what is happening with my this thing, and you can see my synovium is intact here, more or less. So with this, if doesn't happen, then I will osteotomize the tibial tuberosity and take some part of the tibial tuberosity from there on the medial side. So I will take a trial component now and see my tracking. Sorry. काय म्हणला गेलंय ना बघू ना तर ट्रॅकिंग तर बघू पहिले IT बँडच्या उडचं ना just put a cockers, let's see. I will have to do a, I think, alignment procedure. It's not going to stay there.
Not coming?
No, it is still going laterally.
Yes.
So I will release on this and tibial tuberosity knife.
Maybe you have to extend the incision a little bit.
Yeah, I will.
On the tibial side.
I'll get it right in some time.
And do you prefer the sliding osteotomy of tuberosity or some other kind?
For the tibial tuberosity?
Yes.
Actually, I do a combined proximal and distal alignment procedure, which I will show here. Okay. Now, this is my tibial tuberosity. Can you see here? Yeah. So, what I will do is I will take this knife. Trial components वगैरह घेतले ना हरिभो. And then I am going to take this, divide the patellar tendon in the center, and saw choti and a drill. He retract kar Anup. Put a retractor below this thing. Patellar tendon protect kara. So I will take some chunk of bone here.
Okay. With half of the tendon?
Half of the tendon, yeah.
Okay.
Osteodome. Chota.
And when you are creating this window, then surely you will use the extender, I think, for the tibia.
Stem? No, I will mostly not use it.
Okay.
Let's see, because it's a very small window here, and if I get my alignment, okay. So behind this patellar, this thing, I will take, you can see that now this is there with a good,
good
triangular chunk of bone, which I will take it below this tibial tendon here and distalize it. So pull, Rakesh. So you can see that it pulls it very nicely. Flex kar gently.
It's coming now.
You can see it is coming very nicely.
Yes.
So this is a proximal alignment, and when I am suturing, what I will do is I will take this vastus medialis, like told, and I will advance it distally. So it will have a proximal as well as distal alignment. So at this stage, I will now go for final implantation.
Right.
And then, keep this saw there.
Do you fix it with a screw?
Yes, we will have to fix it with a screw. But I will create a sort of a portion where I can insert my tibial graft, a small sort of
trough.
Yes, where I can chota osteotom.
So that it has to heal with the bone.
Correct. So it gives a great bone healing, and then I put it with a washer.
Washer and cancellous forearm screws.
Chota pa hai.
And what kind of washer you use? You use a spiked washer or the plain washer?
Spiked one.
Spiked one.
Yes. So this is what I am going to use later on. You can probably see it now. So that they have kept it ready.
And it's 6.5 millimeter screw or 4 mm screw?
No, this is 6.5 cancellous screw.
So will this piece of bone take such a thick screw?
Actually, I want just a fixation. It's like a lag screw. So it will hold a distal cortex. Yeah. छोटा तो नीला ऑस्टियोटम नहीं का बरं ओके ठीक आहे इम्प्लांट घ्या हे काढायला द्या काय काय पोस्टीरियर रिलीज osteodome actually just we palpate some bone here, so I'm going to take out the posterior osteophyte.
So why do you want to go? So we have to facilitate. Okay.
we can fill in that defect from where the bone graft is taken with bone plug from distal femur or something like that, which is there, which we'll do at the end of the surgery and just impact it there. नहीं क्या गरज नहीं खबर suction okay wash get implant. Are we within time or I'm getting late?
No, I think we
Satish?
are well within time,
So
and
you have more 5-10 minutes.
Yeah.
And everyone is enjoying your surgery, so you can carry on.
So Kasha. And I forgot about Ashutosh, I think, in my introduction. He is our third associate in the surgery. Drill. Thoda cementation la. Suction. This sclerosis portion is there, so I will make some drill holes for my better cementation.
Right.
Subluxation. So we use a Palacos antibiotic cement for all cases. हे थोडंसं ऐक ना हा बोन प्रोटेक्ट करायला पाहिजे टिबियल टिब्रॉसिटीचा ऑस्टोटॉमीचा सो हा आत येत नाही बघ नाही तो बेस प्लेटच्या खाली गेला ना क्रश होईल सावकाशी राकेश ड्रिल some sclerosed tibia also here.
So what will
Dr.
be
Prakash has a question for Dr. Vaidya.
Yeah.
what will be the post-operative rehabilitation plan in this case?
Actually, we'll start mobilizing her. I will see the secureness of my patellar tendon. Otherwise, I'll start mobilizing her. I don't see any reason not to mobilize. Range of movement, I will keep it restricted for about 3 weeks to only 30 to 40 degrees. And then weight bearing should not be a problem. But range of movement will be, protected range of movement. If we feel that there is some laxity, then you can give some brace for some time. But I don't think in this case we will really require any brace for that. सावकाश एकदम सावकाश जाऊ दे impactor knife poly trial as द्या हरिभो मगाशी किती जात होता तो काढ हे काढ
Dr. Suri.
Screw tire in, guys. Ellis forceps that here. As within the.
Any more questions from audience? Welcome.
Uchal Rakesh. Extend. So I will now fix that bone plug here.
Right.
And see if I can retract it still. No, I'll put a final one afterwards and then go for the fixation. But the only problem sometimes is the cement gets in the way of the drill. Hey, don't help. Ellis.
Can you demonstrate the patellar tracking by holding the patella with the...
I'll just fix it and demonstrate.
Right.
Drill. Knife, 11 number. Kya cautery de? Rakesh odun dar, khali dabun dar. So you have to aim it in such a way that you avoid the
stem.
Stem, yes.
Yeah. And this is 3.2 drill?
Yes. It's a self-tapping screw. Satik. वाकू नका फ्लेक्स ना करू. Yeah.
So that chunk of bone has gone into the trough.
Yeah. So this is patellar tracking, sir. I will see that this fixation has to be still more secure.
Right.
Because I have to, but patellar tracking is quite good.
Yeah, it's perfect.
Yeah. And your drawers also is good. Stability is good. So I think that was it. So I have to wait for the cement sitting. Any more questions? I'll take it.
So one question from the audience.
Yeah. So Narendra, Sunil here again.
Yes.
You didn't release IT band, you didn't release...
Nothing I did. I did a kinematic alignment with only 2 degrees or 3 degrees of valgus in femur.
Okay.
And you can see that overall leg is straight. If you do adjustments of varus valgus on the femur side, the X-ray doesn't show it that much.
Okay.
And the entire long leg alignment, it becomes absolutely perfect.
And there is no medial opening at all?
No major opening. The joint is stable.
Yeah. Thank you.
Only I had to do this patellar realignment procedure.
Okay, okay.
So friends, once again, 3 cheers for Dr. Vaidya.
Thank you.
Very nicely done surgery.
Thank you.
And in
Thank
such
you,
a
sir.
difficult scenario.
Thank you for great encouragement.
Thank you, sir.
Yeah.
And now I have the privilege to invite Dr. Suri for a small presentation as well as felicitation.
Yes, sir.
It's okay. Thanks very much for the invite. This was just a thing of last night when Vaidya wanted me to just speak a few minutes on this subject, how we evolved in the sense. I think most of it has been spoken already, actually. Our journey and rationale in this case. If you look at it, establishing neutral axis is a mantra, which has been not changed. The fundamentals of knee hasn't changed, and it's a proven formula for all seasons, and which is very clear. Conventional instruments works, 90% of us use it, we have been using it, we still continue to use in some cases, but they all had one little pitfall error. That's why the technology and the concepts changed. Most of this uses the bony landmarks, like the intramedullary points, the collateral points, epicondyles. But the problem is with this is that some of them are variable targets and some of them are blind positions. And the variable morphotypes of the femur and the tibia and the interpersonal variation, what is the center of the femur, is quite variable and they vary to various degrees. And if it is very clearly elucidated, if you have a femoral entry point and then you put in the rod to get a long rod or a short rod, even if the long rod is more appropriate, what you would find is there is still a considerable amount of play. 3 to 5 degrees, 6 degrees of femoral anti-torsion can happen, femoral flexion can happen, and depending upon the width of the medullary canal proximally and wherever you put. And that will also translate both on the AP and the medial lateral planes. Second point is if you have a short individual, the angle of divergence from the distal femoral point center to the center of the hip is quite variable. The longer the individual, mechanically I think you would be more central, but the shorter the individual, the variations can increase. And it is now very clearly established also with all our studies that this can be changed. The valgus correction point, our own people have published, Dr. Dhansekhar has published and many papers with regard to the medial point of entry on the femur to get it right. But in all this, I think there are two major downsides. One is the appropriate individual component varies, and very blindly we have to put it. And whenever you put the component in a little malalignment, that has an impact upon the spaces. So technologies in the OR basically helps one simple thing, I mean keeping it very simple, potential to place the components exactly in the desired position consistently. Is this a very paradigm shift in concepts? No. But because you are able to consistently reproduce this and appropriately place and balance, the function, the longevity and the client satisfaction is far superior in terms of the outcome, in terms of function. But whenever we are adopting any technology, we realized right much earlier that expectations of the out of the system, what do you expect is very important. The three cardinals before we get baptized into whatever type of thing, whether it's a navigation or whether it is a robot, conviction in the technology, you have to learn to believe the system. Because we are all in the visual range, and then whenever we have something deviation doesn't look like, yes, it is good to suspect, but we should not constantly suspect the technology and have some conviction, though of course you must counter check. And the perceived benefits, are you convinced it's beneficial either to your surgical procedure or to the outcomes, and a belief in the system. Second thing we always look for, I mean if you see over the time from the 22 years ago which you had, the earlier systems, smooth workflow is something which has happened tremendously, like in Avio and the Cori, I think now we are talking about the changes. Ease of operating. You want the procedure not to take another 40 minutes, but it should be ease, preferably an open system so that if possible, I think you can interchange your prosthetic designs without changing the system as such and not be wedded to one concept. Less clutter and of course versatility. Earlier times the problems of fiddle factor, the reflector arrays used to be corrupted, the blood would matter and all the other issues. We had started with that much before, after the initial things with the debut system. I think we had moved earlier on to the ASMs, right about 2005-06. And the reason again was that it was a very off-the-shelf, very simple system. It was surface-based, the pins were within the range, within the incision. But all it gave was the distal femoral and the proximal femur, very limited in a sense. The drawbacks basically was we did not believe or depend upon that for the sizing, rotation and kinematics, which was still in your hands. I mean, this was like a slow transition. But the alignment failures were less than 0.5% to 1% in most when we studied the initial 200 to 300. And of course, this was followed with us getting into the development of the pre-plan, more as a CT-based, which is a patient-specific jig. Basically, a useful tool if you don't have to invest upon the big expensive hardware, and this was a CT, you had to be image-based in this. So you were committed to this with some variation and leeway. But the major controls were still with the surgeon. But of course, all these had a very short shelf life because in a couple of years, they were overrun with the other technologies. But very useful what we found was all on the femoral side, varied morphological anomalies, post-traumatic situations, gross deformities, metadiaphyseal variations you could look at and then correct it very easily. Or with implants inside, you had only a short distal femur. When you can't put in a medullary rod, I think it's a great tool as a navigation systems. As the cognizance grew, I think we need to extract more value out of the systems. We moved on using to the GPS, which was one of the another versatile systems, for three reasons. One, again, it was that it could give us the position, the sizing very appropriately. In our intraoperative, whatever we are seeing today was feasible in that development. But at the same time, it also incorporated the hip and the shoulders, which was a feasibility much easier, and that was our attraction at that time. Of course, it was dedicated to one sort of a design, and you could play around with the rotations, the angulations, both of the proximal tibia and the distal femur. And this was fairly well. So far it was concerned. To some extent, you could do a decent gap balancing. But then all these dissatisfaction issues came, and then there was a paradigm shift in a sense whether our 0 degree alignment in the neutral axis was started getting more and more into question. And we have these sort of various alignment possibilities from the constitutional alignment. In fact, I was saying in the morning, the best sort of natural kinematic alignment is a unicondylar. I sometimes fail to understand we should be using it more and more in a greater percentage. I'm given to understand today in the overall sort of a universe of the total joint replacements in the knee, only 5% is uni, not more. So I think this gives us now looking at the feasibility to improve further the function and the patient satisfaction. It could be a kinematic, or you'd be seeing more of it. I think Dr. Krishna Kiran is showing the adjusted kinematic alignment or the adjusted mechanical alignment, various ways. So you can do. The biggest paradigm in most of these sort of alignment concepts was putting femur first. Previously, we would say we'll create a tibial platform and then work on the femur. But the whole thing has now turned topsy-turvy, except for the final adjustments. You get the femur first so that you get your kinematic axis and restore the rest of the anatomy in the corresponding window which you create, a bony window, and adjust the tibial to the parallelism of the femur. That is the reason the 3-degree rotation concept goes off, and you adjust the rotation based upon your mechanical and the functional necessity to restore the joint line and obliquities. But precise planning demands precise execution, like was beautifully demonstrated by Dr. Vaidya now, that I think you need to look at that 1 millimeter or 1 to 2 millimeters cut which you need. And robot here assists in this bone milling and cutting, especially with the Navio. With the milling technique, I think you are much more precise, plan and execute the predictable outcomes. I totally agree with him in the sense, rather than a socket, I think the milling helps us a great deal. But remember one thing, robot does not and is not tuned to any concept. It is how you utilize it. That is one thing which needs not a kinematic alignment. In fact, today if you say, sometimes the question comes, which one you use? I think it is just that there is a conceptual shift. You use an alignment which is trying to do very minimal soft tissues and adjust between the bone and the soft tissue. And fine-tune this final plan and execute it precisely. That's where the robot comes in. Second reason why probably one will and we will need to shift slowly, which I'm convinced, is that more and more of the partial or the compartmental replacements, either the medial uni, the lateral uni, patellofemoral, combination of the two, and staying as anatomic as feasible with tissue and the bone conservations. So selective focal resurfacing is the other necessity that is going to necessitate the use of technology in these cases, the tissue considering. So robot-assisted imageless, I think, in a way takes away the need for a CT, MRI, and we are able to plan and balance it prior to the cuts. That's a great benefit, which even some of the navigation systems would not give before. So achieving the final plans like you saw in the demonstrate beautifully, you can more or less come to that ballpark point, and then you can fine-tune this. And then finally you are able to execute the whole things. When you do this sort of a kinematic or adjusted kinematic, be prepared to see these type of X-rays sometimes. It is not often we are used to it. Immediately we jump to the fact that it is varus. How much is the limits? 3, 4, 5? I think that's a question mark. There are some in the world who say up to 6 degrees of a correction they give. But we restrict at this time till we develop more confidence and see the outcomes to about 3 to 4 degrees. Don't jump beyond the margins and the defined limits. So fine-tune the balance with the little bony corrections, and still you are doing very well. So at the present time, I think our feeling in the unicondylars, this was one uni which I had done 20 years ago, 2000. The same, it was a fixed bearing uni, and today we do the same thing with the mobile. A little more precision is much better. You're able to execute like you saw in the morning. It takes up a lot of brain and calculations in most cases. So long as you know the basic principles, under correct, no release, and just resurface the bone. 3 points, that's about it. So in short, summarizing, enabling technologies and orthopedic surgeons, to me, I think we are made for each other. I think we could use it for the type of surgeries we do, especially in some zones. It's with articular reconstruction, replacements, and reproduction of the anatomy. It's here to stay. will impact us in one form or the other. I think the earlier we adopt and refine ourselves, probably it may be better. Certainly these are earlier times, time will throw more light on it and how it works. But of course the debate will go on, and this is a small statement I read in 2021, last year, coming from Peter Sharkey, Parvezi and Bob Booth, big guns in the replacements. They still ask, is robot and the hip and knee arthroplasty a real innovation or a marketing tool? I mean, this debate is going to go on, but I don't think this needs to be a factor. Today, if you look at it, the reality of the whole thing, even though you find the top guns talking about the questioning it, it's a robot war, literally in the marketplace. There are variety. Every industry partner today is able to has come out with the varieties. They are everywhere, right from cleaning the house. So why not in the operating room? So enabling technologies and orthopedic surgeons, like I said, we are no exception. More importantly, I think the robots have thrown out so much of data because it is grabbing every information. And what we see coming up in the next years is a predictive analytics. What it does is collects all the data what is being recorded here, and you can clean it, save it, and then pick up the important, required, necessary ones. Then you can identify the patterns, how it comes. And tomorrow it may be able to tell you that as an ex-surgeon, with this information, with these numbers, he would prefer this type of a procedure. Or in these cases, this type of a system works. And it is able to predict it. So there is a predictive potential which happens. And that is probably just coming. It is on the horizon. So predictive analysis, basically what it's going to do probably in the next years is the AI, literally, smart algorithms in diagnostics, appropriate therapeutic approach, what would be ideal, adjusted, total kinematic, whatever. You do not know how it's going to evolve. It will be we the surgeons thinking about it and probably giving some direction to it. And also it's probably a prediction to what probably would be the anticipated outcomes, what you would see in this case. Thank you.
Sir, I would request you to have a seat for 5 minutes as Dr. Vaidya is reaching. So kindly bear with us. Till that time, we can start next session. Moderators, chairpersons are Dr. Narendra Parmar and Dr. Sanju Mahajan. I will request them to come on stage. And the next speaker is Dr. Anup Gadekar. So till Dr. Vaidya comes, we'll start next session. Thank you.
Hello. I invite Dr. invite Dr. Neeraj Adkar, QVIS robotic system, learning curve with different robotic systems.
So with permission of organizers and respected chairpersons, I have slightly modified my talk because that would have been repetition of today morning talk. So I'll be talking regarding how to deal with severe deformities using QVIS, and I'm going to share with you the severe deformity cases here. So can we do robotics? I mean, that's a routine question asked by everyone when we are dealing with severe deformity. Is it possible to deal such deformities with robotics? We saw excellent demonstration just prior to this session. So yes, we can. So case number 1, 74 years old gentleman, hypertensive, IHD, bilateral knee pain 8 years ago and operated for fractured tibia 14 years ago. And this is how he presented to us. Right side it was a simple straightforward varus, but left side a gross deformity and with pre-existing implant. And so we had to take out the implant. The challenges were an osteoporotic bone and a severe defect on the posteromedial side. And so this is his post-op X-ray, complete correction of the deformity. So he used to walk like this. This is pre-op and post-op gait of same patient. So complete correction and leading a normal life. Another patient, 72 years old gentleman, pain in both knees since 8 years, no other significant history, and gross deformity as you can see, and severe varus with severe defect on the medial tibial condyle. And this is his post-op X-ray. We had to graft and extension stem, and this is his pre-op gait, day 1 after robotics. And same patient around 4 to 5 weeks post-surgery. So such gross deformities, not only with this system, but almost with all robotics we can tackle successfully once you are used to handling these systems. Another patient with bilateral knee pain since 7 years, defect on the posterior medial aspect of the tibia, and huge osteophytes he had posteriorly. And I had to use an extension stem with graft and complete correction without any FFD. So this is his pre-op and post-op gait. So I thought instead of repeating today morning talk, it will be nice to discuss and share these cases. So subluxated knee and gross varus, complete correction. Another patient, female 57-year-old, she was operated for proximal tibia fracture couple of years ago, diabetic. There were no signs of infection, ESR, CRP and other parameters were normal, and this was her pre-op X-ray, and this is a post-op complete correction, and stable knee we could offer her. So another patient, bilateral knee pain, 65-year-old gentleman, valgus knee, and these are his pre and post-op gait or videos. So friends, we'll skip a couple of slides here, and this patient, complete correction, pre-op and post-op video. So complete correction of such varus and or extreme deformities is possible with this system. It's highly precise, and most of the patients we could end up with 9 or 11 poly, and good improved range of movement we could achieve in most of the patients. Thank you very much.
Hello. My question to Neeraj. How robot will help in such type of cases? Previously people are doing such type of cases without robot. What is your experience? You had also experience of such cases in past when you are not using robot.
Yes. So is pre-op planning with this particular system, pre-op planning is extremely important as it applies with conventional technique also. So if you do planning, precise planning, then it saves a lot of intra-op time, and the cuts or the correction is easily achievable with this robotic system, especially if the tightness in the flexion on the medial side and the rotations we have to adjust to achieve a balanced flexion gap, especially flexion gap. As showed by Suri sir in his lecture, if there is tightness in the extension, then slight varus to achieve balanced extension gap. Such minor things or adjustment are not possible with the conventional technique, but with robotics we can literally play with these things and we can achieve good balanced knee, and that is I think key to success, I would say, in such deformities.
Would you like to do scanogram in each such type of cases in post-operative also?
So for QVs we are doing complete, from hip, knee and ankle CT.
Okay.
And based on that only we are doing all this.
No, that post-operatively.
Post-operative scanogram is okay. Yeah, so
but
we can
are
do
you
it.
doing regularly or not?
No, we are not doing it regularly.
Okay.
Dr. Neeraj, excellent cases and results. Can you just elaborate in either of one of your case, the intra-op planning or pre-op planning, and how you have adjusted that? Do you have that?
No, I don't have it because I already uploaded that on.
Because that would have been more of
Yes,
a learning
agree,
rather
I
than
totally
just
agree.
pre and post-op.
Yes.
Dr. Neeraj, great cases. Just one doubt and question, just to clarify myself. When you have severe lateral opening, some subluxed lateral opening, and you're extremely tight because it's something like your pivotal medial laxity is 1 point, fulcrum like, How do you control? I mean, it's the bone, how much is the limit of your bone resection? What do you think you would do after that? Or how do you titrate your soft tissues in that case?
So there is lateral laxity and medial tightness.
Significant lateral laxity.
Significant.
Yeah.
So we external rotate the component to balance the gap, but there is limitation to that. Okay, so
in the extension, the problem comes in the extension. The flexion, we are still able to rotate and then
Yes.
get away. Yeah,
Yes.
you're right. How do you do that on the extension side?
Extension, we can give slight varus to the tibial component, or on the femoral side also we can adjust to balance it. And that's where I think, sir, robotics plays crucial role.
I agree. I think the biggest benefit is you are able to replay it before you make the
Yes.
first cut. Yeah.
Yes.
Dr. Neeraj, you've shown a lot of difficult cases. How often do you have to change your plan intraoperatively, and how difficult it is with QS?
See, intraoperative plan modification you need in most of the cases. So it is not that you plan pre-op on CT and then same thing you execute inside the OR. So based on soft tissue condition, you need to modify your plan. I would say 80-90% of the cases you need to modify your plan, what you have planned earlier. Most of the cases.
So you spend double time for planning. So you plan first in your OPD and then you redo it during surgery.
So spending 10 minutes in OPD is, I think, worth, because that saves a lot of intra-op time. You don't need to mark femoral head center. You don't need to mark ankle center. That saves, I think, your OR time inside the OR.
Okay.
So that you save. So there are positives and negatives of each system. So let's not discuss on that. But
my point is
so
that how difficult
it is not double spending double time.
cumbersome.
You save time on some parameters and
right.
Yeah. And there are distinct advantages of CT planning. I came across, I think Mukesh asked a very good question. Unfortunately, I mean, this talk was loaded and this other information was not there. Just a couple of weeks back, X-ray, digital X-ray showed, I mean, it was a typical varus, standard varus knee, and when we got CT, we could find a huge cyst in the metaphyseal region in the tibia. And then we kept stem ready, and then we could cement. Otherwise, it would have been intra-op, surprise. So there are positives or advantages of each system. And couple of patients, we could find hip arthritis. Even if we get scanogram or PBH X-ray, sometimes you don't get those changes, early changes on X-ray. And CT, we could find that, and we could inform or take consent, I mean, inform them that there are certain changes in the hip joint as well. So there are advantages of CT planning, and it just takes 10 minutes extra, not more than that.
I'm sorry to interrupt in between. We are running a little behind the schedule. I would like to invite Dr. Narendra Vaidya on stage to felicitate Dr. Surya Narayan sir. He's got a flight to catch at 5 o'clock. Neeraj Adkar.
I think it will be a befitting if we can all give a standing ovation to one of the biggest legends in orthopedic industry, Dr. Surya Narayan. So you would like to say a few words? Yeah.
I think I don't deserve any of all this. I'm more or less a student. If I look at Vaidya's contribution in this technology intensive fields, I never I was surprised that he's considering that I'm doing something, not at all. But either way, I think it was a great opportunity for me to pick up some good points within the short. Unfortunately, I have to leave. But I'm mighty impressed with what you do, phenomenal. I think 3 places, for 5-7 variety of machines and in-depth understanding. And he has been the front runner, the leader right from 5 years. So no wonder that he has done this excellent job. Like I always say, I think all of us have to keep the eyes open, like what he did 6 years ago. and be open to what the world has to offer us, because otherwise we become fossils without doing anything. Thank you very much once again. All the best wishes for the rest of the day.
So, may I invite Dr. Anup Gadekar for his talk on handheld imageless robotic systems, CORI.
So, good afternoon once again. I'll be speaking on the learning curve with imageless handheld robotic system, mainly on the Navio. Now, despite being a successful surgery, as many as 20% of the operated patients are dissatisfied after the TKR. The improper implant positioning, limb alignment can affect the patient satisfaction, surgical outcome, and implant longevity. Many technologies were introduced along with the changes in the implant design to address these issues. And evolution of robotic arm-assisted TK was one such advancement. As per the published data, the advantages of robotic arm-assisted TK include the accurate bone preparation, improved implant positioning, reduced outliers, reduced hospital stay, and improved early outcomes after the surgery. Being an advanced technology, it has a steep learning curve with increased initial operating time, which is likely to be a major barrier in its widespread acceptance amongst the arthroplasty surgeons. To assess the learning curve with imageless handheld robotic system, that is Navio, in our hand, we did a study where we compared cases done using Navio with those done using conventional jig-based method. These all cases were done from period January 2017 to June 2017. The 75 cases of robotic assisted TK were divided into the 3 groups, 25 cases each group, versus the 25 cases randomly selected which were done using conventional TK. The sample size was calculated with the alpha value of 0.05 and the power of 90%. We analyzed the time required for different phases of the Navio, that is the registration, planning, and cutting, as well as the total time required from incision to the implantation from robotic assisted TK and total time required for the conventional TK. The mean of individual phase times and total time for Navio cases were compared between the 3 groups, and the mean of the total time of each group was compared with that of the conventional group. Now, this is the table which shows the comparison between mean of the time between group A and group B of robotic assisted TK for various phases. And we found out that the statistical difference for each phase was highly significant. This table shows the comparison between group B and group C of robotic assisted TK for various phases, and the statistical difference was not significant for any of the phase or the total time. Same thing was done for group A and C, and again we found out that the statistical difference was highly significant for all the phases of robotic system as well as the total time. Then we compared the mean of the total time of each group of robotic assisted TK with that of the conventional TK, and we found out that the difference between group A and the conventional TK was highly significant statistically, but that between group B and conventional and group C and conventional was not significant. So the result of our study suggests that after first 25 cases, the time required for each phase of the Navio system and eventually the total time reduced significantly. So we can say that in our hands, the inflection point in the learning curve for robotic assisted TK using the Navio system occurred in the first 25 cases. I am happy to announce that recently our paper on the learning curve has been accepted for publication in the Journal of Robotic Surgery. There are other papers available on imageless robotic system and the learning curve. This paper was published by Savao et al. In the archives of orthopedic and trauma surgery, where they found out that the learning curve for robotic assisted TK with an imageless robotic system was completed after 11 cases, and there was no learning curve observed for the implant positioning. Another paper published in International Orthopaedic Journal state that the learning curve of 7 cases for operative time was obtained for robotic assisted TK. One more paper published in the Journal of Robotic Surgery by Bale et al. Demonstrated the surgical time averaging below 60 minutes and the learning curve that was reached in 29 cases. This is an online published paper by the Kegi et al. Where they found out that the time metrics decreased significantly after the first 7 cases except for the residual time. There was one interesting paper by the Kayani et al. Where they studied the anxiety level of the surgical team and its impact on the learning curve or the surgical time. They used the STI questionnaire and they did the QSUM analysis of the STI questionnaire, and which revealed an inflection point for preoperative stress levels after 7 cases, which is similar to the operative times in the robotic assisted TK. So we can say that the surgical team stress is proportional to the learning curve. Now there are some tips which I like to share, which we followed when we introduced the robotic system in our hospital. So keep your surgical team constant in early cases. Do less complex cases in early stages. Decide your workflow during first surgery and follow it in subsequent cases. Allocate responsibilities to each team member. Arrange cadaveric workshop for whole team and arrange visiting surgeon programs with experienced surgeons. Thank you.
My question to Anup. Does age of the surgeon will affect the learning curve? Younger people will accept little bit earlier and this.
See, what I feel is that if the surgeon is having previous experience with the navigation, it is much easier for him to get accustomed with the technology easier. But if surgeon is not having any experience with the navigation, then I don't think the age will matter.
And second question, in early cases that you had done, in that case, his results are equally good to conventional TKR or it is far below?
No, we have already published 3 papers on that, and we found out that the early outcomes were far better than the conventional TKR. I think tomorrow's paper sessions are there. We have published 3 papers.
No, I am asking regarding early 25 cases that you are learning.
Yes, yes.
That
We
you
have
just compare with time only or you have compare with the result also?
No, those cases were included in another paper where we studied the post-operative outcomes also, and the early outcomes were far better than the conventional TKR.
Do you believe that robotic TKR patient is post-operatively less pain compared to that conventional? It is same?
Yes. In our study, we found out that.
Yeah. Okay. Thank you.
Thank you.
Now, may I invite Dr. Nilesh Kulkarni.
A very good afternoon, everyone. I am going to share my early experience about the ROSA robotics. Basically, the learning curve involves the surgeons, operating room staffs, and the technical associates. The ROSA system is basically a collaborative robot, and it is cut guide based. You can say the conventional jigs are robotized in the ROSA system. Basically, the scope of the ROSA system involves there are 2 options, image and imageless options, and it can accommodate the 3 implant systems, Persona, Vanguard, and NextGen. But I used only the imageless NextGen implants. You can see in this picture how the 2D images of the X-ray are converted into the 3D anatomical models. The steps to the ROSA involves the draping, positioning, setup, evaluation, planning, and the execution. And you can see the possible OR setup. Basically, if you are operating on the right side of the knee, the surgeon and the console of the robot should be on the right side of the patient. Draping is an most important part, and considering the sterility, and draping the robotic arm and body before going to the operative field is a necessity. The tips regarding the draping is that proximal aspect of the draping should be far away from the head so as to accommodate the ROSA arm. After doing this one, you can get the screen picture like this when your draping is completed. You can see the pictorial representation of the draping. After the draping, next steps comes the positioning, aligning of the ROSA. Basically, to position the ROSA, you need to put it into the 45-degree angle to the body of the patient at the level of the shoulder so as to avoid the collisions. And after positioning, you need to align the ROSA with reference to the knee axis. You can see now the ROSA is ready for the surgery. After doing the initial procedures, you can perform the incision and put the trackers. Before going for the surgery, there are some tips as Dr. Narendra Vaidya has shown the use of the pins to retract the soft tissues so as to reduce the need of assistant. And reducing the need of assistant, avoid the collisions that affect the robotic arms. There are basically three options for performing the surgery: measured resection, gap balancing, and the hybrid. I use only the measured resection techniques in average build patient with less deformity for the initial cases. So during surgery, I use the parapatellar approach doing the osteophytes removal, meniscus removal, and then I put the trackers outside the wound only. One of the advantages of the ROSA trackers are that small diameter gives you the less chances of the stress fracture. Also, the tracker design increases the coverage area and reduces the blind spot. The tip regarding the tibial pin placement is that you should track initially it with the camera and put 30-degree angulation medially. You can see the pictorial representation of the system with the trackers in situ. Then comes the femur collection and the tibia collection. Basically, since the morning we are discussing about the difficulty in calculating the femoral center in other Cori system and the Nevio system. But I found very easy collecting the femoral center in the ROSA. You just need to collect some points so as to calculate the femoral head center. Then again, you need to collect some femur points so as to get the data from the knee. Tibia collection involves the collection of the malleoli and another tibial points. After that, you need to collect some dynamic assessment of the knee. You should get the knee range of the motion, valgus varus stress at the 0 degree, 60 degree, and the 90 degree angles. And here comes the main step of planning. Basically, the planning is mostly considered and involves the mediolateral aspects and the flexion extension gaps. So, after collecting all this data, ROSA system will give certain information regarding the values of your distal femoral cut, proximal tibial cut, and the posterior cuts. According to that, you need to balance your flexion and extension gaps. So tips regarding the plannings are that aim is to get around 19 mm, 19 mm around median and the lateral aspect, and you can accept the 2 mm laxity on the lateral aspect. The sequence to adjust the gap involves you should do more and more adjustment on the femoral side rather than on tibia. You should first adjust the size of the femur, then you can adjust on the anterior cortex so as to avoid the notching. Basically on the tibia, one side should be smaller and keep the standard tibial cut at 10 mm along with the slope of 7.5 degree. Coming to the gap planning, if you are still not satisfied with your gap, to adjust the flexion gap, you can rotate the femur up to maximum 4 degrees. And so as to adjust the extension gap, you can give varus to the femur about maximum 3 degree. And still, if it indicates some residual imbalance, then you need to go for some release after the trial. And I think the execution is an easy part because it uses the saw and ROSA places the jig, and we need to secure it with the collaborative mode and take the cut with the saw. The flow of the cuts depends on the surgeon whether femur first or tibia first, and validation tool is available for the cut assessment. So whatever the time graph I have taken from my cases, it shows that for initial few cases it took around 1 hour and 20 minutes for me, and later on the time reduced to about 55 minutes for the last 5 cases. Basically most of the times went into the patient preparation and the registrations. In summary, ROSA has small initial learning curve. It takes some time to getting used to ROSA inside the OR. You should spend some time on the planning, but execution is an easy part because we surgeons are mostly familiar with the conventional saw blade. And one of the most advantages of the ROSA system is that it gives you less ergonomic strain, but you should be ready with your conventional setup. Some pitfalls I found while using this robotic system, it indicates me that surgical planning on the skin needs some experience. Also, if planning is not appropriate, no feedback is given from the robotic system. And also large OR setup is requirement due to the bulky system, and collision to the robotic arm can create problems intraoperatively. Fractures on the finholes in the osteoporotic patient can happen. Also, it is difficult to collect the data in obese patient. Some of the literature is showing that initial learning curve for the ROSA and knee system can be achieved in 6 to 11 cases for the operative times. Thank you.
Thank you. Which sort of implants can you use with ROSA?
Mostly some next gen only I used.
Only next gen? Any further questions?
Dr. Srikanth from SOC Bangalore. Thanks for the presentation, doctor. So just want to ask you, you mentioned that you're using a 2D X-ray and converting it into 3D. Will it not create any errors when you do that? Is it not simple to just get a CT and get a 3D straight away?
So after it actually it takes some time to get that 3D planning images, and also you need to provide and you have to spend some time on planning also after getting the 3D images. But it's not like the exact data we are going to perform and take the saw cut. Also you have to assess your gap after taking the 3D images also.
So how accurate is this 2D to 3D conversion?
Actually, I don't have any experience regarding the 3D. I have done only with imageless robotics.
Okay, thank you.
Thank you. Thank you. Thank you. So may I invite Dr. Adarsh for his talk on Maco robotic system.
Good afternoon, everyone. So I've combined a bit of the principles of the Maco as well as our journey, including the learning curve. So as we've all been speaking about these 5 robots, I'm speaking about the Striker Maco today. So this is our joint replacement robot. It's a 4th generation Striker Maco robot. So if you see the overall evolution of technology in joint replacements, you have the static plan initially in the 50s, navigated execution from the 90s onwards. Navigated freehand tools like the Navio started in the early 2000s, and the robotic arm-assisted surgeries also coincided around the 2000s. And this is the evolution of Maco itself. Initially, it started in 2006, and in fact, the total knee came much later in 2016. It is initially total partial knees and total hips. I kind of compiled the other the systems also into this timeline, and if you see 2012 is when the Navio took over. I think this is because of the conversion from Windows to Apple. It's a bit of, it's turned around a bit. But if you notice, earliest robotic systems and computer systems were in 1990s. So it is all the way back then that these systems had come forward. So the classification of robots in arthroplasty, the basic classification is boundary control like the Navio and the Cori, the semi-autonomous like the Maco, where we're still doing the surgery, but we're being helped and we're being restricted by the robotic arm, and the completely autonomous like the QVIS. So this is what our Maco robot looks like. If you see, this is the haptic boundaries on the side, and this is the amount of bone that has to be cut. We are still moving this saw on our own, but it is not allowing us to move outside that particular boundary. If it does, it completely shuts off the robot. It doesn't allow you to move out. So it's kind of like a bit of best of both worlds, you could say. Okay, so the basic advantage we found in the Maco is that you can do all the 3, the total knee, partial knee, and the total hip replacements. But what's the need? When you're having such great results all these years with manual, why do you even think about this? So we split it up into 3 things. In total knee, the 3 core features are the enhanced planning, the dynamic joint balancing, and the robotic arm-assisted bone prep. And we like to summarize as ABC, accurate sizing, perfect gap balancing, and 100% precise cuts. So if this is what, as I mentioned in the earlier talk, we have the enhanced 3D planning with the CT scans. You get the 3D model and the registration. I don't want to repeat what I already mentioned earlier, but this helps in terms of planning before going into the theater. Then we have the dynamic joint balancing. This is a common step for all robotic systems. This is the crux of every robotic surgery. You can see the gaps after giving stress. You can try to make sure that you balance all your flexion extension gaps to the same level so that you have a perfectly balanced joint. And of course, this is something which is unique to the Maco, the haptic boundaries, where you can nicely remove all your arthritic bone without going out and hitting your soft tissues or without cutting any extra bone at all. In partial knee, the advantages are, as you know, partial knee is like sculpting. It's it's a highly skillful surgery, and you have much less margin of error. Here you can, with no robotics, you can make sure there's no overstuffing of the opposite side, and there's no understuffing either. You get a perfectly balanced knee joint with the robot. This is bird out over here, and I'll just show you how this works. It's very similar to, this is quite similar to the Navio, how we do it. instead of having like a handheld burr, we have like something like a gun, like a saw gun. The same piece, hand piece, which is you have to change the attachments. In the total hip, the main challenge, as you know, is the placement and positioning of the cup, inclination and version of the cup, and the leg length as well. And in manual surgery, you always have the fear that you may ream too far, or you may impact the cup too hard and break through the acetabulum. But you don't have that problem over here. We've planned everything beforehand, and we do a single ream and a single impaction, which I'll be speaking in tomorrow's talk. So you have the advantages of inclination, version, and limb length discrepancy. All these things can be taken care of by the Maco in one single go. Again, I don't want to go into detail here because I have a talk on this later. This is how the Maco hip looks like. The green part is the bone which has to be reamed out. It has already been determined, and if you can see, it's disappearing on the screen over there. Right, so summary of the benefits: TKR, ABC, sizing, balance, and cuts. The PKR prevents overstuffing and total knee cup placements and avoid dislocations. Consistency and reproducibility every single time. If yes to robotics, why Maco? I'm not going to go through this, but main thing is 3 primary applications which are cleared by the FDA and haptic boundaries are there. What does it mean for our patients? Less pain in the 90-day period. We are actually seeing this in our clinical practice, and satisfaction has been great compared to the manuals. As in less pain, less post-operative time for recovery, and less physiotherapy requirement as well. In partial knee, you can see the accuracy is much better than the manual. The gray bars are the manual accuracy, and the yellow are the Maco. So our journey, we started in 2018. 19 is when we went to Australia to observe our first surgery. In USA, we went for training. We did a cadaver lab in New Jersey, and then we got certified. We acquired the robot in 2020, and we founded our Sunshine Orthopaedics department. And we had our launch by PV Sindhu on Feb 1st, 2020, just before the first lockdown. So this Dr. Thomas Kuhn, who is one of the designer surgeons for Maco, he was the first person to come and demonstrate with us. We made him hit an RL as well, so we turned him into an Indian. And we did our first Maco TKR in Feb 2020. We launched the hip in 2021, and we've become a center of excellence where we're training other surgeons as well. And a lot of surgeons have come to visit us. We've also certified, we have become certified trainers in Maco robotics as well, and we're also certifying other surgeons. We have a much largely growing team. This is our first team, was only 5 of us, and now we already have like 10 to 15 robotic trained surgeons. What about the numbers? Presently, we're on 2,500 almost, and most of them are total knees, and we've also increased total hips to quite an extent. We're doing almost at least 3 every week now. And our procedure time has come down to 45 to 50 minutes. And initially, it was almost like 75 minutes, and which we'll be talking about next. But what have we learned in these last 2 years? People embrace the technology much quicker than we thought they would. The learning curve is not as steep as we expected. Less amount of pain, faster rehab, and we can do complex cases like Neeraj sir had shown in his talk. The Maco total knee procedure time, the first 50 cases, almost 1 hour, 50 to 100, come down to 50 minutes, and now we're hovering around 45 minutes per case. And what about the total hip? You would think that the registration and time will take a lot of time, but that time is offset by the fact that you're doing only a single ream and a single impaction. So if the registration may take 10 minutes, this is in the early cases. Now the registration also takes less than 10 minutes. And the reaming and the cup impaction is just 2 minutes to 4 minutes, or maximum of 6 minutes. So that even the hip surgery time has come down by 5 to 10 minutes. If you see the literature on the same, the learning curve of robotic assisted TKRs, this particular study showed that it takes around 40 robotic arm assisted TKRs to become time neutral. And this study also shows after 1 year, robotic assisted and manual TKRs, there is definitely an improvement in the time. The same paper has these graphs as well. I don't want to go too much into detail because of lack of time. What are our outcomes? Just another 2-3 slides. The first day after surgery of a partial knee, this lady is sitting nicely cross-legged and speaking to us. And this is the day we were sold on the Maco partial knee. This chap, bilateral partial knee robotic, 1 week after surgery, went back to his walks. This is the day of surgery for a robotic total knee replacement. He's able to lift his leg and bend his leg immediately. Gross deformities also can be done, like this lady over here. And valgus deformities also we have managed to do with this particular system. Bilateral total hip replacement, a 37-year-old lady, we managed to get the equal limb lengths just with the perfect planning, and we could execute it as we wanted to. Why are we getting better results? We think because of the internal homeostasis of the knee, titration of the bone cuts, that is functional alignment, so least amount of soft tissue release and less amount of time with the knee subluxated. How have we changed things that we're doing? We're now comfortable with functional alignment. This is what we weren't comfortable with earlier. Minimal soft tissue release. We're doing more number of unis now, more THRs without a trial cup, and we're having faster physiotherapy protocols. We're doing a study where we're comparing one side robotic total knee and one side manual total knee with patients who have consented, and we're going to now study, we crossed 100 cases, we are going to come out with this paper in the next year. We're also doing studies where we're studying surgery times for all our robotic surgeons, so we can actually objectively define what was our learning curve for the different age groups as well as was asked. We're going to take all the different age groups and see what was the average learning time. And we're seeing the accuracy of cup placements in robotic total hip versus conventional as the same for the partial knees as well. Future, we also have a software upgrade where it's going to tell us about hip impingement as well as spinopelvic abnormalities. Shoulder replacement also is going to be coming for Maco, and the ortho sensor will also be incorporated into the Maco. So we actually have definitive data about the pressures as well. How far we go? I hope we don't end up where the robots are sitting in the post-op lounge, but we're almost getting there. Thank you so much.
Yeah, Dr. Adas, 2,500 is a very good number of cases.
Thank you.
What is about your intake message for infection and everything? This is because huge system infection in joint replacement in robotic.
In robotics, I don't see much difference in except for the fact that there's a big machine over there. Now that the surgery time has also become less, we do feel that there's less amount of infection as well, chances of that.
Surgical time is less, but OR room traffic is little bit more
This
and
is
more
one
equipment
extra
is
person.
there.
Only one extra person.
Only one assistant.
One extra person. He's standing near the console. He's not even near the surgical field.
What is your rate of infection in 2,500 cases? Whether
I
it's
don't
same
remember.
to conventional or it is less?
It's same. I mean, we haven't done an objective study, but I don't remember any of our robotic knees actually coming back with the infection in the last 2 years.
Okay. Any question from audience?
Thank you.
Thank you.
I would like to invite Dr. Mitali Vaidya ma'am to felicitate Dr. Narendra Parmar and Dr. Sanjeev Mahajan. Dr. Adarsh Annapareddy and Dr. Nilesh Kulkarni. Dr. Nilesh Kulkarni. We now move on to fourth live surgery, restricted kinematic alignment with subvastus approach by Dr. Krishna Kiran. I would like to invite Dr. Ashok Kumar and Dr. Raj Kumar to chair the session.
Good afternoon. Kiran, Dr. Krishna Kiran, can you hear me?
Yeah, Ashok, can you hear me?
Yes, clear Kiran, all okay.
Yeah, I think we'll just first show you the pre-op X-ray.
Yeah, you can go ahead Kiran, yeah.
Can you just show the pre-op X-ray, please? Right. So this is a pretty standard flexion varus knee. And we have made measurements for the restricted kinematic alignment. So you can come back and focus here on the thing, yeah. So if you see here, this particular patient has got a distal lateral femoral angle of around 7 degrees and an MPTA of around 12 degrees. So in a conventional kinematic alignment, even if you factor in for wear, this is a little bit too much. And restricted kinematic alignment, what it does is you can use joint line obliquity to your advantage to minimize soft tissue releases without compromising on the mechanical axis. So 5 degrees is the limit which is set for the joint line obliquity on the tibia and femur, and overall alignment must be plus or minus 3 degrees. Since the system error is 1 and our bones are a little bit weaker, we set our boundaries as 3 degrees. So we can go up to 3 degree varus valgus on the distal femur, 3 degree varus valgus on the tibia, but we will try and achieve an overall alignment of plus or minus 3 degrees because that is within the range of the implant permissibility. Is that clear?
Yes. Kiran, do you measure for every case when you plan for restricted alignment?
No, this is to demonstrate, but for every case we look at the joint line obliquity based on the CPAC classification, whether the joint line is inferiorly sloping or is it neutral or is it superiorly sloping, and whatever is the joint line for that particular patient we try and restore it because we have the tool to restore it nowadays.
Do you do subvascular for all the approach or
all cases subvascular approach? Yeah. So the incision is standard midline incision, and there are 3 types of insertion of the vastus medialis obliquus onto the patella. So you have this is the type 1 insertion where this is a superior part of the patella and the tendon is inserting in the top 10%. So this is relatively straightforward to do with a subvastus approach. It's just an additional tool for accelerated rehab for the patients, but it's not mandatory. So you can see here that there is an L-type junction between the VMO and the capsule. So we make an L capsulotomy onto the VMO there. And all this is done in flexion, you can notice, okay? So I made the L-shaped capsulotomy. The inferior part is similar to that of any other surgery. It's like similar to the medial parapatellar approach. Right. So now you extend the knee. I'm extending the knee so you can focus the camera appropriately. Yeah. And if you try and lift the thing up, this patient has got a tight patellofemoral joint because of osteophytes. Scissors, please. So there is a synovial tether here. You can see that, which I am releasing under vision, and this is the fascia which I am releasing. Once you do that, it is easy to mobilize the muscle out of the way. Okay?
Okay.
The next step is to do so this is again done in extension. So what we are doing now is we do a provisional sleeve release till the level of the tibial tubercle. So this is mandatory for all varus knees. It's not as if we will not do any soft tissue release. We will not release the superficial MCL and will minimize the soft tissue release. That's what it is. Doesn't mean that we will not expose the knee. So still you will have to expose till the posteromedial corner and make sure that everything is visible, and you remove all the osteophytes before you make your gap assessments with robotics. So I always tell people the robot does not make one a surgeon. So just like buying a Tesla car will not make you a driver, owning a flight will not make you a pilot, just having a robot will not make you a surgeon. So please understand that. So the surgery still has to be done by the surgeon himself. And you just use it as an intelligent assistant to make sure that everything is in place. So this is just till the level of the tibial tubercle. And this is a preliminary release, and you can see there is a big posteromedial osteophyte there. And I'm happy with this release at this point in time, and if required, I will do more. So this is the original deformity, and it's opening up a little bit. That's okay to start with. Now I will excise the infrapatellar fat pad till I see the lateral margin of the lateral femoral condyle, because that is important to visualize for the surgery. So I will excise it as much as needed. And if everything comes in way, I will remove it. So I'm not fussed about retaining the fat pad.
Do you remove the osteophytes?
Yes, yes.
Stage?
Yes. So now next step is we will try and extend the knee and see if we can remove the patellar osteophytes. Nibbler, please. That will create some space for us for, just hold it, pivot it and hold it.
In Kiran Rajkumar here.
Yeah.
So in subvastus, this part of the procedure is exposure makes it little difficult, and if you want to resurface, what is that?
Medullary resurfacing. Once you do the distal femoral cut and the
Hmm.
proximal tibial cut, this becomes easier. So you can resurface it at that stage if you want. So now I'm okay with this. Now I'm flexing the knee, and you can see that we are able to see the entire femur. Is it clear now?
Yep.
Right. So I'm exercising the anterior horn of the medial meniscus, and we have provisionally planned for a cruciate retaining knee, but if it is too tight, I am happy to convert it into a PS. So we have an option of doing it intraoperatively with this system. Now I have to remove the medial osteophyte from the tibia spike, please. And if you notice, a lot of these cases have got this posteromedial condylar hypertrophy because this is a contained defect, flexion varus knee. The condyle tends to overgrow into the defect. So this tends to happen when the ACL insufficiency happens slowly. If it happens acutely, the knee will subluxate. But if it happens slowly, the tibial bone defect and the femoral hypertrophy will be compensatory to each other. And this will cause excessive external rotation erroneously because of that osteophyte. And it is seen in around 30% of our patients with ACL deficiency. So now we are removing the osteophyte so that the mapping becomes easier. And for robotics, you need to spend extra time initially. That makes our gap measurements more accurate. If you don't spend time here and then just rush to the next step, then all the gaps which we measure becomes inaccurate.
And when you are removing the osteophytes, can you just briefly explain this restricted kinematics? Like
Yeah. So
why you have named it like that?
Yeah, so the kinematic alignment is where you are trying to resurface the joint to pre-arthritic levels. So what it has been found is that only 50% of the knees will be within that plus or minus 3 range, which is the implant tolerance limits. You got it? Remaining 50%, the alignment of the proximal tibia and the distal femur will be outside that range. So if you try and restore the pre-arthritic anatomy in these cases, then the mechanical axis will be outside the plus or minus 3 degrees range. And that can cause premature failure because currently our limiting factor is the polyathlete that we have. So by restricting the kinematic alignment parameters to plus or minus 5 degrees of obliquity and the mechanical axis to plus or minus 3 degrees, now we are able to give the benefits of kinematic alignment in the outlier population as well. And it will make our extent of soft tissue release a little bit lesser.
So it is basically you are putting a cap on the extremes, like you don't go more than 3 degrees.
Correct. So whatever is the kinematic alignment, I am not going to restore that.
Okay.
And also, we don't have the ACL and PCL intact. So although we resurface the femur, which is extremely important, it may exactly not work in the same way we want it. So now at this stage, I will try and see if I can subluxate the tibia forward, which is again important for me to map the tibia properly. थोड़ा बड़ा है ये. And usually these sort of cases have a big posterior osteophyte there, and
Yes.
they prevent the anterior subluxation. See, you can see now I'm able to subluxate it, and I will remove that osteophyte as well. So you can see that whatever work we normally do at the end of the procedure, I am doing at the beginning itself. The removal of osteophytes, tibial reduction, everything is being done beforehand to make sure that the measurements which I make with the robot are accurate. If you don't make all these and then just do the robotic surgery, you can use it as a measured resection tool where you can cut the bones at a particular angle and then come back and do the surgery at a later date. Then the benefits of surgery are not passed on to the patient fully.
But Dr. Kiran, this is a prerequisite of removing all the osteophytes is mandatory when you do a robotic surgery or what? So it has to be removed all the osteophytes so it helps you in good mapping and good outcomes.
Absolutely. That is,
So,
I would completely agree with that, Doctor. So usually visualization of the posterolateral corner becomes difficult with tight knees in subvastus approach. But if you are patient enough, you will get it.
What is your contraindication for this approach?
If it is a stiff knee in extension, I will not do it. Otherwise, I will do it in all cases.
Yeah, there is a question from Adarsh.
Yeah, hi, Dr. Krishnan, sir.
Hello.
Not a question, I just wanted to mention to the people here. So, as Dr. Ashok was saying, it's very important to take out all the osteophytes before going on to the next step. In the image-based ones, there's one small change over there. You have to make sure the registration is done before your osteophytes are removed. So, usually we remove all the osteophytes. But when we're doing an image-based, the image is taken with the osteophytes. So, you have to do your registration with the osteophytes, then remove the osteophytes, and then do your gap balancing. That's
Raj,
a small change there.
You can see now I'm able to evert the patella. So
Yeah,
it was
yeah.
related to the medial tightness there.
Okay.
So once that is addressed, this can be, now we are ready to position our pins.
Okay.
Before doing that, we will just remove a little bit of the anterior cortex there, which I would normally not do. But in this case, we have to register the anterior cortex. So I'll take a triangle shaped synovium out. I'm not a big fan of this step because the vastus medialis can sometimes stick to the anterior femur and can cause stiffness in the patients. So I don't like this step, but part of the game. Yeah, right. So now we are ready for our pins. So the pins are positioned. Can you just focus properly here? Yeah. 4 finger breadths below the joint line. Nice. Midway between the anterior and posterior part of the femoral tibial cortex there. Okay. So we want it to be middle. It should not be towards the anterior or posterior side.
Yes.
Because it can cause a fracture, which is the last thing you want in these surgeries.
Yeah, heterogeneity.
And you will do a single cortex and touch the other cortex so that it has some stability. Knife. So this is very important step, how you position your pins, because this is going to determine the most of the robotic procedure. So now we check whether the whole bone is moving. Tracker, tibial tracker. Ready, Rana? Okay.
Dr. Kiran, almost all the robotic systems works on the pin based, most of the things, because the trackers to communicate with the camera. So the pin is a prerequisite for
That is right, because it needs some reference mark. It doesn't know varus valgus, right? It doesn't recognize. So it just recognizes the relative motion between the two pins as a marker for what is the deformity or whatever it is. So that is how the robotic works. So now it is showing that the system is too far. You need to bring the camera a little bit forward.
But it's within the zone, Kiran. Yeah, the green.
Yeah, but when we flex it, it will go. So I'm not happy with that. I want it in the middle and a little bit down, and this way. No, this way. Sorry. That's it. So now I will check whether it is, visible through the range of motion. And I will also check whether it's moving up and down or rotating, because this can happen sometimes. And then it will ruin a properly planned surgery. Then you'll have to convert. There's no problem with that, but you don't feel nice. So this is the checkpoint. So we always use the checkpoints in our practice. Doesn't take much time and gives us more deep length. So these pins are positioned through the wound. So it will serve two purposes. It will help to retract the vastus medialis. And the first pin is at the level of the medial epicondyle, and the second pin is within the realm of the flange of the prosthesis. So I'm not worried about a subtrochanteric stress fracture, the supracondylar fracture because of the pin, because it's a cancellous bone. So this is again moving the whole femur, and you have to position your arrays so that they are visible throughout the range of motion, and there is no play between the mediolateral part of the.
So this also avoids additional incision for the pins.
Correct, it does avoid additional incision. I am not a big fan of diaphyseal pins. Yeah, so now you flex the femur. Now you can see that it is visible throughout the range of motion. I am happy with this. Now I will position my femoral checkpoint. And sometimes this tends to come off, so you have to be careful with this. Right. So now you are ready to register. वो मेरे को नज़दीक लगा दो. So you have this foot switch and it takes a little bit of time to get adjusted to this. So you have a blue and a yellow switch. So now you have to verify the point probe. So there is a divot on this thing which we are collecting. We mark the checkpoint. This is important because we are using the robot for cutting the tibia and femur. If there is error to the arrays, it is might as well shift it to a manual procedure rather than try and do something with the robot which it doesn't understand.
At any point your femoral pins, if it loosens, like
Yeah, then you have to abandon the procedure.
yeah.
No, but keeping the checkpoints, you can redefine the pins, Dr. Kiran.
Yeah, you can, but it's more cumbersome.
No, that's the advantage of keeping checkpoints always.
Yes.
Even your femoral arrays moves, the tracker moves, you can tighten it, redefine the checkpoints.
So at this stage, we will have to loosen the side post for the hip center registration. So this is a mandatory evil for these procedures because otherwise you don't have the adequate play. Okay. So now I'm registering this. So once you do that, the error should be 0.5 or less in my hands. I don't want to have an error of, 1 because the system itself has an error of, 0.5 degrees. And every error you accept, it will compound the error, So when we are looking at accuracy, might as well be really accurate. Otherwise, don't do it. But 1 is probably the acceptable limit of what you can accept. Beyond that, you should not. Because each millimeter will contribute 1 degree. So now you saw the collection with Corey, which was pretty fast. With Navi also, it's not too bad. Okay. So you have to be really clear what you are defining, So this is the advantage of a CT-free technique. And you can validate it as Dr. Vaidya showed you, using those additional special point marking, the pink points which you can see on the screen. So I take a little bit of time on this because everything will depend on the accuracy of the model, If you don't register the model properly, you will not get accurate outcomes with the surgery.
It's pretty fast in creating the...
Yeah, it's pretty fast, it is intuitive, it's not, it's not going to cause any issue with us. And I'm making sure that I'm registering on the anterior cortex.
Anterior,
Yeah. And I'll just go as posterior as I can.
Does it indicate if you are insufficient in the registration?
Yeah, it will stop, it will not accept it.
Okay.
Okay, so now I'm relatively okay. Then can you special points mark karo? So now I can validate whether I'm okay or not. So this is the medial epicondyle, I can see. So and I will mark it. Can you rotate it and show them? So that is a sulcus, which I think is a sulcus. So the model is pretty accurate, okay?
Okay.
And similarly, you can define the anterior cortex as well, So I'm having pins on the anterior cortex, not that way, the other way. Yeah, so this is the anterior cortex.
Okay.
And it is pretty much validating what I do. You can continue.
And these special points helps you in the planning. How
That
much
is
of
right.
notching, that's important.
So now you can see what is the epicondylar axis. So this epicondylar axis is 5 degrees external to the PCA, and the PCA is 0. So my registration point for the femoral rotation will be between 0 and 5 degrees for this patient. Did you get that point? So it may be parallel to the PCA or the epicondylar axis based on what is the gap here now.
Okay, so you know that you are going to be within 5 degrees.
Within 5 degrees. So that is again the acceptability limit for my kinematic, restricted kinematic. So in kinematic it is 0 always. But in restricted kinematic we make some restrictions to that 0 because we don't want to have an unbalanced knee. Normal knee has got medial tightness and lateral laxity. But that is not in the tolerance limits of the polyethylene.
So in a manual thing we keep 3 degrees of fixed external rotation, and here you have another 2 degrees. So you know that only you will externally rotate more of 2 more degrees and not more than that.
Correct. But if you see some of your severe varus knees, I am sure you would have manually externally rotated it more than that 3 degrees.
Yeah.
You know.
Yes.
So it is just that we are quantifying what we are doing in this situation. So now the tibia has got some issue with the sizing. Others pointed out it in the morning. It requires to register both flares, the medial as well as the lateral flare.
Okay.
So currently that is a drawback, because if you don't register the lateral flare, then the size can be this way, that.
That's a little difficult also.
That is difficult, but we can circumvent it. Right. So can you enlarge the robotic screen?
The tibial side registration was too quick.
Right. So now that you got used to it, I am going back to my original speed. So now I am not doing it slowly. So this is 5 narrow, you can see here. But I want it to be a little bit larger because it covers the whole femur now. Okay? You got that point?
Yeah, but why didn't it select the correct size?
So it can be one size this way, that.
Okay.
So, but this option of, you can go back to the axial cut. You can see here, this is the distal most point there, the yellow one.
Yes.
And the implant is seated at the distal most point. And this is the posterior most point, and the implant is seated at the posterior most point.
Okay.
You got it?
Yes, yes.
And on the lateral side, it is sitting at the level of the joint line.
Okay.
You got it?
Yes, yes.
So I'm not making any changes here, but I think the tibial size is little bit larger than what I think it is. You can see there is overhang here, because the axial cut is not covering that much. So now I make the size 3, and this tibia is actually externally rotated. I can see the extortion. So I can externally rotate the tibia by around 3 degrees, which is, which will be the combined rotation. So we'll keep a track on this. Now, one of the factors which can, cause premature failure is malalignment between the tibia and femur.
But in this tibial tray, you cannot have a very gross malalignment because it is an anatomical tibia.
No, no, it is not about gross malalignment because of anatomic tibia. It is about the tibiofemoral mismatch.
Okay.
Suppose the tibia is 10 degrees externally rotated and your anatomic tibia is placing it in 10 degrees and femur is in 0 and you are doing a PS implant, that is a problem.
Okay.
So this will give you a combined angle which can be adjusted to be positioned within 5 degrees.
Okay.
You got the point.
Kiran, can you show the flexion of the femoral component?
Yeah, I will do it in, it's around 3 degrees default.
Yeah, default.
So this is now showing a true deformity of this patient. This is around 20 degrees of varus on stress. You can see that.
Yes.
And 11 degrees of flexion. And it is correcting to 7 or 8 degrees. Because we saw that the MPTA was around 12-13 degrees in this patient. So probably he has some bowing. So and this is the maximum correction we are able to get at this stage. You are able to see that?
Yes, yes, very clear.
So I will stress that knee in that position and make the gap adjustments. Okay?
Okay.
So this is the gap measurement we have made. So it's just a provisional gap. It is in varus. So we are not going to address all that varus with the bone cuts. We are going to still do the surgery and then take a call where we accept it. So now you can see here, if you look at the window, there is 8.3 millimeter tightness on the medial side, 11.2 mm tightness on the medial side in flexion. But we have to pivot it based on the lateral side.
If not a restricted kinematics, you would have put the tray in varus?
For even now, I will put it in varus. So now what first adjustment we will do is, we will convert it into 3 degrees of varus.
Okay.
Okay?
Okay.
And then I will increase the slope of the component to 5. Okay? So now that has made some changes to the overall alignment. Now I will increase the tibial cut. Okay?
Okay.
And now, and also take a little bit of additional distal femoral cut. So now my lateral side is more or less balanced.
Yes.
You got it?
Yes, yes.
So what I am prepared to live with is around 4 millimeters of tightness on both sides, equal in extension and flexion. That is easy to balance. But I have discrepant tightness on medial and medial side in extension and flexion. I can't balance it because it's a continuous sleeve. So what I will do, I will rotate the femoral component. And I told you that I am prepared to accept a
till 5 degrees.
Till 5 degrees. So now this is around 3 degrees of rotation. And I will anteriorize the femoral component because you can see it is posterior to the most posterior point. I am able to anteriorize it a little bit.
What size femur you have selected?
This is 5
5.
femur, and I will reduce the flexion of the femoral component by extending it. So now I'm, my combined, this is again a point which you can only do with robotics. The combined sagittal angle must not be more than 10 degrees. That is, component flexion and the posterior slope combined must not be more than 10 degrees.
Okay.
You get the point?
Yeah.
So now I can anteriorize it a little bit. I'm happy with that. This is okay. And now I'm able to balance my lateral back gap, and medial is a little bit tight, so I'm prepared to recess or remove the PCL because that is a structure which is causing that flexion tightness.
Okay.
So
Correct.
this is,
Do you give any varus valgus to the femoral component?
I can give a little bit of varus to the femur if you want. That is not a problem for me. So which makes it, neutral in extension. Overall alignment we are planning is 2 degrees of varus, and we will have to do some sort of a tibial reduction or soft tissue releases to balance that residual tightness. Is that clear so far?
Yes.
Right. So now we are ready to cut the femur.
And the tibia shows too high. You're not taking any bone on medial side.
Yeah,
That's
that is
correct?
because, that is correct. That is
correct.
okay.
With these corrections, can you again once more do the check?
Sorry?
No,
we can't check the gaps now because the gaps are already shown there, right?
Okay.
So here it's already shown here. So this is the 4.2 mm tightness on the medial side,
Okay.
5.2 mm tightness on the medial side, lateral gap is balanced, and the overall alignment is 2 degree varus. So we will require to do some soft tissue release in this patient.
Yes.
So now you have to verify the checkpoint at this stage to see if it has moved or not moved. And usually it is okay, and then and then you are ready to cut the femur. So we will burr the initial cut. Okay. Karo. So now you can see that the notch is getting cut here. So it's an adequate femoral cut. But it is only about a millimeter or so. The green is millimeter, blue is around 2-3 mm, and purple is around 5 mm or more. So here I am refining whether the marked cut on the bone is matching the burr.
Okay.
I am checking because sometimes what happens is with all technology it can give up midway,
Okay.
and it may not work. Then you are stuck. Okay. So now we are ready to do the burr. So you can do a distal burr technique. And since this is it's not as fast as Corey, but it's okay. So we have refined this technique to just take a little bit of cartilage out with the saw blade, and then femur nidicra. Yeah. So just make sure that it is all white, right?
Okay.
So beauty with this is it doesn't eliminate the saw. You can still use the saw. You can still use the saw. It's like a lot of people think that, it has to be burred, everything. It doesn't need to be burred. And a lot of people say it is just navigation. I don't think it is just navigation, Navigation is not an execution tool. Navigation is a planning tool. So it is a combination of navigation with a smart robotic. It's a handheld tool. And I think most of the robotic technology will eventually gravitate towards this sort of technology, which is handheld. This is a cruder version of what it can be. It can be much more quicker. So we already see with Corey that it is so much more faster and better. And you will have more and more, instead of big screen, you will have iPad or maybe virtual goggles into which you can do your thing. That red is nothing to worry about. It just indicates that there is a retraction lag between the burr and the bone and the bone cut there. So it doesn't indicate anything.
Excuse me here. Can I ask a question?
Yes, please.
How much anterization of the femoral component is acceptable, or in other way around, is there any patellofemoral pain post-operatively where patient is struggling with if the component is anterized?
Excellent point. So I did not bring it up because I was hoping somebody will ask that question. The anterior offset is a very measured component of the TKR surgery. So people assume that it is flush with the anterior cortex all the time, but it is not flush with the anterior cortex in all the time because you are again doing a measured resection of the anterior cortex. So if your thickness of the anterior component is 3 millimeter, you must just take 3 millimeter of anterior cortex off, removing the osteophyte to restore the anterior offset, which is again possible with robotics. So in addition to the combined rotation, combined coronal alignment, combined sagittal alignment, we are again now looking at a combined anterior and posterior offset. So you can restore both by this technology. It is not necessary that if you have anteriorized the femoral component, you are not restoring the anterior offset. It is actually, if you don't anteriorize it enough, sometimes you may end up overcutting it, and these patients have difficulty in getting up from sitting position. So most of the people don't measure the anterior offset before surgery, and it is not possible to replicate it with manual surgery. Does that answer your question?
Yeah.
So we are trying to restore the anterior offset. If you see, I am still not restored the anterior offset. If you look at the axial cut there, the component is still a little bit back than what was the normal anterior part of the femur in this particular patient. But that is a limitation of the implant.
Yeah, this is a CR knee, but in a PS knee, it's the same thing. Will you prefer to do that by?
PS knee, we will remove the PCL and then do the gap assessment. And my basis is that on the non-affected side, we are trying to get the gaps balanced. And then we will balance the affected side through soft tissue releases. So this is the rotational alignment. So you can see that it's pretty simple and straightforward. And then you use the
So now you'll use the saw.
we use the saw as you would normally use for any other case, and it will save you a lot of time, you know. And I will show you how beautifully you can use technology.
Do you refine the cuts after the saw?
Yeah, that's right. So we will take a cut. We will take so there are two types of surgeons. You can be very overconfident with your saw cut, or you can be hesitant with the saw cut. So I will take a hesitant cut and then refine the cut with the burr later on. And if you notice, there were a lot of osteophytes at the back, which you can remove, and which will give you a lot of correction on the medial side. आ गया? पूरा हो गया? Okay. So we are just using the robot as an intelligent assistant, that's all. So it is not going to replace the surgeon at all.
Yeah, it's also
Straight there, na? Straight wala there, straight. So you can see there is a big osteophyte at the back, which we will remove later on. And now I can go on to Burrell and refine the thing and see if I've overcut the situation at all. Okay. So this blue will remove the
Virtual move.
Yeah, and then it will make sure that the saw blade is only.
Kiran, can you show me the distal burring what you did, no, with the first, so that the difference between saw and the burr you can make it out, no?
Distal burring, okay.
Yeah.
So there is some issue with this burrow thing. I think we'll shift to the next thing.
You heard about a cut mode. I think it's in refined mode. Just check it.
It is in burrow.
Yeah.
Huh? Distal. No, this is the issue with sometimes with the technology.
No, it's in a, just check, you are in speed control leg goals, that screen has to go out.
No, this is we don't use a speed control at all, it is exposure control.
I can get the cross signs are coming now.
This one?
The target. Yeah.
That we are already done with. So now you can see that it's not actually, it's way away from where we are doing, so that can happen sometimes, with the technology, but I think we'll just go to the tibia now instead of sticking to the same thing. But the point is that we can refine the cut on the femur once we made the saw blade cut. So you can use it. वो ठीक से लगा देना.
But it's not mandatory.
It's not mandatory, it's not mandatory. So this is the tibial cut picture. So we will use a refining tool. We'll just check if everything is fine. So it looks okay. You can see here where I am moving on the tibia. The anterior part of the tibia, it is corroborating, and that is the red area where there is no cut which is expected. So we will take a provisional cut again to make sure that the surgery is done a little bit quicker. So we can use the conventional cutting block. Do you have a conventional cutting block? So this is our standard protocol for all patients.
Oh, okay.
So we will take a minimal cut from the tibia so that it becomes a little bit quicker for us.
Remove the sclerosed bone and then...
That is right. Otherwise the burr on tibia becomes too cumbersome.
You can take the conventional jig with the visualized cut, so you can cut it off.
Yeah, I don't like that visualized cut with the robot, so I don't use it that much. So we just take a conventional instrumentation and then position it at 2 degrees varus and then 0 degree slope, and then we'll just remove a little bit of bone. Pins de do.
So you're using a 0 degrees
0 degree slope. Because I noticed that even if I am very, very accurate with the tibial slope, with the tibial cut, the slope is really off because of the variations in the metadiaphyseal diameter dimensions of the bone. So you will have to really calibrate before surgery to understand. So this is just a small piece of bone. It's around 2-3 millimeter or 4 millimeters. Sometimes if I am short of time, I will take a bigger cut as well. So we remove these pins, and now you can go to burrow, so some issue with this. Burka issue.
But that when you're now burring the depth, how that burr will...
So this removal of this 2 mm, this blue color indicates that the burr now comes out only 2 mm. Because you have already cut a little bit of bone.
Okay.
Otherwise, if I remove that, it will go. If I remove that, it will go 7 mm with this one.
Yeah.
With Cori, it will go 9 mm.
Okay.
We don't want that. So we want it in a much more controlled manner. So I don't mind spending a little bit of time here.
Burring the tibia will give you a good slope, accurate slope what you're planning.
It will give accurate slope. That is absolutely right. Because your saw blade has got so much error with slope. That is my observation. After performing so many surgeries, I still cannot get the slope, everything right with the tibial cut. So although it appears to be easy, usually there is a lot of changes which we have to do with the tibial cut. So although manual surgery has served the purpose for a long period of time, I think technology definitely has its role. It will convert a good surgeon into an exceptional surgeon, because now all your errors are covered, and you cannot tell your assistant or bullshit them telling that this is okay, ye theek hai, because it will give you the data there. And now you will have to justify what is happening. So you also think more and become a better surgeon than you would than you already are. But it will not make a poor surgeon into a good one, because it's not replacing the surgeon.
Yeah, still a lot of thought process goes into the planning.
Absolutely. The same thought process that goes into manual surgery goes into the robotic surgery. And you should still be prepared to convert it into a manual TKR if required. Because whenever there is technology, there can be error with that, so you should be aware of that. But just like the planes have, changed from pilotage, where they would look at Eiffel Tower and then recognize it is Paris, technology has also moved on in leaps and bounds. So if you don't use it, it's to our disadvantage, our patient's disadvantage. If you have an option to use it, you must use it. That's what is my take on it. And without using technology, we should not say that it is of no use. Even if you are a good surgeon, I can challenge you will not get it 100% right in 100 cases. So now we are done.
That cannot happen.
That is right. So now we'll do our, so I've left a small rim of bone there at the back. Saw de do. Give me the tibial sizer, please. So that's done.
That rim of bone is reflects in the robotic screen also. Can you see the blue one?
Yes, it reflects.
That's so accurate, yeah.
It is accurate. And now I will size the tibia. So we have measured around 3 and it is 3. And then we mark out the extra bone there. Pin laga de. So for just the sake of so you can see an osteophyte there,
is there.
which is reflected in the screen as well. Right? So that will go, and the same set of things which we normally do to balance the varus knee, we will do it. So you can see here, this is again an osteophyte. There is a postero, and for each 2 millimeter of bone, there will be around 1 degree of correction which we will achieve.
Yeah.
So I am preparing the tibia here. And it is size 3.
Yeah, if it is 5, then you have to do 3 or 4.
Yeah, so the technology has means to circumvent its deficiencies, where you can still go back and then do the resizing of the tibia. But I think they're working on getting the size right in the first place.
Yeah, that is the one disadvantage with the this Genesis tray, like.
Yeah, that's right.
In this kind, 5, this is okay. Sometimes, most of the time, you get 4 femur.
Correct.
And tibia side, you have to put 2.
Correct.
Then it becomes a problem. Then you have to go for a different insert.
True. That is true. I agree with that. Lift the femur up. So now you check the flexion gap. Lift it up. No need. Just use the hand. No.
You want to release posterior femur, Kiran? You want to release posterior femur?
So I am going to remove the osteophytes at the back. So I am removing the meniscus and the osteophytes, and this hopefully will give us the required correction without tampering with the PCL. That's what I hope. But I am okay to recess the PCL because we have disc insert available here.
How exactly the deep dish, you remove the PCL and think of putting a deep dish, does it?
I always do it and I have no problem with it. So if the requirement is there, then I will do it, because I am worried about the pins and the PS in combination with each other. Curved off. But if you see this case, I am not worried because there are a lot of osteophytes at the back which we can see on the pre-op X-rays, and those will give us a lot of correction. And we just needed 4 millimeters of correction for this patient. Curate, please. Curate nahi hai? Curate nahi hai. Achha, cockers de do. You can see I am removing that osteophyte from the back, which will correct both extension and flexion tightness for us.
Any questions from the audience, please?
So these cases we have to be careful. If we don't balance it properly and try and do trial reduction, sometimes it will avulse the MCL.
Oh.
So be careful with the trial reduction before you do the complete. Yeah, so now I've removed all the osteophyte at the back and it looks pretty good. You can see the gap, looks reasonably balanced. Okay.
The posteromedial osteophyte sometimes impinges and pulls out the MCL
correct.
attachment.
So the PCL also looks just a bit tight. So if you remember, the flexion gap was around 5.6 and extension was 4. So the PCL will influence only the flexion gap. So I'm just recessing it just a bit to make sure that it's okay. Give me the trial, please. 3/9. So this is the 3/9 insert which goes in. Looks reasonable.
Excuse me.
It's a 9 size insert?
Yeah, 9 insert. हाथ पे दे दो ना.
Have you seen any difference?
Kiran, there is a question for you.
Yeah. Have you seen any difference in gap assessment pre-operatively or pre-cutting if you remove meniscus versus you remove meniscus after cutting?
Yeah, there will be a gap. There will be a slight increase in the gap if you remove the meniscus beforehand. But having said that, these gaps are individualized. It is for the individual surgeon. It is not for, you can see now this is well balanced in flexion. There is just a bit of rotation in flexion. And when I put the knee back, and that looks pretty good to me, So now I'm happy to, it's fully extending, looks valgus. I'm happy to finish. Femur nahi dikh raha. Aap hat jana zara. So this is around 5 degrees of varus is okay for me. Opening to 6, that's the restricted kinematic protocol. 3 degrees of flexion, and in flexion it looks pretty good. Wo de dena? Haan, kar raha.
So how much of flexion you are able to achieve now?
I'm able to get it to around 3-4 degrees of flexion and maybe around 4-5 degrees of varus. That is okay for me. So I'm happy with this.
So in this stage, can we see the placement of the tray in the screen?
Yeah, we can see next with the thing. So this is within the restricted kinematic alignment protocol, okay? So this is okay for me. So I'm happy with this. I will continue. And you can see the soft tissue laxity here. Because you saw that the femur moved probably. That is why we were not able to get this tracker rotated. So therefore we were not able to get this model right in this particular situation. But rest all pictures are all right.
Why is that the tracker moved, is it?
No, this is a hexagonal tracker. So it can rotate a little bit. When it rotates a little bit, then that model goes off.
Okay. So you focus on the graph.
So you focus on the graph.
Not on the model.
So usually the model is also right, but this has been obviated in the Cori because now it's not an hexagonal slot anymore, so it will not have that micro movement as well.
So can you calculate the tibial tray? Is it in varus? You have put it in varus or in neutral?
Yeah, it is in varus. You can see the tibial tray is in varus.
Can you make it in the full screen? Here we are not able to see.
Yeah, can you make it full screen?
Anand?
So you can see this is exactly what I want. It is slightly lax in extension, slightly lax in flexion, and very tight in mid flexion. Can you see that?
Yes.
So a millimeter or so of laxity in full extension, millimeter or so of laxity which is equal on both medial and lateral sides in flexion, and it is tight in mid flexion. So it is going to be a very good joint for the patient. So we will complete the cementing and all. I think you can proceed with the program if there are no more questions.
Any questions at this
Can you
stage?
show the data, no? The eye screen, information screen, yeah.
Yeah, so that is the planned alignment is 2 degrees. We have achieved 5 degrees of varus, which is within the confines of functional alignment. That is okay for me. And that could also be related to this femoral pin a little bit, getting a little bit loose or something. So clinically it looks reasonably okay. And you can see the patellar tracking with the subvastus approach. And you can see how the overall thing looks very, very good.
So mainly focus on the balancing graph.
That's
across
right.
the 0 to 120. Yeah.
One last question, Kiran. Like in the subvastus approach, when you close, that you're closing the muscle to muscle.
That is right.
So the scarring doesn't happen, or is it
No,
not?
there is no muscle here. There is just a, remove these things. So now we are ready to remove the trackers.
Right. Okay, one last question.
Sir, you put a deep dish always only when you are removing PCL, or even with the PCL in a rheumatoid case you use a deep dish?
Rheumatoid patient, you can use a deep dish. There is no harm in doing a deep dish.
With
But
PCL?
even with PCL, you can use it because they are all anteriorly lipped. They are not posteriorly lipped. So if you have something like a Biberon lip which is more elevated posteriorly as well, you cannot use it with a PCL intact. You cannot use a BP knee with PCL intact. But the Smith & Nephew, the DEPI, these can be used because they are only anteriorly lipped.
Thank you.
The Debron and the Person ultra congruent, you can't use with PCL.
Correct.
Remaining everything can be used.
So when the posterior lip is elevated, you cannot use it because now it will impinge. But if you have only anterior part which is elevated to give more stability for restraint or a late PCL rupture, that is fine.
Yeah, can you now remove the pins? Can you just show one final
Yeah, I'll show you the closure, how it will come.
moment? Yeah, then we'll go off.
Thumb process.
Full screen.
Can you mix the
yeah.
cement and open the implant, please? हो गया ना पूरा अभी preparation हो गया ना. So by the time we do this thing, the cement is all mixed. You know, so it saves a lot of time because we have already prepared everything. So this comes here. Can you give me the stitch, please? कोई सा stitch दे दो, कोई सा दे दो. So we normally use straight affix in our practice. So it's a barbed wire suture, you just run it through.
No need of knots. It's
No
just
need of knots, yeah. It's much quicker, and you know. So this is apex stitch, which will give us some idea. So you can see that.
Okay, yeah.
So and then just go down and go down. That's it.
Right. Okay. Thank you, Kiran. Thanks
Kiran.
for the
Thank
wonderful
you, Raj.
demonstration.
Thank you, Ashok. Thank you for chairing the session. Thank you, Narendra, for the opportunity.
Thank you. Thank you.
Thank you, sir. We'll move ahead to the sixth live surgery, that is robotic assisted total knee replacement with ROSA by Dr. Alpesh Patel. I would request Dr. Rushikesh Saraf and Dr. Nilesh Kulkarni to chair this session.
देखते हैं ये कितना परेशान करते हैं. Sir, your mic on, sir. ये वाला कितना करेगा? This would be a problem. Hello. Hello. The mic is on. We are with the this.
Hello, Alpesh.
Hello. I am audible.
Yeah.
Okay. Good evening, everyone. We are ready with the case. This is a male patient. You can just focus on the X-ray. This is a standard varus knee. We are going to operate on left side, and the deformity is around 8 degrees. Okay, we are going to use the robotic knee system to perform the case. The robotic knee systems come with two units. One is the robotic unit, and second is the optical unit. The robotic unit have a main console and a planning screen, and the optical unit also has a planning screen. Both these screens would have the same data. We can manage from the robotic screen also and the this optical screen also. We'll start the case.
Dr. Alpesh. Dr. Alpesh.
Thank you, Tunikat. The ROSA system has the advantage that it has.
Hello. Dr. Alpesh, can you hear us?
It has two options. Image-based case and image-less case both can be done. In the image-based case, a specialized X-ray is required, which gives the full anatomical details and the implant choices. And the image-less case, we can directly register on the directly register on the operation, doing the surgery by surface mapping. So today we are going to perform a image-less case.
Dr. Alpesh, can you hear us?
Yes, I am able to hear.
Can you please explain the OR setup for ROSA, positioning and all?
Okay. Hello? You can just increase the sound. No, this sound I am not able to hear. Just you can repeat the question.
Can you explain the OR setup for ROSA, positioning and...
Yes, the ROSA, you focus on this robotic unit. ROSA knee platform has two units. One, this is the robotic unit, and robotic unit have a robotic arm and a planning screen. And another is the optical unit, opposite side. The optical unit have a laser beam and a planning screen. Both planning screen would give same information. We can adjust the cuts and we can perform all the actions from both the planning screens. Now the this ROSA system have two options. One is image based and another is imageless. In imageless case, no pre-operative X-ray is required. The data is collected by surface mapping. And the image-based case, a specialized X-ray with marker is to be taken, full leg length, and which is to be processed, and the data which is received will give the implant, the full alignment and the implant choices. So today we are going to perform a image-less case. We are positioning the ROSA. We are positioning the ROSA, the robotic arm. This robotic arm unit is adjusted just about 2 finger breadth above the knee and parallel to the knee. Okay, this is the robotic arm interface, and this is the robotic arm unit.
Okay. How much assistant do you require for the surgery?
The registration, again repeat the question.
How many assistant to perform the surgery?
You need 2 assistants. We are aligning the ROSA at present. The alignment and the registration process takes around 5 to 10 minutes, and once the registration is done, the surface mapping requires around 3 to 5 minutes. Done?
Any specific patient selection criteria for doing ROSA robotics?
No, there is no specific selection criteria. We can do even for the bad varus knee and valgus knee also. The ROSA system has the advantage of using, it can be used in bilateral case by operating by keeping the robotic unit on the same side. It has the option of keeping the robotic unit on same side and opposite side also. And surgeon can also stand on same side and opposite side. The OR setup has different options like selecting the surgeon and robotic unit position. And even in bilateral cases, we did not require to shift the unit.
Which method you prefer while doing bilateral?
Bilateral, usually I start with right side and keep the robotic unit on right side and surgeon on same side. And when the opposite side, left side is to be done, then the robotic unit remains on the right side and surgeon moves to the left side.
Okay.
So here in this case we are operating left case and the robotic unit is on the left side. Okay.
It's most preferred approach.
And but in bilateral cases, we need not require to move the robot to the opposite side.
Hello.
Hello.
Alpesh,
Yes.
have you faced any problem with sterility of the robotic hand? Because the lights and robotic hand looks very close to each other.
No, today we have, due to this camera positions, we have moved the light to opposite side.
Okay.
Okay, the problem is with the positioning of the camera to display. Otherwise, the one light is on the upper side and another light is in the foot end side.
Okay.
The standard practice is this. But today, because the light is coming from this camera is positioned on right side and it would interfere, we feel that it would interfere with the laser beam. So what we have tried to position the light on the opposite side.
How much time it takes to prepare your robotic hand or keep it sterile?
Robotic sterility issue, again, what I didn't get you.
To cover the robotic hand with sterile drapes?
It takes around 2 to 3 minutes.
2 to 3 minutes, not more than that.
Not more than that. And again, what is happening is this: we have tried to position the camera on top side. So that is why that registration issue is there.
I think that proximal end of the draping should be far away. So that will help you to accommodate the ROSA arm.
Next. This is the registration of the ROSA is done. The ROSA is calibrated to check the calibration and there is no hindrance in working or robotic arm has no locking. This OR setup can be done before the starting of the surgery, does not require any trained skill. So this step can be completed before the starting of the surgery. That can save the time of the surgeon also. We will start the case. I put a standard medial parapatellar incision. For sir. Like in conventional cases, first medial release is to be done, which is not that much extensive, but we need to expose the posterior osteotome or periosteum and collateral.
So while using ROSA, you remove all osteophytes or you keep the osteophytes?
No, we remove the osteophyte, whichever possible are osteophyte we remove. Reason is to have a proper assessment of the laxity, small knife.
And to begin with, you release up to posteromedial corner or you decide about that afterwards?
No, up to postero-medial corner, but only in the upper part, not too much down, not extensive release.
Only deep MCL part.
Deep MCL part. Then we patellar fat pad.
You can use ROSA for total knee replacement, or also you can use it for uni knee, total hip.
Uni knee platform has not been introduced in India at present.
Okay.
Uni knee for persona has been launched at US, but it has not been introduced in India at present.
And what about patellofemoral replacement?
Patellofemoral joint not available.
And hip?
Hip, it is not launched yet, but it is under process. At present, it is for only total knee replacement, and it can be used in all the available implant option, like when the Zimmer has option of next gen Zim, Persona and Vanguard. What changes is when you use the system, you need to change the cutting guide. This is the cutting guide. This cutting guide needs to be changed. This is cutting guide for next gen. But if we want to do persona, then we need to apply the cutting guide for persona.
Do you regularly use next gen or persona system?
Persona system. File. Patella is relatively good. Done. Tibia forward. I usually forward the tibia before registration so that it becomes easy in registration. Lateral. Forcep. Meniscus. Nibbler. Retractor. Remove this.
I think that's a good idea to remove the meniscus before getting all the collecting the points and planning for the surgery. That gives you exact information regarding the knee status.
Yes, usually I remove the meniscus and then do registration. We are now removing the osteophytes. Osteotomy. Pins, tracker pins. Remove this. Small knife. We are now going to put the tracker pins. We will require 2 pins in femur. No.
Any specific tips regarding trackers placement?
4 finger breadth above the 4. The pin should be unicortical or just touching the opposite cortex. Knife, this trackers. Pin, small pin. The trackers are to be placed 4 centimeter above the joint line and slightly external rotate the trackers so that the visibility to the optical camera is good. On the optical camera unit, we can see that the femoral tracker is well in the center of the box. There is a bucket-like shadow in the optical camera unit. You can show this. The tibial trackers are placed around 4 centimeter below the tibial tuberosity, midway between the shaft and parallel to the this joint line surface, and the second tracker need to be rotated 10 degrees. We need to check in flexion and extension that the tracker is visible. Flex karo.
Actually, that's a good idea. So whether your trackers are visible, then only put the second pins.
No, usually I follow that. So, because if the trackers are not visible, then it becomes then it is now practically not possible to execute the plan. Once the trackers are placed, we move further to the registration. There are 17 registration points. First is the femoral head center. You need to create a big optical elliptical circle. But what I have done is, I have found it is very easy to move from right to left. Practically it would create a elliptical curve. So this was registration of the femoral head center, then registration of femoral canal entry point.
I think in the ROSA to calculate the femoral head center is quite easy.
Quite easy. This is the digitizer for posterior condylar axis. We maintain somewhere between 3 to 5. Anterior trochlear notch. I put my 2 fingers, one on the upper side and second on the inferior side. So it would register, it would be in the same line. This would give the idea of the AP axis. Then femoral medial epicondyle, distal medial femoral condyle, for 7.
Can you adjust the camera position at any time during the surgery, or we need to keep it static?
Practically it is, we can adjust, we can move the camera, but most of the time it is not required.
So Alpesh, here you don't need to mark the femur completely.
No.
You have to just collect few points.
Yes.
So what do you feel? Is it easy to collect medial and lateral epicondyle and posterior condyle and all the points on the anterior cortex?
It is absolutely accurate. Based initially, what we have done is we had done a case study of around 30 patients where we had measured the actual cuts, means we what was the plant cut, and we had measured all the cuts on with calipers. And there was hardly more than 1 mm oversizing of cut was there in only one or two patients. Otherwise, it was absolutely accurate. Tibia forward then. You take that. So this is the registration of tibia and femur is done. This is knee stat evaluation screen where we can assess the laxity in different degree. This is showing 9.5 degree varus, flexion of 2.5 degrees, apparently does not look to be in flexion. Okay. So this is the knee state evolution screen, which shows medial and lateral laxity of 4.5 in extension, 0 degree, and in flexion there is medial laxity of 0.5 and lateral it is 3.5. So knee is loose on lateral side, medial side is okay. Once this is done, we get a planning screen which shows flexion, extension and balance. So target is ki we should somewhere the implant thickness is 19. So we cut around 19 to 19 mm in extension and 18 to 19 mm in, we keep bit tight in flexion. So here the cuts are more on lateral side. So we are decreasing the resection in tibia.
Can you tell your preferred sequence of planning?
I balance on only one side, that is normal side practically. So laterally we should balance. So first in extension we have targeted that the gap should be around this knee is loose in extension.
Babu, give me only robotic screen, please.
You are able to
remove PIP, remove the PIP.
Now you are able to see the planning screen.
Perfect.
Yes? Okay. So in this screen you are able to see extension and flexion. The planning screen shows it has two options. One is view in extension, one is view in flexion. And second thing is this is without balance, where we can change the posterior slope and flexion of femur and styler side. So and in balance we get the idea of what amount of box would be generated after the resection. So here what we are seeing is there is 18 mm of total rectangular box space generated on the medial side and 22 mm on the lateral side, and in flexion of medial side is 14.5 and lateral is 19. In this case we can internally rotate, externally rotate the femur to 5 degrees so that some space, medial space is generated more. We did not change the numbers more. Practically the logic is ki, we should go ahead with the, this correction. In flexion there should be no notching. Stylus height should be maintained between 0.5. Okay. We go ahead with the resection.
No any adjustment on the tibial side?
Tibial side resection is 3.5 on medial side and lateral side is 7.5. That is okay. Sure. We have the option to resect femur and tibia as per the surgeon preference. In this case we will be going with femur first, distal femur first. The robot comes in the automotive mode, and once it reaches the bone, it changes to collaborative mode. In the collaborative mode, we can change the mediolateral plane so that we are over the bone. In. Stylus, Z-Retractor, medial collateral, angle wing. We can, in this system is the workflow is same as conventional surgery. So we can even check with stylus that we are okay or not, and that gives a confidence in the system again. Validation. नीचे का निकाल.
Hello, one question.
Yes.
Now here the jig was placed by the robotic arm.
Yes.
Okay.
Yes, you can show the screen. Yes. Now this is the validation tool which is showing the amount of resection we have done. Register not have. 1 minute. Register not have. Snapshot ले लीजिए. Done. वही पिन रिवर्स करके पिन. Yes. Pin remove देना. hold T. Okay, we'll go with the workflow of now 4-in-1 tibial. We'll go with the workflow of tibia. You take this. Tibia first, so that we can check the extension cap. Over. Okay. Pin inserted. Suppression. Done? Okay, done. Now, lateral. Medial. Okay, lateral. Osteoto, cocker and knife. Validation tool. This is the, you can show the planning screen. This is the cut taken in the tibia. We are not perfect. Okay. No, removal of pin. Give me a saw, collateral. There is a small piece of bone behind. Just saw. Spacer block देना. खींचो. So we are able, the block is absolutely rigid. There is no laxity. So here we can check the flexion extension gap without any changes in the position of the robot. This system has that advantage that we can check the flexion gap and then move to the. If you see, though in conventional case, this knee is opening more on lateral side and medial it is opening less in flexion. And we have selected even 5 degrees of external rotation in this. Now we are going for 4-in-1 cutting block pin insertion. ના કાઢવી પડશે ને, જીગ રિમૂવ કરવા. वापिस पिन डालना है. लॉक થઈ ગઈ. ओके. We have taken G size, stylus, angle wing. We are checking for the notching. Like just conventional cases, we can cross check all the cuts. Ani peg. छः collateral. You can show here, absolutely the piano sign is available. You can show here, ऊपर से collateral. You can see the piano sign. There is no notching on the anterior side.
Hello, Dr. Patel sir.
Yes.
Satish here. Actually, we are running out of time, so we request you to rush up a bit. And the US surgeon, Dr. Edmund, is online there, so we'll run both surgeries side by side.
Okay.
Is it okay with you, sir?
In our case, the extension gap would be visualized in only 2 minutes.
Okay, sir. Yeah. Thank you.
That will almost make principles clear. Pin.
Yes, sir. Sure.
नहीं अभी बढ़ा. छोटा प्लेट लगाना, पिन रिमूव करने के लिए देना. निकालना पड़ेगा. लिफ्ट कर. मेनिस्कस, मिडिल मेनिस्कस. लिफ्ट करो फीमर को. I am removing the meniscus at this stage. Femur lift करना है. फ्लेक्शन बॉक्स गैप देना ऑस्टियोटॉमी फॉरवर्ड ऑस्टियोटॉमी बॉक्स देना ब्लॉक स्पेसर ब्लॉक लिफ्ट करना सीधा कर the block is a bit tight on medial side, otherwise it is okay. Flexion and extension is okay. We'll go ahead with the box cut.
Dr. Alpesh?
Yes. You can shift over to another surgery simultaneously.
Yeah, thank
No
you,
issue.
because
Okay.
we are running behind time.
No, sure, sure.
So we'll shift to next surgery. Thank you. Nice demonstration.
Okay, thank you.
Yeah.
Sir, you can show us trial and the graph. Patel, sir?
Once it is done, we'll come back.
Sir, you can get trial done and show us the final graph on screen.
Okay.
That's okay, sir. Yeah.
Okay. Bag નથી આમાં બોક્સમાં चलो पिन देना छोटा ब्लेड Tibia forward.
Patel, sir?
Yes.
We request you to show us the trial and the graph. Can you do that?
Yes,
If
yes.
you don't
Only
mind?
2 minutes. We are preparing the tibia. It will take only 2 minutes.
Okay, sir.
रिलीज करूँ पड़े हेलो 5 4 देना ओके 10 हाँ डन कर फॉरवर्ड करो डन चल Pin. पकड़ना. ट्रायल આપી દેજો પેલા કીલ વાળો. Five. Five. Right.
Hello? Patel sir, we can see the graphs. Hello? Hello?
Babu, could you get us back to the theatre live, please?
चांगलं आहे.
Check.
Okay, done. Now, trial remove. Check.
Thank you very much, Dr.
Okay.
Alpesh, for a very nice demonstration of Rosa Robotics.
Sure, thank you.
Thank you, sir.
Beta?
Thank you, Dr. Saraf and Dr. Kulkarni. I would now like to invite Mr. Sandeep Makkar, the Managing Director of Johnson & Johnson Medical India, to address the vision of Wellness Robotic Systems.
किसको लगाना है? ये लगा दो.
Hello everyone, welcome. It's just wonderful to see everyone face to face after such a long time. Dr. Vaidya, thank you so much for putting together this wonderful technology-oriented symposium. You know, it's nice to see this surgeons community getting transformed into engineers and surgeons, you know, at the same time. And what a change I've seen in the last 3 to 4 years. So I'm here to talk about the next chapter in digital surgery, the VELIS system from DePuy Synthes, Johnson & Johnson MedTech. So with that, you know, why is it different? What's so different about this? Why is it the next chapter? Well, it's the next chapter because it takes the inputs of 3,500 surgeons from all over the world, their learnings around technology, their learnings from other robotic systems, and really brings it together to address the unmet needs that are still out there. It's also the next chapter because it's simple, it's intuitive. So it reduces your cognitive burden as surgeons. It's also the next chapter because it's efficient. It streamlines your workflow. And it's also the next chapter because it delivers a more personalized care, whether you're doing your cuts or soft tissue management. So, you know, and what good is a robotic system or robotic assisted surgery if you're not really building the overall capabilities around it? So as Johnson & Johnson MedTech India, as a managing director of the business, I just want to assure this community of surgeons that not only are we going to launch the VELIS digital robotic system here, but we are also building big capabilities in India, whether it's on supply chain, making sure that the implant continuity is there, that India is prioritized for the knee implants that will get used on the VELIS robotic system. Also, world-class professional education capabilities, including virtual reality and cadaver lab partnerships. And also a world-class service and repair capabilities in India as well. So we've trained our engineers that will be available here to service this system as well. So we're very proud to launch this. We're in the middle of a launch process here as well. So with that, I want to introduce an innovator, early adopter of technology, Dr. Redmond, Dr. John Redmond. He was trained at Mayo Clinic. He was actually also awarded by the Mayo Clinic in terms of his excellence, his clinical excellence, his compassion, his competency. He's authored over 40 articles and has just been at the forefront, you know, since then. Now he works at Jacksonville at the Mayo Clinic and St. Luke's. He's been an absolute forefront runner, whether it comes to adoption of digital surgery, robotic assisted solutions. He's done 2,500 surgeries. He was the early adopter of direct anterior approach in hips. He does complex hip surgeries and also muscle sparing joint replacement techniques. So with that, I won't take any more time. Dr. Vaidya, over to you and Dr. Redmond.
Hello, Dr. Edmund. Nice to have you in this meeting. Sorry for the delay. We're running a bit, you know, behind schedule. So without wasting, I had a short visitation and a short stint with VELIS system, and I saw that. It's very compact, and it's a 4th generation robot where it is an image-less system again, and it sits on the table. So there is no console which comes near the table. And it is a saw-based model. It has got certain specifications like, you know, you see this surgeon controlled saw, so there is no burring or anything required, so that learning curve probably might be less. Precision of that saw when I tested on the bone model was quite good. I am not a right person to tell about the in-patient because I have not used it in cases of, you know, patients, which Dr. Edmund will tell us. The sensors were very fast and hydrophobic array, so, you know, there is no need to clean it completely. And the feel, the end point of the saw, that feel is really good, the natural feel what we are used to. And the screen also, I think many people who have used the knee 3 system, there's a very simple and straightforward sort of a screen where your adjustments can be there. So there won't be much of a learning curve. I think with that, I hand it over to Dr. Edmund for his surgical demonstration. Thank you.
Okay. I'd say it's good morning here, but good afternoon there, I believe. Thanks for inviting me to participate in this conference. I appreciate it. I think we're about to play a video. We have we recently obtained a VELUS robot in our ambulatory surgery center in Jacksonville, Florida, and so we shot some video footage of the technique. So this is me. I've opened up the knee and I've put the femoral and tibial arrays in. I just placed a checkpoint on the tibia for tibial registration, and I'm using a marker here just to mark those spots for in case an array gets bumped later. And then, like a lot of robotic and navigation systems, the first step is going to be to acquire landmarks for the entire femur and entire tibia. I think my assistant's getting the camera positioned right there so that we can see the arrays. And then we'll start taking checkpoints here. So this is the tibial checkpoint. That's the femoral checkpoint.
So Dr. Edmund, this is not a fixed point, or you don't have to put any pin or anything to determine these fixed points?
I put my tibial pins outside of the wound so I can still have the software program when I have the real implants in. So I put a small hole in the tibia, and I use the femoral pin for a checkpoint on the femur. So I just took the hip center there, and right now I'm collecting the ankle center. The computer is going to calculate the midpoint between the malleoli for the distal aspect of the mechanical axis of the tibia. And I'll have an assistant hold the extensor mechanism out of the way, and I'll start taking points on the tibia. So the top of the mechanical axis of the tibia will take something in the center of the footprint of the ACL. This is an imageless system, so no CT scan or MRI required. And then I'm taking points on the medial and lateral tibial plateau for resection levels. And then you also, you define the AP axis and the slope of the tibia.
So you don't have to map the entire surface of the bone in this system. You have to just register some points.
The tibial registration is actually quite simple. It's 5 or 6 points. You define the mechanical axis, you define the axis for slope, and then you define resection levels on the medial and lateral plateau. And here I'm painting the femur. So you paint the distal condyles and the posterior condyles. The computer takes 200 spots along the condyles to define the most distal and most posterior aspect. And then you run the pointer along the anterior cortex of the femur so that it knows where the saw blade will exit for the anterior aspect of the femoral component. So my research assistant is filming this with an iPhone, and right now I'm just confirming that the registration that I took, I think we'll turn the screen here in a second. So on this screen, I'm confirming that the points that the computer has chosen are in fact the most distal and posterior points on this patient's knee. And so you can see there's kind of a cloud of points, and I'll run my pointer along the bone to make sure that there's no points more distal than what I've collected, or more posterior than what I've collected. Just basically verifying the model. Sorry, that screen could be tilted better.
How much distance you accept, like 0.1 millimeter to 1 What's the difference except for those points?
Yeah, there's a couple things I'm checking. One, that I didn't step on the pedal while the probe was off the bone, so I didn't collect any error, an air ball or a point that's not actually there. And then I'll accept anything within about 0.2 to 0.4 millimeters.
Okay.
So once I've verified the model, then I'll collect soft tissue data. So what I'm doing here is I'm putting some retractors in so that I can remove all the osteophytes around the femur and the tibia.
And what's your alignment philosophy? You always go for a mechanical alignment, or you do some kinematic adjustment with this? And how easy it is with this robot to do a kinematic alignment, if at all one has to do it?
Well, I use patient-specific alignment, and we can elaborate on that if you'd like. People that are kinematic alignment can also use this robot very easily, because you're mapping cartilage and bone, and I think you can understand the anatomy of the knee quite well. I think the robot's tailored to whatever alignment philosophy you like to use, because you're going to get data on the topography of the femur. I like patient-specific alignment, and so I think this patient's in a little bit of varus, and so I'll correct this knee in a little bit of varus. But basically what I've done there, I've removed the osteophytes, and now I'm collecting soft tissue data on the medial and lateral side of the knee. And so for me, my background, before kind of adopting this system, I had done a couple thousand Maco knees using patient-specific alignment, and so I still use a very similar workflow. Other people do this very, very differently, but what I'm doing here is I'm putting tension on the medial collateral ligament in extension, and putting tension on the lateral collateral ligament in extension.
So what's the difference you noticed in Maco and this system, what you now following?
Well, several differences. So the first thing is this is an imageless system. I think that's one of the larger differences. So for me, in our work environment, I do about 500 to 600 knee replacements a year. And so to try and get that volume of CT scans and get insurance approval and get the CT scans to the operating room becomes a bit cumbersome. So with this system, I don't need to, from an administration standpoint, this makes that quite easy. The cutting, the soft tissue balance graph with the Maco, you just collect points at 0 and 90 degrees. With this system, you can see the entire arc of motion. So if you like to pay attention to mid-flexion instability or tension in deep flexion, you can see that. The graph that you're seeing on the computer screen there on the right side, that's the ligament tension throughout the entire arc of motion. So the cutting device, this does not have haptic boundaries, so it'll keep you in plane, but you can, as a surgeon, you can control the blade and use it in any direction you need to get to the outskirts of the bone. So I'd say those are some of the bigger differences. So what I'm doing here is I've now collected soft tissue data. What I like to do, I'm a cruciate retaining surgeon, so I also like to tension the knee in flexion with both compartments at the same time to make sure I'm not going to run into PCL tightness. What I was doing there before is collecting flexion data in each compartment as I flex the knee.
Can you explain what just you did? What sort of instruments those you have, and what?
Yeah, sure. So, just for simplicity, if you want to pause the video for a second, that's fine. Just for simplicity, I use a curved osteotome and a Cobb elevator, which are two instruments I already have on the field to tension the flexion space. And I'm going back right now, and I'm confirming that the numbers that I have on this soft tissue graph are in fact what I want before I make any bone cuts. So I'll test it in flexion and extension at least twice per case before I go on to plan the arthroplasty. In this system, there is a monitor that the surgeon can use, which is draped sterilely there that I'm using. There's also a monitor on the far side of the room that if you have a representative, they can help control implant positioning.
So how big is the footprint for this system?
It's quite small. It was designed for, if you have a really small operating room, you can actually attach the robot to the bed and then wheel the cart out of the room, so you just have one camera, and then the robot is attached to the bed.
All right.
So it can essentially have almost no footprint. In the United States, we have, my ORs are quite large, but I understand from a worldwide perspective, there are folks that operate in a much smaller environment. So in this particular knee, like I said, I use patient-specific alignment. The extension space is actually quite balanced without much manipulation. After I tensioned this knee, the flexion space was wider than the extension space, and so what I'm doing right now is I'm adjusting the components to try and get the flexion extension spaces to match. What I've found over time, so in this system, the number 11 is the thickness of the tibial component. And for me, I try to aim for a 6 millimeter polyethylene in this system. So it's 6 millimeters of polyethylene and a 4 millimeter tibial base plate. So the numbers that I like to see in extension are 11. And then I will typically plan the posterior medial flexion space at 12 and the posterior lateral flexion space at about 13 or slightly above that.
So you deliberately keep the lateral space slightly more than the medial space, is it?
Yes. So when we first started using patient-specific alignment with robotics, many of us would use an Insall-Kelly technique where the lateral side was the same as the medial side, and what we found is those patients had trouble with stiffness. So for adequate rollback, I think you want to leave that posterior lateral space slightly loose so that the knee can roll back. And anatomically, as you're operating on a standard knee, that posterior lateral space opens up quite a bit in a native knee, and I think we need to try to recreate that anatomy somewhat. So what I've done here, so those numbers are actually, to me, those are the numbers that I would like to see from a soft tissue standpoint. The problem is, to get there, I ended up resecting 11 millimeters of distal femur, which for me is too much. I don't want to elevate the joint line. So what I'm about to do next is I'm going to distalize the femoral component, but to do that I need to fill up the flexion space. So I'm distalizing the femur, and I'm switching from a size 4 femur to a size 5 femur. And with anterior referencing, that'll close down the flexion space. You saw the numbers in the flexion space just went to 9 and 10. So that's too tight. So what I'm doing now is I'm taking some flexion out of the femoral component, rotating around the anterior cortex to open up the flexion space to get the flexion extension spaces balanced, and then I'll resect a little bit more tibia. So now I'm back to the soft tissue balance that I like, and to me, when I look at those numbers, I'm taking 9 millimeters off the distal femur, which is about the thickness of the component. And I'm taking 8.5 off the posterior medial condyle, which is about the thickness of the component, so I won't lose any posterior condylar offset, and my joint line will be appropriate. So once I have that plan, the rest of the case is typically very straightforward, because now all I have to do is cut an implant. So I use a pretty easy self-retaining retractor system. I don't like assistants around when I'm cutting because they can get in the way of the arrays. So I'll put a 90-degree Homan over the extensor mechanism on the lateral side of the tibia, and a Z-Retractor medially under the medial collateral ligament. And then I can cut without any assistance around. I think I caught the drape here a little bit. And now this is the distal femoral cut. So you let the robot come into plane. Once it finds its plane, engage the trigger. And then from a cutting standpoint, I've had experience with Maco Rosa, and now this. This is very similar to how you would cut using a cutting block or a traditional total knee, but the robot keeps the saw blade in plane.
So if the leg moves during the surgery, how much play is tolerated by the robotic arm?
Almost none. If you push on the saw or the leg moves, the robot will cut power to the saw, so it can't cut.
Is it haptic control? Like, is it?
It's planar controlled, but not haptic bound. There's no haptic boundaries because it is an imageless system.
Okay.
So I've made the distal cut there. Now this will be the anterior cut. And then there's a foot pedal. Every time you push the foot pedal, the robot will rotate the saw into the next cutting plane. So now we're done with the anterior cut. So I make sure my Z-Retractor protects the medial collateral ligament, and then I'll cut the posterior medial condyle. And again, you can bounce the saw blade to feel the posterior aspect of the condyle.
So virtually you don't require any assistant as such.
Over the years, I now prefer no assistants around me when I'm cutting because I don't like them to move the leg and I don't like them to get in the way of the camera. So here's the posterior chamfer cut. Assistants all want to help, but they like to get in the way. And then the anterior chamfer cut is here. So when we go to the tibial cut, so a couple things happen. You have to recheck your tibial checkpoint to make sure the array is still where you planned it. And then I'll also move that Z-Retractor down under the, we skipped a spot there, but the Z-Retractor gets placed under the medial collateral ligament on the tibia. You can operate the saw with one hand, so I'll use the 90-degree Homan to really pull the patellar tendon out of my way so that I can get to the lateral side of the tibia.
Narendra, hello.
Hello.
In severe cases, do we have to do releases before taking the cuts? In severe deformities?
I'm sorry, I missed the question.
There's a question from audience that in severe deformities, do you do the soft tissue releases first or bony cuts? What is your protocol?
So yeah, for something that I do patient-specific alignment, and I try to have a boundary. So we'll use a severe varus knee as an example. So what I'll do is I will put the femur in 2 degrees of varus. I'll put the tibia in 2 degrees of varus, and I'll externally rotate the femur to get it close. Now, if the deformity for me is not correctable within 4 degrees, then what I will do is plan the lateral side of the knee where I want it, and then I will do a soft tissue release on the medial side to catch the lateral side. So for me, I'll plan the lateral side of the knee for a 6 millimeter polyethylene, and then I will leave the medial side tight, and I'll do soft tissue releases and until I catch the lateral side. So I'm still not ending up with thick polyethylene and have reasonable resection. Does that answer? Is that okay? Does that answer the question?
I think yes.
So the bone cuts are made. The video skips over the part where I remove the meniscus, and then I put the trials in. I like to feel the PCL to make sure it's not too tight and deep flexion. In this particular knee, I think we'll switch to the camera here. When I'm in flexion, I'll rotate against the hip. I like to see the medial side be able to open up about a 0.5 millimeter to 1 millimeter, and then the lateral side open up 2 to 3 millimeters. And then the extension space I like tight. So this is the knee after I've cut. So the knee, I might have went a little too fast there, but the knee came out to full extension. It might have been in 1 degree of valgus. And then what I'm doing on the right side is testing this polyethylene thickness and going through this graph. So I'll go back and I'll tension Again, the medial collateral ligament inflection and extension, and the lateral collateral ligament inflection and extension. And those numbers that you're seeing there are what the computer believes is the gapping of the bone with the real implant in. And I like to see about 1 millimeter of play on the medial and lateral side and extension, 1 to 2 millimeters and 1 to 2 millimeters in the posterior medial flexion space and 2 to 3 in the lateral side.
There's a question from audience.
Yeah, John, so when you are using the saw to do the posterior medial and posterior lateral cut, does the blade or saw stop as soon as you cut? And if you are going to go beyond the bone cut, say you're not damaging the soft tissues posteriorly, so does the saw stop automatically or you have the control over that?
No, the saw will not stop. You have control over it. So this is one difference between a CT-based system and an imageless system. The computer doesn't know where the back of the femur is, and so you have to use tactile sensation, just like if you're doing a manual knee, to stop the blade. But you're activating the trigger just like you would a regular manual saw.
So the very advantage of robotic surgery that it prevents injury to the soft tissues is not there in this system, which we have in a CT-based system, because there the burr stops actually.
Yeah, so I don't have, which system are you talking about?
It's a burr-based system, so it's a CT-based system, QVIS.
Okay, sure. So this does not do that. I can tell you from experience after doing 2,000 Maco surgeries, I don't trust that CT scan for protecting me against soft tissues. The reason for that is you take a CT scan, now the burr system may be very different, I don't know. The CT, because you go through, you remove osteophytes, you're removing bone, by the time you're cutting on the tibia, if you try to trust that haptic boundary, the saw blade can come out posterior medially on the tibia and injure your medial soft tissues, and you can end up with instability. So in this system and in the striker system, I will leave a cuff of bone around the tibia about 1 to 2 millimeters when I break off the tibial fragment, and then I'll go back and I'll sublux the tibia forward and then remove that 1 to 2 millimeters of bone.
Okay.
Supposing you
Now,
start...
on the posterior medial and posterior lateral aspect of the femur, I don't worry about that too much because typically as soon as that fragment gets cut, you'll either see it move or you have good tactile sensation as the saw blade starts to come back into that area.
So it's like a standard thing what we use.
Yeah.
A standard saw, give way. What is normal we always do. So I think...
so there is no advantage in this system of stopping that.
Yeah, that's...
Sir,
yeah,
supposing you started with cruciate retaining, and in case if you want to convert into posterior stabilized by erasing the PCL, then you wanted to go back and plan, or automatically system will take into account of that conversion and you can proceed with the surgery? Do you want to go back and change the plan?
You certainly can change. So in this system, because the attune has different thicknesses posteriorly for the PS versus CR system, you do have to plan for it. So I would recommend, if I was a posterior stabilized surgeon, I would release the PCL before I did any soft tissue balancing, and then the computer will calculate the thickness of the posterior stabilized implant.
No, suppose in case, in between, if you want to change something like you wanted to release, without release you can't get the balance, and at that stage, do you want to go back and change your plans, or do you want to do something?
I do that. So for me, we just use an example of a severe varus knee that had an uncorrectable deformity. So in that case, I will release the PCL because it opens up the posterior medial flexion space. And so, but when I do that, I'm going to collect the soft tissue graft after the PCL is released.
So technically,
Now,
there is no deep dish in attune or anything like that. So you have to go back probably, and you can't put like a deep dish in the same system. Say here, I think with the DePuy, yeah.
If I was doing a case and I was tight, so this happens clinically. If I'm doing a robotic case and I'm just slightly tight in flexion, I'll either pie crust the PCL or take the PCL. In the attune system, the polyethylene is indicated for PCL resection because of the congruency of the poly. We could get into I don't know that we necessarily want to go down the road of knee implant systems, but the attuned knee, you can cut the PCL and still use a CR system.
Okay. One question there.
It's a saw-based system, as I've seen, the way you were performing. So in conventional, we have a slot to put the saw, as well as in some other robotic system, there are some haptic system to provide overcutting or going out of the bone. So here your robotic arm is quite sturdy, or you are holding it firmly with your hand, the saw?
It's actually because the robot's quite light, I can't remember the actual weight, but it's like 40 pounds. It's not a very sturdy arm. So the arm will rotate into the plane, and really I don't grasp the saw very hard. I'm just pulling the trigger and then allowing it to stay in that plane. Now I have to watch the tip of the saw blade, or know where the tip of the saw blade is. But so for example, the CT-based system that I've used in the past, it will actually not allow you to go to the periphery of the bone sometimes. So you have to go back and either take osteophytes off or cut additional bone with a handsaw. In this system, you can see the bone, and you can cut wherever you want, but it will hold you in plane.
So you have to hold it firmly.
No, I think what he's trying to say is it's a planar capture, but there's no boundaries.
Yeah, there's no boundary. It's a saw which guides you.
It's a planar capture.
You can just have a hold of the saw which will give you a cut and feel of the end point of the cut.
Okay.
So you're still it locks you in the plane, but it doesn't give you a boundary that you can't go out of.
There's no boundaries. It holds you in plane. If you try to move the saw out of plane, the power to the saw gets cut off.
Okay. So there's an inbuilt system of avoiding errors as such. Yeah, you can't go obliquely or anywhere around. Yeah, one more question.
And it's only the back of the saw that's in the plane. It can still skive, like splay. The tip of the blade can still splay and notch.
Actually, I have seen that the blade thickness is, I think, 3.2 millimeters or so, and it's quite rigid. It doesn't get any oscillations because the rest of the blades what we use. So that is a thicker blade in this system. So probably there is no, but in osteoporotic bones, what we face, sclerotic, I don't have any problem, but osteoporotic in our country, probably we'll have to check it on patients.
The saw blade can't skive much because as soon as it starts to skive, if the blade angles the saw and pushes on it, it'll cut power off.
So any deviation will cut off the saw from the system. So as simple as that.
Yeah, so in the Maco system and in this system, if you're dealing with sclerotic bone, I do about 50% of my knees uncemented. So if it is sclerotic bone, I will go back. So after I've made the initial cut, I will then go back and recut that same plane in both systems because it's not uncommon to see, a half a millimeter, a third of a millimeter of bone come off during the second cut in sclerotic bone. And when I'm doing uncemented knees, that's important.
One question. Do you do simultaneous bilateral knees in the same patients?
I no longer do that. I used to. I don't do it anymore.
Okay. Because is the system useful for those things in terms of turning around quickly to do the second side?
I think you could. I mean, there's going to be some time factor because the cord, you're going to have to. There's cords that run between the camera and the robot, so you would have to. Of course, you'd have to reverse the position of the camera and the robot.
Okay. And how fiddly is the system to attach to the table? Like how your OR staff finds it? Is it very easy to put it on the table and before surgery, and how it happens? Can you just explain a bit about those things?
Yes, the robot, so a standard OR table has a bed rail, and there's two holding arms that clamp down on the rail. It'll go through several sheets to get onto the bed rail, and the cart won't disengage the robot unless it's firmly attached.
In the PS system, will this system do the box cut, and what about the keel for the tibia?
It does not do the box cut, and it does not do the keel for the tibia.
During the conversation, it was told that in the attune, even if the PCL is removed, the insert for the CR will take care of it.
Yeah, so in the attune system, the polyethylene matches the femoral component because of the locking mechanism on the tibia. So if the polyethylene in this system matches the femoral component. So the congruency of the tibial polyethylene is higher than in most systems. So if you cut the PCL, there's enough congruency that, at least in the United States, it's FDA indicated to use that polyethylene even if you sacrifice the PCL.
So would it be right to say that over the years, if the PCL get compromised, the attuned CR will still be safe in such patients?
Correct.
Thank you.
In fact, if I have a tight flexion space posterior medial after I've made my cuts, I'll say this happens 5% of cases. I'll either pie crust or cut the PCL and still use the same insert. And I've been doing that for years with no complication.
So in your case, the ankle was stabilized with some pad. Is it mandatory to keep the ankle stable, or what was that in the covering the ankle?
So that's my technique. I use a leg positioner. I have for years. I only do arthroplasty now, but I used to do ACLs, and I've always used a leg positioner. I like it. I used to take care of a lot of obese patients. It just holds the leg steady, there's other surgeons that just put a bump on the table and still use the robot. It works fine, but you do have to have an assistant.
Thank you.
Any more questions on the floor? No. Thank you, Dr. Edmund. And one more talk.
My pleasure.
I think he'll talk about some more slides are there, isn't it, John?
Yeah, if you want. So I think we'll run through this. I'm about to hop on a plane back to Florida, but I think this might be okay to go through briefly if that's okay.
Yeah, that's okay. Please
Okay.
go ahead.
So this is, there's a lot of alternative alignment techniques that have been discussed over, I'll say, the past 5 to 10 years. I think with the introduction of robotics into knee arthroplasty, more and more of us are discussing a patient-specific alignment philosophy or kinematic alignment philosophy. And I think, we've all seen studies like the one on this slide where, we used to pat ourselves on the back because the 10-year revision rate was, 2%. But the reality is, just because the knees aren't being revised, not all of our patients are happy with their total knees. So in this study, at 1 year from knee replacement, 19% of these patients were unhappy. And the question is, why? Our total hip patients do very well. Why do the total knee patients lag behind? So as we've gone to some of these kinematic alignment ideas or patient-specific alignment, this is a study out of HSS looking at 200 varus knees, 100 of them cut with mechanical alignment, 100 of them cut with kinematic alignment. And what they saw is less pain and better functional outcomes at 1 year to 2 years with patients that were treated with kinematic alignment. Go ahead, next slide. And so my personal thought on this, and I'm not alone, some of our patients are born with constitutional varus. And I think there's been some studies that I think Ranawat helped define constitutional varus. And those patients, we used to cut the femur at 0, cut the tibia at 0, and do a big soft tissue release to get the leg out straight. And that may not be what's best for that patient. So some of our patients are valgus, some of them are varus. And I think it not only allows us to do fewer soft tissue releases, which hopefully results in less pain, but functionally they may do better. And so I was just going to briefly discuss my algorithm for patient-specific alignment, or what I do with robot, and this has kind of been a learning experience over the past 4 or 5 years. But I typically will divide a varus knee into flexible, not correctable. I do the same thing for valgus knees. And the two things that have to be taken into account if you're a femur first surgeon, which I am, are posterior osteophytes on the femur, and then genu recurvatum or hyperextension. But I think we're starting to get away from that x-ray you see in 2005 and more to the x-ray that you see in 2022. So a flexible varus knee, this is the patient that comes in, they've had a previous medial meniscectomy, the deformity is pretty easily correctable on the robot. Sometimes these patients will even be put in, it's very similar to that live surgery that we recorded. I didn't have to manipulate the components into varus on that patient, and the soft tissue's balanced just fine. So it's an easily correctable deformity, minimal changes to component position. In this case, you're mostly using the robot to balance the flexion extension space. A varus knee that's correctable, I would say this is probably 80 to 90% of varus knees that come through the operating room. So they have mild varus deformity. It's typically 4 to 10 degrees, and you can typically balance the soft tissues within 4 degrees of malalignment. So I'm talking about hip, knee, ankle alignment, so long leg alignment. So I will typically put 2 degrees of varus on the tibia, 2 degrees of varus on the femur, externally rotate the femoral component slightly to open up the posterior medial flexion space. And I would say 95% of the time, you can then cut that knee with this technique, not do any additional soft tissue releases, and be very satisfied with the balance of the knee at the end of the case. This is the example that we just discussed. Somebody asked from the audience. This is the non-correctable varus knee or more severe varus knee. And for me, I'm willing to go out of mechanical alignment by 4 degrees. I figure sometimes I'm going to be a little off, so it could be 5 or 6 degrees, but there's some good data from Mayo Clinic, Mark Pagnano and Matt Abdel that says the longevity of those implants still seems to be fine within these kind of slight deviations from 0 on the mechanical axis. And in this case, I'll leave the lateral side tensioned where I want it for the polyethylene that I'm interested in, and then I will release like we talked about the PCL and do a large medial release or a reduction of the medial plateau to get the medial side to open up to catch my lateral side. And valgus knee, very similar algorithm. You know, you have very flexible valgus knees that sometimes just have more posterior lateral wear. These are typically easy to correct. Yeah, you can leave them in relatively neutral alignment, just like the flexible varus knee. Again, this is probably the majority of valgus knees that come through the operating room. They're 4 to 10 degrees of valgus. And some people feel differently about this. I am fine cutting my tibia in a couple degrees of valgus and my femur in a couple degrees of valgus. If I'm going to cheat one direction or another, I typically will leave the tibia at 1 degree of valgus and then put 3 degrees of valgus on the femur. And then you do have to slightly internally rotate the femoral component to close down the posterior medial space, which, you know, some of us are trained that's a bad move for patellofemoral mechanics. I really haven't found it to be an issue as long as I'm only deviating within, say, 3 degrees of internal rotation in relation to the posterior condylar axis. And when I do that, I'll sometimes cheat my tibial component into slightly extra external rotation in relation to the tibial tubercle, just to make sure that the tracking of the patella is reasonable. And then there's the severely, you know, valgus knee that's not correctable. And again, I treat this just like I treat a varus knee. I get the polyethylene on the medial side where I want it, and then I'll do a soft tissue release to open up the lateral side to catch the medial side. So those 6 scenarios are, you know, 99% of the knees that we take care of. The one caveat, if you're a femur first surgeon, because you don't have access to the posterior aspect of the knee until after you've made the bone cuts, I look at the lateral x-ray and I'll look clinically at the knee during surgery. If there are posterior osteophytes in one compartment, I'll plan that knee 1 millimeter tighter in extension. If it's large osteophytes, I'll plan that 2 millimeters tighter in extension. Because once you remove those posterior osteophytes on the femur, the extension space in that compartment will open up. And it's never, I've learned this the hard way over the years. You don't want to have a sloppy extension space with a tight flexion space. That's a difficult problem to solve. I'd much rather be in a situation where I have to recut the distal femur. Recurvatum, so it's interesting, you know, I look at some of the knees that we do these days, and if I hook a patient up to the navigation software on a robot, not uncommonly you'll see 10 to 15 degrees of recurvatum. And you know, the cuts that you're taking off the distal, you know, I'll distalize the femoral component. We think we get about 3 degrees of correction per millimeter. I generally won't take somebody that has a recurvatum knee and correct them to 0. If they're 10 degrees, I might correct them to say 4, but I will distalize the femoral component a bit in order to clear up the recurvatum. The one thing that I've found, if you do that too much, you'll end up with mid-flexion tightness, which is an awkward feeling in the operating room. But some of these distal resections are on the order of just a few millimeters. The VELOS system is well adapted to this type of philosophy for patient-specific alignment. I mean, you can use it for any philosophy that you have, but the computer really helps you plan the position of the femoral and tibial components, multiple degrees of freedom. You can adjust for the patient's soft tissue envelope, and the robotic saw executes the plan very efficiently. So that's a quick rundown on my patient-specific alignment.
Thank you, Dr. Edmund. It was a really interesting talk, and everybody was engrossed in your presentation. So thank you very much, and again, sorry for the delay. You had to wait in the lounge for some time. I know you are traveling and your flight is there, so thank you very much.
Not a problem at all. I'll head to the airport right now. I'll be right on time. If there are any other questions, I'm happy to field them.
Okay. Any questions from the audience?
Usually in valgus knees, we give more external rotation. As Dr. John has said, he gives internal rotation for the femur, and to compensate, he gives some external rotation for the tibial component. Am I right, doctor?
Correct. So it's completely backwards to how I was trained. I was trained that in a really valgus knee, it's going to be a hypoplastic lateral femoral condyle, and you need to externally rotate in relation to the posterior condylar axis. The reality is, if you do that, you will end up with a very sloppy posterior medial flexion space. So if you start taking a lot of bone out of the posterior medial aspect of a valgus knee on the medial side, you can end up with a lot of instability. And it's interesting to watch this happen on the computer because you get that soft tissue data before you cut. But I also think, because the robot is calculating the rotation based on the posterior condylar axis, you do tend to internally rotate the femoral component somewhat because there's deficient posterior lateral side.
Yeah. How many times you have to go for the lateral retinacular release?
Over the years, I do a lateral release far less than 0.5%.
Thank you.
I don't like doing lateral releases at all. I used to resurface all my patellas. I'm a big fan of not releasing the lateral retinaculum. And I haven't, over the past 5 years, I can count on one hand the number of times I've done that. It's usually somebody that's got a chronically scarred, partially dislocated patella when I do it.
Thank you. Thank you.
I think that's very important, that as we start using the robotic systems, initially it was always claimed by the critics of robotics that it's just a bone cutting tool. But as you start doing kinematic or patient specific, what John is saying, you understand that we are releasing too much soft tissues, and you start getting surprised. Like even the case which I did today, we did not release anything. Just 2 degrees of component positioning changes the whole game. So you don't need to do a massive release. That has been a common surprising factor for me also.
What's the help Welless gives in tibial component rotation and in patellar resurfacing?
So you asked about tibial rotation?
And patellar resurfacing. What's the help that Welless gives as a robot?
It's not going to help you with tibial rotation. I think surgeons do that differently. I mean, the way I was trained and the way I still practice, I typically will put the anterior aspect of the tibia at the medial 1/3 of the tibial tubercle, and the back aims at the PCL insertion. And I have found that to be good for patellar tracking over the years, and I don't deviate from that much, other than what I just described if I'm internally rotating the femur, and I probably don't even need to do that, but it makes me nervous. I was trained to resurface all my patellas this year, and mostly because I started using the attuned prosthesis, I just started going to unresurfaced patellas.
Thank you.
I think the patellofemoral mechanics of this femoral component are quite good.
Thank you. I think that's all from us. Thank you so much, and thanks for spending time to us. Yeah.
All right, guys. Enjoy your conference. I really appreciate you having me. Thank you.
So friends, I think So friends, I think we'll end today's scientific sessions here. We were lagging behind in time due to a lot of discussions and interest shown by the audience. We saw a couple of surgeries which went very well. All the surgeons did their job perfectly well. Tomorrow, we'll try to accommodate one session which we have missed today. That is the interesting cases and some tricky cases which I was going to ask our panelists. So it will be done in the last session tomorrow. That is the free papers, because we have very few free papers. So during that time, half an hour we'll spend on interesting cases. So please join us. I also invite you all for the workshops which are being conducted by the industry partners. And later on, let's enjoy the evening in the Bangway. Thank you very much.
Dr. Vaidya and Dr. Mahajan.
Yes, sir. And you have a live case? No, it's a recorded one. Yeah, I cannot be here and there. No. Put it on your laptop. Mic